Hello, hello. This is day 2, and this is Shushruta Hall. So we have our chairperson, Dr. Deepti Chand. Is she around? And Dr. Piyush Kherade. Dr. Piyush is already there. By the time Deepti madam joins, madam is already there, yeah. So we have both the chairperson, and we have our esteemed honorable speaker, Dr. Sunil Ambulkar. Sunil is to be there, is seen. Sunil is there, and Pramod, I met him. So I welcome both the speakers, and the second session is going to be by Dr. Shailaja Kade, who is the Maharashtra RSS DI chair, all the way from Pune, which will be chaired by Shilpa Paranjape ma'am and Zakir Siddiqui. So both of them are there. I request my reporters to please start the session immediately. Yeah.
Good morning, everybody. Today's day is clear, and I think the session and the flights of all the lectures will be on time. So let us begin with the second day of Academia 2022. In this session, we'll be starting with, as told by Dr. Gupta sir, its first lecture is dialogue. It's done by obstructive sleep apnea. It's basically a duologue, and the dialogue is between Dr. Sunil Ambulkar sir and Dr. Pramod Gandhi, the eminent endocrinologist of Nagpur city. Before we start, rather than tightening your belt, I will say loosen your blade and be relaxed in the chairs, and we'll be going ahead with the first flight that will start by 9:32, and for this session, to carry out all the further activities, I call upon the chairperson, Dr. Deepti Chand ma'am. She is senior physician professor at GMC and eminent physician. And Dr. Piyush Kherade is a consulting physician from Nagpur city. Please ma'am, come here and occupy the seats. I request the chairperson to see that all the flights, they should start by the time and end by the time. And let us begin the journey of joy of knowledge, and let these all lectures take you to the different parts of the world. So let us begin the second day with this session. I hand over the session to the chairpersons.
Thank you. Good morning, everyone. Thank you, organizers, for giving the opportunity to board on this flight as a chairperson. And today, we are seeing the least explored part of this chronobiology, that is the sleep OSH, that is the obstructive sleep apnea, and its linkage with your diabetes and hypertension. For this, we request captains for today's flight, Dr. Pramod Gandhi sir and Dr. Sunil Ambulkar sir, to start this journey with their eminent talks. So Dr. Sunil Ambulkar is the eminent endocrinologist. He has done his MRCP and is a consultant at the Institute of Clinical Endocrinologist and Diabetic Care, and was the ex-associate professor and HOD of GMC and Super Specialty Hospital. And he has clinical experience of as a principal investigator in various phase 2 and phase 3 international and national trials. And the second captain for today's is Dr. Pramod Gandhi sir, who is the DM Endo and director at the Kingsway Hospital, secretary of Maha Endocrine Society and executive member. He was the past president of Diabetic Association of India and the regional faculty for various courses run by the PHFIs, and conducted more than 40 phase 2 and phase 3 trials.
Good morning. I thank the organizers for giving us this opportunity to chair the session. We have two stalwarts from the city, very prominent endocrinologists, very successful, to present this very interesting topic on obstructive sleep apnea, which is known as a silent killer, of which we are most of the time unaware, troubling our spouses and all. So with this, I present to you Dr. Sunil Ambulkar and Dr. Gandhi.
Morning. It's a pleasure to be here with appreciation of Dr. Sunil's enthusiasm and effort in carrying out this activity. Our topic is very interesting, and in the sense, Pramod has taken lion's share in preparing this topic. So all questions related with obstructive sleep apnea will go to him. Very important. If it is a metabolic aspect, then I will answer. Next slide. You know, diabetes is increasing. Diabetes is increasing. Obesity is increasing. Combination of diabetes and obesity is increasing. We will have huge number of diabetes in our country, and the challenge is phenomenal. In fact, 8 to 10% of our whole population is diabetic. So is the number. These are the risk factors: advancing age, gender, gestation, family, obesity, diabetes, physical inactivity, and dietary problems. Obstructive sleep apnea is an offshoot of diabetes. What is obstructive sleep apnea? Obstructive sleep apnea is apnea, cessation of inspiratory airflow for lasting 10 seconds. Hypopnea is reduction of inspiratory flow at least 30% for last seconds. Now this symptom, this obstruction sleep apnea, patient will complain of symptoms. The symptoms will be snoring, cessation of breathing, morning headache and drowsiness. These symptoms, this apnea should be accompanied by symptoms, then only the treatment is considered. Prevalence of obstructive sleep apnea is 3.5 to 19%. In fact, it is much more than what is quoted. It is more than this. Next slide. Obstructive.
There are common determinants of both obstructive sleep apnea as well as diabetes. We all know that obesity, advancing age, these are the common risk factors for both diabetes as well as obstructive sleep apnea. The risk of developing diabetes, it increases with the severity of the obstructive sleep apnea. Also, the prevalence of obstructive sleep apnea in patients with type 2 diabetes, even at lower BMI, is more than those patients who do not have diabetes. That means there is a positive bidirectional association between obstructive sleep apnea and type 2 diabetes. This in turn increases the risk of development of cardiovascular diseases or cardiovascular morbidity as well as mortality. We all know that in obese patient, during sleep, the upper airway is closed because of obesity. This leads to hypoxemia, hypercapnia, and which ultimately leads to arousal. This arousal opens the upper airways, and once patient gets adequate oxygenation, patient goes back to sleep. But when patient develops hypoxemia or hypercapnia, during that time, there is increased sympathetic overactivity, there is sleep fragmentation, and this leads to various comorbidities and symptoms associated with obstructive sleep apnea. We all know that these are the various symptoms of obstructive sleep apnea. Patient can have nocturnal symptoms like snoring, choking, hypopnea, apnea, night sweats, insomnia, erectile dysfunction, nocturia. These are the common symptoms. Excessive daytime sleepiness is one very important symptom which is associated with obstructive sleep apnea. Obesity, the other important risk factors which probably leads to obstructive sleep apnea is enlarged neck circumference because of obesity, crowded upper airways. So all these factors contributes to the sleep fragmentation which happens during the sleep, which happens in patients with obstructive sleep apnea. So how do we evaluate the obstructive sleep apnea? We know, as madam has rightly said, that 80% of the patients of obstructive sleep apnea in this society are undiagnosed till now. Can you imagine the huge problem which we are facing? And the diagnosis is very simple. There are various questionnaires. These are the various questionnaires which are available on net. You can download and fill these questionnaires. And simple questionnaires will give you the diagnosis of obstructive sleep apnea. On physical examination, patient will be obese. There will be some upper respiratory tract obstruction which is responsible for development of obstructive sleep apnea. And if at all you strongly suspect that patient has OSA, then probably this patient should be subjected for PSA. PS polysomnography is a expensive it's a time consuming test requiring trained technician, and then hence Home-based monitoring is required, is recommended in many patients who are symptomatic. Do not exclude the diagnosis of OSA based on one negative or one inconclusive PSG. Patient can still have OSA even if PSG is negative. You need to repeat it on many occasions. It is highly recommended that we should repeat these patients. And the AHI cutoffs are mild obstructive sleep apnea is defined as those patients who has 5 to 15 episodes per hour of either hypopnea or apnea. Moderate is 15 to 30 and severe is more than 30 episodes. In patients who has symptoms of OSA, even more than 5 episodes of apnea or hypopnea with disturbed sleep is suggestive of OSA. In an asymptomatic patient, we say that probably 15 episodes of apnea and hypopnea are needed. Obesity is predominant risk factor. It is said that 10% increase in the body weight has been correlated with 6-fold increase in the risk of development of obstructive sleep apnea, which is very huge. That means if you take otherwise, 10% weight reduction will reduce the risk of OSA significantly. And all of us know that the risk of diabetes associated with obesity. Now, OSA does play an independent role in the development of diabetes. Now, this is a very complex pathophysiological mechanism by which probably OSA leads to development of type 2 diabetes. To simplify it, I can tell you sleep fragmentation and intermittent hypoxemia leads to increased sympathetic activation, therefore increased catecholamine. Alterations in the HPA axis leads to increased cortisol secretion. Catecholamines and corticosteroids or cortisol, these are the hormones which probably increases the blood sugar level, which increases the insulin resistance level and worsens the glycemic control in a pre-existing diabetes mellitus. There is increased oxidative stress, activation of inflammatory pathways leading to increased interleukin 6 and TNF alpha, which are again the cytokines which leads to insulin resistance. And changes in the adipokine profile like increased leptin, decreased adiponectin, all these factors contribute to the development of insulin resistance, deterioration in the beta cell dysfunction, and ultimately leads to worsening of diabetes control in a pre-existing diabetes, or a patient who does not have diabetes can also lead to new onset diabetes in this patient. It is said that even in existing type 2 diabetes patients, the risk of diabetes or worsening of diabetes is increased. In Indian population with type 2 diabetes mellitus, even at lower BMI, they have higher risk of development of OSA. The prevalence, the presence and severity of untreated OSA is independently associated with poor glycemic control. This is in spite of adjusting the various confounding factors like age, sex, race, BMI, duration of diabetes, lipids, exercise, insulin sensitivity. In spite of all these, OSA is found to be independent risk factor for development of type 2 diabetes mellitus. Now, till now we discussed that OSA is responsible for development of diabetes. Now, OSA is not only responsible for worsening of diabetes or development of diabetes, but it is also responsible for development of other or worsening of other components of the metabolic syndrome as well. It is found that OSA is associated with increased risk of obesity, insulin resistance, hypertension, dyslipidemia, and ultimately it leads to increased risk of cardiovascular disease. The complications of diabetes are also increased in patients with OSA. The OSA is associated with increased risk of development of retinopathy, neuropathy, nephropathy, and one important factor which is responsible for development of cardiovascular disease is hypertension, mostly the drug-resistant hypertension and non-dipping form of hypertension during the night. This is one important risk factor for development of coronary artery disease. And the mechanism of development of various components of the metabolic syndrome is also practically same. There is increased sympathetic activation, oxidative stress, increased inflammatory cytokines, and this leads to various components of metabolic syndrome, which in turn leads to the increased risk of cardiovascular disease. There are other comorbidities which are also associated with obstructive sleep apnea, like cognitive impairment, depression, decreased quality of life, increased chances of vehicular accidents because of daytime somnolence, psychosocial dysfunction, erectile dysfunction. These are the components of other symptoms of OSA.
On clinical examination, it is the weight and the neck size. Male more than 17 inches and female more than 16 inches will suggest you a diagnosis of obstructive sleep apnea. Their facial features, retrognathia, micrognathia, will give a clue that the oropharynx is small, and because of the relaxation of muscles of soft tissues of palate, this oropharynx get closed during sleep, and that is how they develop apneas. The treatment is, of course, weight reduction. As Pramod has said, 10% reduction of weight will reduce obstructive sleep apnea by more than 6 times. But the gold standard treatment in this patient who are symptomatic for OSH, not that they only have apneas or hypopneas during the night time. They should have morning headache, drowsiness, they should have disturbed sleep, they should have hypertension. As it is correctly said, the second commonest cause of resistant hypertension after alcohol is obstructive sleep apnea. If these things are present, then CPAP is the most important modality of treatment, gold standard for this patient. Mandibular advancement devices or modafinil tablets are secondary and tertiary means of treating CPAP. CPAP gives wonderful results to the patient. They sleep throughout night. This is one of the trials which shows that how CPAP was very important. Treating OSA can improve insulin sensitivity, postprandial glucose, cardiac outcome. Arrhythmias are common. This patient can die of arrhythmias in the night. Hypertension is also gets corrected. So it's a bidirectional flow. Obesity, diabetes to obstructive apnea to diabetes and obesity.
So we say that CPAP is the gold standard, but then the effect of CPAP therapy on glycemic control and insulin resistance has shown mixed results in terms of glycemic control. There are other cardiovascular benefits which are definitely seen with CPAP therapy, but the effects are got altered. Anyway, these are the various studies which has clearly shown that some studies had shown that there is increase in the insulin sensitivity, improvement in the HbA1c. There are some studies which has shown that there is no change in the insulin sensitivity or glycemic control in these patients. Till now we spoke about the effect of OSA on diabetes. Now, what is the effect of diabetes on OSA? The prevalence of OSA in patients with type 2 diabetes has shown varying prevalence in various studies, but then there is significant increased risk of development of OSA in patients with diabetes, possibly because of increased weight in these patients as well. So there is a complex association of obesity, type 2 diabetes and sleep apnea. This is a complex association and it is interlinked, and it's a bidirectional association of type 2 diabetes and sleep apnea in these patients. It's seen that obesity is associated with increased sympathetic activity, oxidative stress, inflammatory cytokines, which leads to sleep apnea and increased risk of development of various counter-regulatory hormones like catecholamine, cortisol, which increases the risk of insulin resistance, type 2 diabetes, which in turn leads to development of obesity and further worsening of the sleep apnea in this patient. The high prevalence of obstructive sleep apnea in patients with type 2 diabetes suggests that there is some morbidity and mortality which is linked to diabetes, which may be attributable to the undiagnosed obstructive sleep apnea. And therefore, it is recommended that even in absence of clinical manifestations of obstructive sleep apnea, all obese patients with type 2 DM should be screened for obstructive sleep apnea. Now, these are the current recommendations. All those things are which we have discussed just now. Patients with pre-diabetes and diabetes, clinical screening should be done in these patients by risk factor assessment, physical examination. We should evaluate them for obesity, neck circumference, craniofacial abnormalities should be seen. And there are various structured questionnaires which also leads us to the diagnosis of OSA. And the final diagnosis is based on overnight clinic-based PSG or overnight home-based PSG monitoring, which leads to diagnosis of OSA. Treatment is lifestyle modification, CPAP, various oral appliances in those patients who has various structural abnormalities. Positional therapy does also help in patients with obstructive sleep apnea, and surgical therapy in those patients who has anatomical defects is recommended. Those patients who has obstructive sleep apnea, in these patients again we should evaluate them for diabetes. The diagnosis of diabetes we all know, and the management of diabetes in terms of weight reduction is very important in such patient, and therefore along with lifestyle modification, the weight losing drugs like metformin, SGLT2 inhibitors, GLP-1 analog, these are the drug of choice in such patient to reduce the further risk of obstructive sleep apnea in these patients. To summarize, we can say that possibility of obstructive sleep apnea should be considered in all individuals with type 2 diabetes who has metabolic syndrome. All individuals with type 2 diabetes should be assessed for the symptoms of OSA. Individuals with type 2 diabetes should be referred to a specialist for evaluation of OSA and its diagnosis and treatment. Management of OSA should focus mainly on weight loss. CPAP is currently the gold standard of therapy, and in patients with OSA, we must routinely screen these patients for presence or absence of hyperglycemia by doing GTT in these patients if they are not diabetic. Thank you. Thank you for your patient here.
We have finished in time. If you have any comments, questions, they are most welcome.
Thank you, Dr. Gandhi and Dr. Ambulkar.
It can be present in non-obese because of retrognathia or micrognathia. The structure of the oropharynx determines the incidence and prevalence of OSA. It's more common in obesity because the fat deposition is there in the parapharyngeal wall. Muscular relaxation is more in obese person, so they have more propensity to develop. But it's not that they will be only obese.
If there are any structural abnormality in the upper airways, probably that is responsible for development of OSA in this patient. And since our BMI is lower in Indian population, even at lower BMI, we do see, even in absence of structural abnormality, we do see that these patients do have OSA. Majority of it.
90%, more than 90%.
Yes, sir.
Obesity have GERD. GERD will reflexly lead to bronchial asthma because aspiration of content in the bronchial tree. So these are the offshoots of obesity. Osteoarthritis, obstructive sleep apnea, GERD, reactive airways disease. These are the complications of obesity.
We spoke just broad, we had given just broad overview of OSA and diabetes in 20 minutes.
Good morning, sir. Sir, just one question. Well, first of all, thank you for the wonderful deliberation. Sir, I have seen in my practice that these patients needs very high amount of basal insulin, sir. OSA with type 2 diabetic patients. So do you have any preference of any analog to choose in this kind of patients? And what recommendations has to say about it, sir?
There are no such recommendations about which insulin we should use in such patients. Our target is that we should achieve good fixed fasting first. That's our target, and that's why these patients needs higher insulin. But it is clearly shown that these patients have significant increase in the insulin resistance, and therefore whether it is OHA, whether it is insulin, their requirement goes very high.
Same experience.
So whether we use basal insulin or basal bolus, it's a individual choice. Probably we need to evaluate every patient individually and decide the doses of insulin. We can use any insulin.
Thank you, sir.
I have a point here. During rapid eye movement sleep, the body muscle tone goes down.
Yes.
The pharyngeal muscle
Yes.
tone is down. So when you take a deep inspiration, the intrathoracic pressure is negative. So in fact, that also pulls the pharyngeal muscle. And like sir said, that GERD leading to inflammation or smoking leading to inflammation of the upper passages also adds to the swelling of the fat which is already there. The two important factors which will contribute extra to the
Yes, that factor I have mentioned.
Smoking alcohol and sedatives. This should be avoided.
alcohol intake.
That part I have mentioned in one of the slides, but I did not discuss it here.
Yes.
But then even in patients with type 2 diabetes, long-standing diabetes, they do have autonomic neuropathy, and laxity of the
The
pharyngeal muscles also is one of the contributing factor for the development of OSA even in non-obese patients.
Yeah, well said.
Anything which narrows oropharynx, whether anatomically or whether obesity and fat and muscle relaxation, will lead to OSA. That is the pathophysiological mechanism of OSA.
Sir, especially in the case whenever the patient comes, he said कि due to nocturia, because he has to go to frequent urination at the night time, and some of the patients who are on antipsychotic drugs, should we alter that because it will also ultimately lead to the obese? So will it contribute to this?
There are many antipsychotic drugs which probably increases the weight, and that probably further worsens the OSA, insulin resistance, glycemic control. And once glycemic control is worsened, probably they will have frequent nocturia. So that is a well-known fact.
Some antipsychotic drugs can precipitate decay or hyperosmolar states. So you have to be choosy in selecting antipsychotic drug in diabetes.
I'll tell you one very interesting story. One of my patient, who is a mother of a well-known neurologist, not in India, who was on antipsychotic drugs, and her insulin requirement was more than 200 units per day. Then we realized that we are missing something somewhere. We stopped her that drug, we changed it to some other drug, and her insulin requirement has come down to 20 units. In between, she required 2 times hospitalization for hypoglycemia. So antipsychotic drugs can also cause significant insulin resistance. So that should be kept in mind.
Third generation antipsychotics, second generation antidepressant, duloxetine, certain drugs have more propensity to develop this problem.
One more thing I want.
Risperidone and olanzapine, these are the two common. Risperidone and olanzapine, these are the 2 common drugs which we have.
One more thing, apart from the gold standard, like we all know that CPAP is the gold standard, but some patients might, they have to wear that mask for whole night and they feel quite uncomfortable. I think a new therapy, that is the upper airway stimulation therapy, implanted device in research. So, sir, can you enlighten us on that?
It has just been reported, but then it is not very well studied in the various clinical trials. Therefore, it is not discussed today. But these are the upcoming therapies. Probably BiPAP therapy is also recommended in some patients who do not tolerate the CPAP. In some patients, BiPAPs. In some patients, some nasal devices are there, which are also tried, but not very well tested in the clinical trials, and we do not have sufficient data for those devices.
I agree with you. The devices which are used rather than a full face mask, we use the nasal pillows and all, which are relatively more comfortable.
Only nasal masks are more comfortable than full face mask.
Full face mask, because that
Because nasal
doesn't
masks has
have
come up
pressure
now.
on the nasal
That are
bridge.
getting more comfortable.
BiPAP, that's why BiPAP is also recommended in some patients.
Yeah. So
Neil and Pramod, wonderful lecture indeed. Very, very informative. Just one thing I wanted to ask you. Anybody who snores, is that an indication for doing PhDs?
Anybody?
Who snores in the night?
Yes, yes. Sir, the simplest investigation is pulse oximetry.
Okay.
Screening. You do screening of pulse oximetry. Ask your attendant to note the pulse rate and oxygen saturation. If it is a 4% drop in oxygen saturation throughout a night, you practically diagnosed OSA. Then you confirm by limited polysomnography, not huge complete. Pulse oximetry is the most important screening test.
Nowadays,
Pulse oximetry.
What is limited PhD?
nowadays
Limited,
home-based
there
polysomnography which is available, which can be done, and which is a basically screening tool. But negative home-based polysomnography study does not rule out OSA. So, but if it is positive, it gives you diagnosis. That's why if it is negative, then probably a clinic-based extensive polysomnography is needed. Sir.
Limited, I can tell you. Sir, I quit now.
Sir, can you use the mic, please?
It better that rhythmic snoring is there and rather than arrhythmic. I have read somewhere that spouse can be asked about the type of snoring.
Spouse is more trouble than the patient itself.
That is true,
This
but
is the disease.
if the snoring is
Spouse
rhythmic,
complains more than the patient.
very true. If it is rhythmic, it is supposed to be okay. If it is arrhythmic, it is supposed to be more.
If you are rhythmic, you are tuned to it and you sleep. If it is arrhythmic, you both will not sleep.
No, arrhythmic snoring indicates that there is frequent fragmentation of the sleep and which is a disturbed sleep. Rhythmic snoring is probably related to your inspiratory and expiratory disturbances. That's why arrhythmic snoring is worst.
In daytime, people who doze off in front of TV and
Daytime
all,
somnolence
doesn't
is very
feel so
important
fresh
symptom.
in the daytime.
Very important symptom.
Very important. So those are the clues which should be picked up.
Upward sleep apnea scoring. Watching TV, just sitting after the food, sitting by the car, then just talking to somebody. There is a upward sleep apnea scoring. If it is more than 10, then you must evaluate for obstructive sleep apnea. Daytime sleepiness. Limited sonography is pulse oximetry, chest movements, and nasal inspiration expiration. That is limited. Then you have EEG, then you have EMG, then you have many other things. That is complete polysomnography.
I think if there are no more questions, come to
Thank
the
you.
end of it.
Thank you, madam.
very much
Thank you.
for the excellent talk.
Thank you very much, sir. Please, speakers, please stay. Thank you very much for this superb talk on sleep apnea. In the beginning, we have started with sleep and you have awakened us. So thank you very much. I request the chairpersons to please felicitate our distinguished speakers. I request Dr. Madhusudan Sada sir to please felicitate our chairpersons. Extremely sorry. Dr. Manohar Sada, please felicitate our chairpersons. Thank you very much. Thank you very much, sir. And thank you very much, speakers and chairperson. So let us go to the next session. The next session is on postprandial hyperglycemia, a real concern. For this session, to chair this session, I call upon the chairpersons, Dr. Shilpa Paranspe ma'am. She is a general physician, consultant, and Dr. Zakir Siddiqui, he is a practicing diabetologist. So I invite this chairperson and request them to start the session.
Hello. A very good morning to one and all. It's an honor to chair for a lecture for on Dr. Mrs. Shailaja Kade ma'am. Dr. Shailaja Kade ma'am is a director of Orange Diabetes Medical Foundation and Research Center, Pune. She's a chairman, RSSDI Maharashtra chapter. Awards, Punya Parvati Bhushan, Dr. Anandibai Joshi Award, Times Health Icon Award 2017. Zee National Healthcare Award, September 2019, Maharashtra Times Health Icon Award, November 2019, felicitated at Trinity College, Dublin, at Tricentenary 300-year Diabetes Program, and research works, cardiovascular outcome trials with Dream Canvas, Devote, Sustain, etc. Co-author, Drugs for the Heart in Diabetes with Stephen Del Prato, and co-author for Oxford University press book titled Diabetes, Public Health Diabetes in Developing Countries. Over to you, ma'am.
Thank you so much. So, good morning to everyone, and congratulations to Dr. Sunil Gupta for such a effort put in for this Hello Diabetes Academia 2022. So, my job is in the next 15 minutes is to have some outline about postprandial hyperglycemia. I know we talk it a lot. Let's discuss few aspects and what should we do and why it is not good when the glucose goes up in the postprandial state. So we all struggle with lot many things, insulin, drugs, monitoring to have that control and to reach to that magic number of A1C of 6.5. And that struggle goes on in every follow-up visit when the patient is visiting us. So we know when we say glucose control, it's not fasting and postprandial only, but it has everything. It's not only HbA1c also, there is a variability. So every postprandial peaks in the day matters, and overall time in range in 24 hours matters to get to reach to that target of correct A1c. So as there is a obesity or in the IGT, the first thing what happens is the first phase insulin secretion within 2 minutes of food ingestion is lost in the early phases of IGT and then of course diabetes, which leads to the postprandial hyperglycemia, and that's the defect which is difficult to address with the drugs. Though we have lots of drugs, it is not good not only for as a glucose but also to the vascular tree. So we are targeting everything, fasting, postprandial, as I said, throughout the day, peaks, and also time in range to reach that A1C. The relation of post 1 hour glucose, or whatever glucose level comes after eating food, has a very strong correlation with the death. And this epidemiological evidence is true even in the normal ranges. There is enough evidence which says that postprandial glucose has a continuous linear relationship with cardiovascular death. And there are many, many epidemiological population-based studies, prospective studies, which are showing this again and again. We all have heard about Honolulu Heart Study, but what it showed actually in a population-based epidemiological survey, the 1 hour postprandial glucose is associated with a significant increase in cardiovascular mortality. And this relationship is true even in the normal ranges of glucose. So the postprandial glucose going up from 114 to 133, there is an increase in the risk. From 133, it's going to 156, there is an increase in the risk. So even in the normal ranges of postprandial glucose, there is an increase in the mortality, which is a very strong association seen again and again. We all have seen that IGT, there is a strong correlation, like before a patient developed frank diabetes. If you compare impaired fasting glucose compared to IGT, so the survival is poor with the when the 2 hour glucose goes up compared to when there is a fasting glucose impairment. And that again shows its relationship with the cardiovascular risk or the overall vascular mortality. There is a strong correlation which goes linear again whenever there is an increase in the postprandial glucose, even in the degree of hyperglycemia in the impaired glucose tolerance test. DECODE was actually trying to see the relation of fasting glucose and the postprandial glucose with the all-cause mortality. So when the postprandial glucose goes, say, from 140 to 200, whatever is the fasting glucose, we can see that all-cause mortality goes up. So something happening in the postprandial state along with the high glucose, which is increasing vascular risk. So this was epidemiological studies which has done population based, but even though we take type 2 diabetes, which we treat every day, there are some studies which actually have tried to find out whether postprandial glucose has a different cardiovascular risk. So diabetes intervention study, which was a follow-up of 11 years, which tried to find out the postprandial glucose relationship, and which showed that even compared to 144, when it is 180, more than 180, there is a 40% greater risk of myocardial infarction in these type 2 diabetic patients. San Luis study, again, what it showed that the 5 predictors were studied, postprandial glucose for cardiovascular events and mortality, a 14-year follow-up of type 2 diabetes patients. And what they studied, CVD events, mortality with 5 glucose parameters. So whether fasting is bad, post-breakfast, post-lunch, pre-dinner, and A1C. When 5 of these parameters considered together, major predictor of cardiovascular risk came out was postprandial glucose after lunch. So PPG lunch and A1C were the strongest predictor, and same importance was retained when both these parameters were put together. So not only epidemiological evidence, even in our known type 2 diabetes patients, if there is a high postprandial glucose, it is strongly correlated with myocardial infarction and cardiovascular mortality. So San Luis study. And so there are implications of 1 hour glucose also. So there is not still recommendations, but it is not good. Even 1 hour glucose rising, that is bad. So there is another big study which tried to search whether postprandial has a different, but all 3, fasting, postprandial, and A1C, show a linear relationship which increase cardiovascular risk in patients of type 2 diabetes. This is because whenever there is a hyperglycemia after the postprandial state, it's not only metabolic effects, but also there are vascular effects which produce stress on vascular wall, endothelial dysfunction, and atherosclerosis. So we just see 3 or 4 pathophysiological links which are studied very nicely in healthy subjects, which will again show us that how there is a increased whole vascular streets, there is own stiffness, there is an increased LV diastolic dysfunction whenever in the postprandial state glucose goes up, along with there is lot of inflammation, dyslipidemia, and endothelial dysfunction. And the repeated fluctuations are bad. So when the glucose goes up and goes down and again goes up, it is still bad because it is associated with high circulating inflammatory cytokines, more oxidative stress, and endothelial dysfunction. So in some healthy subjects, acute increase in blood glucose to 270 milligrams, which increases heart rate, blood pressure, and catecholamine levels. So there is a response from the vascular tree. In this small study, there were 52 subjects undergoing oral glucose tolerance tests. It is related, the 2-hour glucose was related to significant decrease in vasodilation, and it has a strong correlation. 20 healthy type 2 diabetes, healthy and type 2 diabetes patients were compared, and myocardial contrast echo showed perfusion defects in the postprandial state which are not seen in the fasting. So whenever the glucose is going up, there is something is happening which is increasing the atherosclerotic risk, which also is associated with increase in inflammatory markers. So this association of postprandial glucose, which we saw in the epidemiological studies, which increases cardiovascular mortality, as well as we know a lot of pathophysiological correlation even in healthy people and also in type 2 diabetes. So as I said, repeated fluctuations are still bad. So you need to look at the whole glucose range throughout the day, and we should avoid these peaks and fluctuations. Maria Taskinen, we all know from Finland, she has the major work about the lipids, and actually she first started lipids as a branch from Helsinki. All her study showed was postprandial hyperglycemia associated with high fasting glucose, more pre-meal glucose, more carbohydrate ingestion, and high glucose, hepatic glucose production. So therapies targeting overall postprandial state will be more beneficial rather than just looking at the glucose. What she and her group has shown that in the postprandial state, there is not only high glucose, but there is a postprandial lipemia. So VLDL, chylomicron, intermediate density lipoproteins, which are very atherogenic otherwise, become more atherogenic if there is a background hyperglycemia. And the first atherosclerotic streak which starts in the vessel wall actually gets pushed. There is a more kind of an inflammation and endothelial dysfunction. So postprandial state as a thing is bad. So therapies targeting postprandial, so like exercise, which improves the postprandial state overall, not only glucose, will improve this vascular risk which is associated with postprandial glucose. And both these have independent and additive effect on oxidative stress and vessel wall disease. the lipemia as well as the hyperglycemia. So as I said, postprandial state, high glucose, more abnormal atherogenic lipids associated with oxidative stress, hypercoagulability, and there is a decrease in fibrinolytic resistance. So these triglyceride-rich lipoproteins and LDL removal is reduced when there is a high glucose. So that's why if we reduce glucose, there will be improvement in some aspects of postprandial state, and that atherosclerosis will have some good effects to reduce that vessel wall disease. We all know that a contribution to the glycemic load, because I think now it's very well established, but this slide is shown that because initially all the recommendations were never that you should never treat postprandial. Look at the fasting and just try your therapies. But with the Asian patients, we know that contribution of postprandial glucose is much more even in the normal ranges or lower ranges of HbA1c. Not only at the higher, but even when the A1c is around 7. And I don't have a slide, but Dr. Yaznik's study from Pune Maternal Nutrition, even in the normal ranges of glucose, the contribution of postprandial glucose is is quite significant, which contributes to the A1c level. So which again tells that story of postprandial 1 hour or 2 hour glucose is quite important, and it is doing something to the vascular tree. We know that Indian food with high carbohydrate has an extremely high glycemic index as well as glycemic load, and has been also seen in this study published by Shashank and his group about the START study. So there is a still bigger challenge for all of us to target these postprandial peaks with such kind of food which we eat many times a day and remain in the postprandial state most of our 24 hours. So there are recommendations that the PP state is there is endothelial function which is negatively affected. The preprandial glucose as well as postprandial contribute to A1C. So target should be defined not only for fasting, time in range is also important, and all postprandial peaks needs to be taken care of. The major benefit comes by monitoring dietary carbohydrates, which we very well see in pregnancy. I think pregnancy is the best time to study the relationship of what we change in the food and how it affects the postprandial peaks, because patients are so much motivated. They keep good charts. You can do CGM, you can do hope monitoring, and it's a big learning for us rather than the patient about the food and the postprandial glucose relationship. Even breaking up prolonged sedentary time is actually improves these peaks, and there are very good studies done in Oxford which shows that if someone is sitting 9 to 5 and doing a job on the laptop, if their sitting time is broken by every 30 minutes, if they do 3 minutes exercise of standing up, just doing some movements, just for 3 minutes, every 30 minutes, experiment was done for 8 hours. And it was beautifully shown that in 24 hours, how postprandial peaks as well as inflammatory markers go down. So breaking the sedentary time is also very, very important to have overall decrease in the load of postprandial glucose. Coming back to drugs, I think all drugs reduce postprandial hyperglycemia, even basal insulins, because they reduce preprandial glucose and the peaks go down. So that is not separate. But if the fasting glucose is very well under control, and if we really want to reduce the postprandial hyperglycemic burden, we do have certain good drugs like non-sulfonylurea secretagogue as well as AGIs, alpha glucosidase inhibitor, which will take care of postprandial state as a whole, along with, of course, everything. GLP-1 based therapies have an advantage because they suppress glucagon. So there is a more kind of a good effect on the postprandial state. So we know that we need this right from day one, and we need our patients A1C to 6.5 without producing hypoglycemia, and we don't want weight gain. If we can achieve that, we are giving and keeping the patient there for all years. Actually, we are helping our patients to reduce the overall vascular risk. Sulfonylurea secretagogue stimulate a rapid but short-lived because of their rapid attachment and rapid detachment to the site, which is there on sulfonylurea receptor. And so it's a short-lived secretagogue property which usually do not produce severe hypoglycemia. So they act on SER1, but there is a separate kind of a binding site which is similar to sulfonylurea, but very small size. So molecular weight is very small. There is a rapid attachment and detachment. So there is a kind of enough insulin release, which is glucose dependent. So hypoglycemia risk is there, but it's a very good decrease and a robust insulin release, which takes care of postprandial glucose. I think we all are using these drugs for many years, and repaglinide definitely does a wonderful job. So it is glucose dependent. Insulin release is rapid and brief. It just takes care of those peaks. It can be taken with meals, and there is so that if patient is not having any food, one can drop that tablet that time. Reduced risk of long-lasting hypoglycemia, so the risk is much less. It improves the beta cell function because of decrease in the overall glycemic load on the beta cells, so glucotoxicity is reduced. So efficacy of repaglinide is much better than nataglinide, but both are working very good. This was the population-based study from the Danish registry, which has taught us a lot of things. It was trying to see the cardiovascular risk when compared to metformin with different drugs. And this Danish study says that all-cause mortality, cardiovascular mortality, if you compare with metformin in patients with previous MI or no previous MI, repaglinide and glyclazide were not different than the metformin. You can see here, this was glyclazide and this was repaglinide. Here again repaglinide and glyclazide. And here again repaglinide and glyclazide, which are touching the line 1. So compared to metformin, the risk is not different, which was for glyburide, which first time came, and even for glipizide, the risk was higher. So the population-based studies have their own limitations, but this was the study which was initially Danish and the UK, which started the debate about sulfonylurea. Coming to alpha-glucosidase inhibitor, we know voglibose, which prevents these excursion, wonderful drugs as a combination, and they do have some GLP-1 action, and they reduce the postprandial peaks because they retard the carbohydrate absorption. So the combination of these drugs, if we have in our portfolio, which will definitely improve a little bit the postprandial state as a whole, which I was mentioning, to reduce the burden on the vessel wall. So it is our job to introduce. So I think physical activity in the postprandial state is the first most important thing. And of course, these kind of a combination therapy, which non-sulfonylurea insulin secretagogues and combination of alpha-glucosidase inhibitor is one more addition in our prescriptions, which can help our patient to take care of this postprandial state. Thank you so much.
Thank you very much, madam, for completing such a vast topic in a short time. If there are any questions, please.
Madam, you have said that repaglinide is non-sulfonylurea.
Secretagogue.
We have learned that it is a non-sulfonylurea moiety of the sulfonylurea, which is also active.
Yeah, so it works on sulfonylurea receptor.
It is a sulfonylurea.
Its molecular weight is small, and there is a short attachment detachment.
I don't know. We were taught that sulfonylurea has two moieties. One of them is repaglinide.
So receptor.
One of them is repaglinide, and another one is the sulfonylurea moiety.
Which is with the big.
So how can it
molecule.
act on different receptor?
It is the same receptor. The binding site is slightly different with this repaglinide.
Your slide mentioned that it
Yeah,
acts on
slide
different.
mentioned that. I saw that.
Any more questions? Thank you, madam. What I feel is that first and foremost, that the effects of postprandial hyperglycemia, as we know, we should tell them to the patients also. Because many a times patients feel that, okay, I will control 1 time, 2 times, but then that should be persistent. Throughout their lifetime, they have to control their postprandial hyperglycemia, which is very important. So diet, patient education comes first, after that comes diet, then the postprandial exercises. And what we usually do, we take lipid profile fasting state. So we should also now start seeing lipid profile in the non-fasting state, in the postprandial state. Because whenever patients also, it has in their mind that we have to see lipid only in the fasting stage. So if we tell them you do fasting just now, they will say I'm not fasting. So we tell them that no, that's not, it's okay if you do it just now also. And then we show them the correlation. The patients are very knowledgeable nowadays. So if we explain to them properly, they will help us to control the postprandial hyperglycemia. Of course, we will be doing that with the drugs and all that. But the patient's participation is also most important in this.
Yes, madam. Food choices are absolutely important. And the first study done with continuous glucose monitoring in pre-diabetes patients to just change their choices of food, the real-time CGM. Even in practice, I think that is the most important thing the real-time CGM does. The patient's choices change automatically. And that you, whatever lectures you give will not happen unless they see that how much my glucose goes up with some kind of food, which like pohe and other breakfast. So then there is a change. So this is very true.
Most of our patients are basically having a defect in insulin secretion and insulin action, and most of them are having 3-meal pattern. So actually they are in postprandial phase for the whole day, and that's actually leading to increase hepatic glucose output, and which indirectly or directly leads to hepatic insulin resistance, decreased hepatic glucose uptake, and in muscle uptake, glucose uptake is also reduced. So hence, if we can modify the meal pattern, and can we add one meal replacement instead of giving a full meal, that directly or indirectly helps in treatment of insulin sensitization.
Definitely, it will. All the studies show that it has a good effect on the overall glycemic load in the day.
And one more thing I would like to add, that once diabetes develops, it is very difficult. If you develop it in the later stages, 40s and 50s, your food pattern and your eating patterns have developed so much that it is very difficult to change. So as individuals, as doctors, we should start advising that right from the childhood, that pattern should be there. In frequent snacking, that portion size, that should be restricted right from the childhood.
Yes.
Thank you very much, madam.
Thank you.
If there are no more questions, I think so we can start with the next session.
Thank you. Thank you very much, Dr. Shailaja Kale ma'am, for enlightening this real concern. And I request now Dr. Sarita Ugemuge ma'am, co-convener of HDA 22, to please felicitate our chairperson, Dr. Shilpa Paranjpe ma'am and Dr. Zakir Siddiqui sir. Thank you very much, everybody. Let us proceed to the next session. I invite Dr. Amit Saraf. Dr. Amit Saraf is a physician and DNB coordinator at Jupiter Hospital, Thane. So I invite Dr. Amit Saraf to navigate this next session as a moderator, and we'll be having two speakers in this session to have a ride. So I hand over mic to Dr. Amit Saraf, sir.
Thank you. Good morning, all. At the outset, would want to congratulate and the entire team of Hello Diabetes, Dr. Sunil Gupta, Madam Gupta, and the entire team for this amazing conference and a very unique concept of the airport and the terminals and the captain and the pilot taking us through this entire diabetes knowledge conundrum. It's a beautiful concept. It makes you reinvent, rethink, and it's a pleasure to be here this morning. Today morning, my job, and again, thanks to our partners who sponsored and powered this session, the Novo Nordisk. So with their help, we are here to talk about a unique session with two very experienced captains to take us through this entire morning session on insulin cockpit. So to initiate and kickstart the proceedings, I have the pleasure to invite Dr. Shaila Sheikh, our first speaker for the morning. And she's going to speak to us on achieving glycemic symmetry with newer basal insulin analogs. Dr. Shaila Sheikh is no stranger to these proceedings. She's a consultant endocrinologist at the Prince Ali Khan and Wockhardt Hospital in Mumbai, the principal investigator for the international clinical trials, almost 35 of them, member of the executive committee, past treasurer ESI Maharashtra, member of scientific committee CAD, awarded top docs in Mumbai by the Times of India Group from 2017 to 21, author of International Hajj and Diabetes Guidance and IDF DARC Guidelines in 2021, published many papers, review articles, and speaker at National and International Forum. Always a pleasure, Shaila, to introduce you and to hear to you. Over to you.
Good enough? Thanks. Thank you. I hope now everybody can hear me, right? Great. Okay. So first of all, a very, very good morning to each and every one of you. Coming in the morning on a Saturday morning at 10 a.m. I really appreciate it. A big thank you to Dr. Sunil Gupta for inviting me over here. So it's always a pleasure. And Nagpur is always a special place. Loads of friends, lovely hospitality. So I frankly love this place, Amit. Okay, having said that, today I have around 20 minutes left to talk about, I would say one of the very, very important areas of concern when we are managing our patients with diabetes. And why am I saying an important area of concern? I want to ask all of you all a question. How difficult do you find initiation of insulin in clinical practice? How difficult? I personally feel it is the most common cause of doctor shopping, at least I know in my city. I mean, the moment I say insulin, and I can make out from that body language of my patient sitting in front, my patient is going to think, okay, maybe I need to see the doc next door. And we have plenty of docs next door. So, do you face a similar situation? Right? So we are all on the common cock flight, at least if I am allowed to change my words that way. So we are all in a similar flight at this point of time where we do have difficulty. If I put it another way, how often do you initiate starting insulin? You have some reservations about insulin. You feel maybe this is really going to cause a lot of hypoglycemia. My patient is not going to be comfortable. It's cumbersome. It's going to be an issue starting insulin. I'm all the time worried about hypoglycemia. How often do we think about these situations when you are thinking that maybe this patient of mine actually needs insulin, but I am still a little hesitant. Maybe I can actually add that fifth OHA to my patient. How often does this thought come across in your mind? Does this happen? Okay, it never happens. Never happens. It happens to me, to be honest. There are times when I am wondering, because if I think that, okay, is this patient going to take a lot of time explaining? I've got a busy OPD out there. Is it going to be very simple to get this patient on insulin? Is my patient because of his hesitancy about insulin, is it going to be a little longer time? To be very, very honest, in clinical practice, a number of factors will decide how we are going to initiate insulin, which patient we are going to initiate insulin, and potentially how easy that job could become for us. The journey of insulin, we've been celebrating 100 years of insulin last year, and the journey of insulin has been absolutely fantastic. And this is one area of medicine. Small changes, incremental changes have helped us as clinicians move a long way from where we started. We started with, when you look at the insulins, we started from porcine, bovine insulins. We went to a lot of other insulins, intermediate way. And now we are actually at a point of time when we are talking about ultra long insulins, we're talking about second generation insulins. And mind you, in 6 months, we're going to be talking about definitely once a week insulin, which we are going to have clinically available to us, Icodec. So we are really having a fantastic journey. The 100 years, mind you, friends, have been very, very fruitful to us. These are my financial disclosures for the day. Very important with this new draft that I first talk about that. And then I go to this case study. This case study actually is a prototype of what you and me see in clinical practice. So I'm not going to go into the details of discussing the actual case, the numbers up here, but this is something which you see in practice a patient comes to you, a typical male patient who's around 45, 50 years of age, our ADA criteria has reduced to diagnosing our patients at a much younger age. I'm sure Dr. Tevaskar and everybody is going to come up with new criteria as far as India is concerned. We're most probably right. We'll reduce the criteria still further. So when you are looking at a patient of 45, this gentleman was diagnosed around 6 years back, but potentially looking at a gentleman who could be having diabetes even long before that. So young patient, but a patient who's not very compliant. Unfortunately, in diabetes, because it's a chronic disease, still your patient is not very symptomatic. Your patient tends to take this disease a little lightly. They feel that, okay, maybe ma'am is just exaggerating the entire issue of a microvascular complication. Maybe she's just, because today she's talking a lot more about the cardiovascular risk of diabetes, but because it's a long term and you're living with it day in and day out. Shailaja just spoke to you about walking after every meal, but practically we do a lot of it, but still we don't do a lot of it. So you are looking at this patient who is 6 years into diabetes. You are looking at this patient who is having an HbA1c of 8.8%, and you're looking at a patient with 3 risk factors: dyslipidemia, you're looking at a patient with hypertension, you're looking at a patient with microalbuminuria, mind you, you're looking at a patient with an EGFR of around 55 and a social alcohol intake. So you are potentially looking at a patient with all the complications which you expect with diabetes. If you look at the medical history of this patient, you are having a patient with metformin 2 grams. Patient is tolerating metformin 2 grams, glimepiride 2 milligrams twice a day. We know at half maximum dose, you will see the maximum efficacy of. I have to use both of these. Okay, that's really multitasking, and women are used to it. So you are looking at a patient with an MPA of 25. So basically looking at a patient who is busy, who's not doing very well, who is now beginning to get a little worried because the social media in the last 2 years is bombarding him with all kinds of information. And now he's convinced that, no, I need to take better care of my health. I'm somewhere missing the boat. I need to do something about this. So now he's got a panic consultation sitting in front of you. He's promising you the moon. He's telling you, ma'am, I'll do everything you tell me on earth, anything and everything, but I want my diabetes to be better. And we do see patients, who come to us in that panic mode saying, ma'am, nahi, abhi main sab sununga. Aap mujhe baithne bologe to baitunga, utne bologe to uthunga. So this patient now at this point of time is telling me, I will do whatever you want. Now, what do you do? What would you do in this patient? Would you add another OHA? Do you think with an 8.8, even if I add another OHA, for example, this patient was already on DPP-4 inhibitors, had not done very well, doesn't tolerate alpha glucosidase inhibitors, gets a lot of gaseous distension, glitter zones plus minus. So it is a question of, how do we really manage this patient? What do you think? What would you do? Don't tell me I've ruled out all the 3 OHAs out there. I can see the smiles. What do you think we should do? Would you think in terms of injectable? Would you think in terms of SEMA? What would you really think in terms of? Okay. Now, in this gentleman, if you think in terms of injectable therapy, I would like to reiterate, I would first think in terms of injectable GLP-1 receptor agonist or an oral GLP-1 receptor agonist, because we have huge amount of benefit with injectable GLP-1 receptor agonist. There's no questioning that. The downside, when in clinical practice, I try to initiate a GLP-1 receptor agonist, my patient, the first thing which gets a little worrisome for them is the cost. If you tell them that, okay, it's going to give you this additional benefit, the second question my patient asks me, madam, how long do I have to use it? If I tell them you have to potentially continue using it, I immediately get a yearly cost on my table. Madam, are you asking me to use this? This is the cost with your Android phones. I have a cost in a minute. Madam, this is, and I'm actually giving you practical clinical situations. Now, if I look at all this, then I think that maybe my patient, I can think more in terms of initiating insulin. And the biggest issues which I've always had with insulin, be it hypoglycemia, be it weight gain, I am not seeing with the newer insulin. So I am justified at this point of time to think in terms of initiating insulin. Now, this gentleman is a busy gentleman. The moment if I talk to him about any kind of insulin which is going to really restrict his lifestyle, I know he's not going to do it. And I, as a busy clinician, also have an issue of, not wanting to have a very long conversation at that point of time regarding or starting 2 or 3 shots of insulin if not required. So I personally, and for the best benefit of my patient, think the best way forward would be to initiate basal insulin. And why would I think in terms of basal insulin? I tell my patient, sir, I think you definitely need insulin. We are going to discuss that over the next few minutes. And the second question the patient asks me is, ma'am, how many times a day? How often would I have to need insulin? What kind of side effects is going to cause for me? And a very, very prompt answer is, you just need to take it when you go home. You don't need to worry too much about the time difference. You don't have to take it at any fixed time. You just have to take it in the evening hours whenever you're at home. If you're reaching home at 8 and you're sleeping at 12, take it between 8 to 12 in the night. And or if it's more convenient for you to take it in the morning, you can do it in the morning. So you are offering a patient a number of options in the way the patient can take insulin without significantly increasing the risk of hypoglycemia. Whenever you start any molecule, the issue always is going to be efficacy, safety. When you're looking at efficacy, you're going to look at HbA1c and glycemic variability, because we all know the fourth parameter, or I would say the fifth parameter that we are looking at now is glycemic variability. We're increasingly talking about time in range. Of course, it has to be simple and side effect profile. Efficacy and safety are two of the most important parameters that you would talk about when you look at any insulin. Efficacy wise, I think this house knows it. Efficacious insulin is the most efficacious molecule we have for the treatment of diabetes. So I'm not going to get into details about this. The issue always for us has been safety. The moment you say insulin, maybe because of our conventional uses of insulin, what worries us is always hypoglycemia. That has been the most important worrying factor. So what does data tell you, friends? Data tells you this was the begin data, this is the switch to data, this is the CVOT devote data, and this is real world evidence, the European Union treat to diabetes data, where IDEC was compared with Glargine U100. Glargine U100 is an insulin you and me use very, very comfortably. I think in the middle of the night, we give a prescription of Glargine U100 without worrying about it. But we all know that there can be certain issues associated with. So should we be moving to the next step? Should we be moving forward and thinking about what better you could offer your patient? If you look at this data, what you would realize is across the board over here, if you look at the begin data or the switch data, 28% overall reduction as far as hypoglycemia goes. What I find actually very, very interesting is if you compare these molecules, when you look at the nocturnal and the severe hypoglycemia rates, which we actually worry about, nocturnal hypoglycemia really worries you and me. That is where you see the most benefit when you compare these two molecules. When you compare Glargine 100 with your Degludec, and what this graph very, very categorically shows you, this is your hypoglycemia events per 100 patient years. This is your mean HbA1c, friends. And when you look at this graph, you realize when you're really targeting your lower HbA1c, this is an HbA1c from 5 to 6. When I come at around 6, you would realize that the incidence of hypo is much higher with Glargine U100. So when you're coming here, when you're targeting over here, and the graphs are separating over here, very, very vivid separation. So when you are targeting your patient at 7 or maybe lower, when you're individualizing targets, when you're seeing younger patients and you want lower targets, as you try to reach those targets, that limiting factor that you've always been worried about, hypoglycemia, starts to creep in. And that is where you need to be able to really help out your patient, because it is that difference which is going to decide whether your patient is going to continue with insulin, how comfortable your patient is with insulin, and how comfortable you are with insulin. Because even a single episode of hypoglycemia for the patient does become very, very difficult for you, because it has certain cost implications and it has a lot of psychological trauma which is created for the patient over there. When you look at the DEVOTE 6B study, this again shows, as we all know, that patients with severe hypoglycemia have a higher incidence of cardiovascular events. The DEVOTE 6B analysis very categorically showed that yes, hypoglycemia is associated with increased cardiovascular events. And over here, it was shown that when you compare degludec with glargine 100, yes, there was a lower risk of MACE events in this group vis-a-vis your glargine 100 group. The conclude study, these were patients, this was an RCT, these were patients with insulin, already on insulin. We all know the conclude study had certain issues with glucometers, and we all know that the conclude study actually brought to the forefront how important it was for us to monitor our glucometers. But what it did show very, very categorically that yes, when you look at the nocturnal and the severe hypoglycemic group, there is evidence that this group does better with degludec than it does with glargine. The confirmed study, again, this was a study which showed that insulin degludec 30% lower rates of hypoglycemia. That's significant. That is not something which you and me can ignore. And also a change in proportion of patients experiencing more than one episode of hypoglycemia was lower with degludec compared to glargine. So I think I spoke enough about hypoglycemia. I think we have enough evidence over there that yes, as far as that one parameter that you are worried about, definitely degludec has a certain advantage. When you're talking about glycemic variability, we are increasingly talking about time in range. At some point of time in the future, we all are going to be talking about our patients remaining at least 70% time in range, in a range between 70 to 180, which is again going to be individualized according to patients' requirements. But you and me are going to be talking about a combination of HbA1c and time in range as we move forward. So it is very important that we understand that yes, if we want our patients to be in range, we need to use molecules which reduce within day variability, which is very, very obvious over here when you compare it with glargine U100. We need molecules with within day variability reduction, comparison with U300, and again 4 times lower glycemic variability over here across both the charts over here, if you see, where you compare with either U100 or with 300. So definitely reduction as far as glycemic variability is concerned. And what does it translate into? What does it mean for you and me? For I am a clinician. What I am interested in, that when this I translate in the clinical world, what it tells me is there is a significant difference as far as time below and in range is concerned and time below range is concerned. There is a reduction as far as time below range is concerned. As we all know, time below range for me and you implies hypoglycemia. So when I try to translate this further in the clinical practice, what do I see? This is a type 1 diabetic patient, CGM based data, randomized to either glargine 300 or IDEG 100, morning time, and an endpoint at 12 weeks, CGM done before randomization and at the end of 12 weeks. And what did this data show us? This data, very, very interesting data, because I think this is one of the first CGM studies which actually compared both the molecules. And over here, you would see 44 minutes more patient spends in range. And you would wonder, ma'am, in 24 hours, how does 44 minutes really make a difference? I mean, why are you emphasizing on that 44 minutes? Because we all know that the amount of time that the patient spends above range, or the amount of time the patient spends, for example, below range, above range is going to contribute to your increase in HbA1c, is going to contribute to your microvascular complications, is going to contribute to your macrovascular complications. And we are all now talking about a continuum of diabetes care where every increase in your sugars does translate into some kind of complication in the long run. And with us seeing younger and younger patients, we need to be able to see to it that our patients stick to goals and are able to stick to goals as safely as possible. So that is what it means for me clinically, because this patient, if I add these two, almost 88 minutes benefit, because time above range is lesser and time in range is more, and that means my patient's HbA1c is going to be lower. Is this simple? Pretty simple to use. We all know this. I'm sure this audience also knows this. But what I would like to reiterate over here, you can use it in combination with everything. Start with 10 units, or when you're switching from other basal insulins, you reduce it by 20% if you're switching from a pre-mixed dose. I've already spoken about the flexibility. We all know about the flexibility, and that gives me actually the biggest advantage in clinical practice, because it gives my patient that feeling of, okay, it's okay if I'm on insulin. I am not dogged down by the insulin. It doesn't mean that I have to stick to a particular time when I'm taking insulin. And that translates into better adherence for my patient. My patient is able to stick to what the roadmap further has said. And mind you, when I'm not expecting problems, I am not absolutely hellbound on my patient monitoring every day. I may tell my patient, yes, you can monitor twice a week. You can adjust your doses depending on your fasting. This is your target which we want you to reach. And once you've set down targets, once you've had this conversation with your patient, once you've involved the patient, then that's when you can actually reach goal. So this is the summary of what we did. This patient did at the end of 3 months reach an HbA1c of 7.4, and the oral medications, glimepiride, was reduced. And at the end of 12 weeks, we have a much, much happier patient who promises to continue insulin. And at this point of time, I realized that it is not as cumbersome as it was thought to be. Thanks, Amit. That ding dong actually sounded like the way a flight, they say, put your seatbelt, put your seatbelt.
In fact, I would just say that Captain Shaila Sheikh has caused to land us without any turbulence. A very nice delivery. I think a big round of applause for Dr. Shaila Sheikh. A very nice presentation. We can take in a few questions at this point in time. I can see seniors, Dr. Vasan Kumar, Dr. Rakesh Sahai, Dr. Tivaskar.
They are not to ask me questions, so they are my seniors.
Yes, please. You can come to the mic in the front and.
Morning, ma'am.
Good morning.
Ma'am, in our experience, it is the, insulin delivery devices which makes us our job of initiating insulin much easier. And the cost, and it is available because free of cost from the pharma companies. That is why it is easier, ma'am. We don't have much to choose between DEG and U100 with of glargine, ma'am. What is your experience? Because when we initiate insulin, it is like that OHA failure, A1C rising about 9 and all. So we do not worry much about hypoglycemia in our routine clinical practice. When we start insulin, it is the affordability and availability of insulin pen delivery devices which makes the job easier, ma'am. That's what I feel.
I agree with you partly. I definitely agree with you that insulin delivery pens have made life much more easier for us. It becomes much more easier to initiate insulin. When you show that pen to the patient, that entire phobia of pins, the needles and the entire mental concept of, that injections and injecting the patient is sort of washed away. Totally on the same page as you. I totally agree. As far as hypoglycemia risk is concerned, all data shows that when you initiate insulin, even if your patient, for example, has an HbA1c of more than 9 and you're initiating insulin at that point of time, you still need to be careful. You still need to be careful when you're initiating insulin. And at that point of time, when you are making a choice, then you would take into account all these variables. You would take into account what kind of evidence the insulin molecule is giving you, whether you want to, what kind of evidence as far as hypoglycemia and weight gain the molecule is providing for you, what kind of cost your patient is going to be bearing for that kind of evidence. And then you as a clinician would make an informed decision as to what is best suited for the patient. But definitely at the time of initiation, there is an increased risk of hypoglycemia, even if the patient's HbA1c is 9. Because see, when you initiate insulin, often you also see situations where your patient suddenly may decide to become more dietary compliant also. Maybe has not been taking his medications very well, decides to start taking medications well also. So in the real world, there are a number of variables. So we cannot afford to underestimate the risk of hypoglycemia in any patient on insulin. So that we cannot negate.
Yeah, I agree with that. But what I have seen is that it needs high doses of insulin, ma'am, Digludac or U300, rather than comparing Lantus 100 units, ma'am.
No, on the contrary, you would You would require lower dose if you're using Degludec and Glargine 300 compared to U100. You would require lower dose. You would not require a higher dose. Definitely not a higher dose. These are second generation insulins. You would not require a higher dose. You would maybe require the same dose or maybe a slightly lower dose, but definitely not a higher dose.
Any question or?
Thank you, ma'am. And please have a seat here on the stage only. And sir, as the navigator, you can go ahead with the next speaker.
Right. So the next captain in this insulin cocktail is a very senior, experienced gentleman, Dr. Sanjeev Indulkar. We've all seen him over the years And sir is here to talk to us on a very, very important topic of the two-in-one solution for insulin initiation, the growing wall of real-world evidence from India. And sir is a practicing diabetes since 1988 in Aurangabad, ex-Maharashtra RSDI chairman from 2014-15, faculty for the PHFI course in 2009, ex-associate professor of medicine at the MGM College, PI for the Carolina and the Ramadan trial, and hosted the DFSI Con 2016, Maha RSDI 2009 as the chairperson. We welcome you, sir. Please give him a big round of applause.
Thank you, Amit, for navigating this wonderful journey. And I also thank my co-captain, Shaila, for initiating the topic in a very smooth, non-turbulent way. I would pick up the baton from her and would go ahead with a step ahead. In clinical management, we are always comfortable with basal insulins, but there are some situations where we have to have some limitations by using only basal insulin, and the issue regarding postprandial comes out, which is nicely discussed by my previous speaker during postprandial hyperglycemia and its importance. These are my financial disclosures. The important difference of using basal in Western world and in probably the Indian scenario comes here, because we have high carb diet, high postprandials resulting, and patients are on multiple oral antidiabetics till they are uncontrolled and need for a safety and convenience. So these four important parameters shows that beyond degludec, we want something else so that we can address postprandials, which is nicely discussed by previous speaker, and the importance of not only addressing fasting, but giving important significance to postprandial comes into picture. And in view of this, as Shaila has rightly discussed, that insulin prick, insulin injection, she has talked about just a single prick with a basal, but in our clinical situation, we do require additional preprandial insulin, and the number of prick goes up. And again, the situation becomes panicky that second injection we have to give to take care of either of the postprandials after breakfast, after lunch, or dinner. And in this situation, a wonderful molecule which is available with us, where insulin degludec is combined with insulin aspart, and this co-formulation, which we all are using since about 3 to 5 years, has made our journey turbulence free in the management of basal insulin taking care of fasting hyperglycemia, and this preprandial insulin, which is a co-formulation given as a single injection, looking at postprandial hyperglycemia. If you look at these two figures, the pharmacological properties make iodine gas a prudent choice for OD initiation, and if required, subsequent intensification. These two injections, which include a basal and a preprandial, would take care of almost 24-hour hyperglycemia. How this is doing in clinical, preclinical, RCTs and real world evidence? I think we all know these well, that these are phase 3A and these are phase 3B trials with detimir by 30, Iglar U100 versus basal insulin plus IAS with MILS and versus iodine gas. So there are n number of trials, RCTs. They have shown categorically that it works. And as we look ahead at the key factors that can influence the clinical practice decision for choosing a therapeutic option, we have evidence from SRMA, safety studies, phase 2, phase 3 RCTs, large outcome trials evidence, and from personal experiences. And very important, these two trials which have shown that evidence from real world evidence and clinical practice setting experiences. So we have RCTs, we have n number of trials, but I think our clinical experience, what our patients are getting benefited by using this, which is rightly discussed by my previous speaker, in a patient who required a basal insulin with a flexibility of time, and at the end of the therapy, he went to such a point that everything was comfortable. But as I said, there are situations where postprandials trouble us, which are very difficult to manage, keeps patients out of time in range, keeps patients HbA1c on a higher side, and there probably we have to think of this. What are real world evidence? These data are collected outside the controlled constraints of conventional randomized clinical trials to evaluate what is happening in normal clinical practice and ever increasing role in decisions that affect patients' access to therapy. We know RCTs are in an ideal situation and we want real world data in our clinics, how it is going to work. There are n number of real world evidences. We are going to discuss this one with Kalra, Kesavdev, and then another with Kesavdev, Chowdhury, and two important trials, Arise and SMART. We'll just look at them one by one. So this is the first trial with insulin degludec aspart, 1 year real world experience, where they have looked for almost 52 weeks, 48 patients were taken into the trial, and the results were in real world practice after 6 and 12 months, Iodine resulted in reduction in HbA1c and daily dose of insulin from baseline as shown here. A1c went down by 2% at 6 months, insulin went down by 5.42, HbA1c went down to 2.04, and the insulin totally went down by 1.76. So real world evidence confirms that this works, this is efficacious, and this is safe. A further study where they have shown that type 2 diabetes initiated on iodine and on regular follow-up were identified from EMR, and clinical outcomes and hypoglycemic events were captured. This is a retrospective data, and it has clearly shown that with mean iodine treatment of about 10.3 months, only 5 hypoglycemic episodes were reported. None were severe, and there were no reported episodes of nocturnal hypos. We were talking about hypoglycemias, and if you remember the days when we are using NPH, then the conventional premixed insulins, and now basal plus basal bolus and these co-formulations, the number of episodes of hypoglycemia in our clinics at home of the patients are going down, and especially severe nighttime hypos are almost not there. This is the second retrospective evaluation of the prescription pattern and clinical outcomes of iodine amongst patients with type 2 diabetes in a real world setting of Indian clinical practice. It has showed that significantly in all these cohorts, only OHA with insulin, with GLP-1 receptor agonist and other groups, significant improvement in clinical outcomes with negligible hypoglycemia and no weight gain was seen. The older insulins used to cause more hypos, more nocturnal hypos, and weight gain, which has been definitely overcome by this wonderful combination. As we go ahead and look at change in HbA1c and try to compare IGLAR U100, IGLAR U300, and IDGASP, IDGASP is statistically significant and causes a greater reduction in HbA1c as compared to IGLAR U100 and IGLAR U300, as it is shown here very well. So this is our second aim: no hypos, no weight gain, bring down HbA1c smoothly so that in clinic we achieve our targets, patients are comfortable, and the clinical outcome is satisfactory. Further, if you look at change in fasting plasma glucose, FPG is significantly reduced with IDGASP and IGLAR U100 compared to U300, while significantly better PPG reduction is seen with IDGASP compared to IGLAR U100 and U300. So if you compare U300 glargine, U100 glargine, and IDGASP, probably the targets achieved are better, superior, and persistent. Another study where insulin initiation in OAD failure patients with type 2 diabetes was done, and they looked for significant increase in insulin dose with Iglar U100 arm, non-significant increase with Iglar U100 and iodic asp arm, and no significant hypoglycemia occur between all the three groups. There was a question that whether the insulin requirement goes up. Probably this trial answers this, that with this second generation insulin, there is no increase in insulin dose over a period of time. Now coming down to real world evidence with prospective follow-up for iodic asp. We have talked of couple of patients, couple of cases and few trials, and they have clearly shown that iodic asp in Indian scenario is superior, better to address both fasting and postprandial rise, which is very commonly seen. A trial, a multicenter prospective non-interventional study investigating the clinical effectiveness of iodic asp in people with type 2 diabetes in real world showed that about 1100 adults were enrolled, and this was the study information, and these were the key inclusion criteria. The results were, this is global drop in A1C about 1.4%. This is the Indian cohort of about 185 patients. It showed 1.6 A1C drop, which is more as compared to global data. If you look at fasting plasma glucose, the global drop was 49. The Indian drop was 52. This is again better in Indian subgroup. And if you look at switch with iodic asp in patients who are uncontrolled with basal insulin by prior treatment group, this was the change in A1C. And if you initiate with iodic asp in patients with uncontrolled with OAD, this was the change in A1C. Both are around 2%. And if you look ahead with number of hypoglycemic events, initially non-severe hypoglycemic episodes were reduced from 364 to 162, and in Indian cohort from 47 to 8. And if you look at severe hypoglycemia, they are significantly lower, and probably this speaks the beauty of this wonderful molecule, wonderful co-formulation when we talk of hypoglycemias. The other study, which was study of management of diabetes with Rhizodec treatment, showed these were the study information and these are the inclusion criteria. The results were very good. Where insulin treated patients, we had a drop of A1C of about 1.8% and OAD by about 1.7%, and the effective control of A1C drop was what, about 1.8%. So this is the second real world trial showing 1.8% drop of A1C. If you look at FPG, the drop was about 50.4, and over a period of 12 weeks, it went down like this. If you look at post-breakfast, it has 82.5 milligram drop and it went down like this. But the post-lunches were still better, about 74. So it brought down post-lunch, post-breakfast, both, as it was having a part of a fast-acting insulin. And the reduction of number of hypoglycemic episodes confirmed non-severe right from first visit, second, third, and fourth visit. It went down drastically. If you look at severe hypos, they were 24, and subsequent visit, there were no severe hypos. And this point was discussed by previous speaker, that hypo, whether nocturnal or daytime, is a very important limiting factor for therapy, and it plays an important role from physician side and patient for the continuation of the treatment in further course of the disease. So we have this wonderful co-formulation with us. It is well to use plain basal insulin in most of our patients who are on OAD and failing to reach the targets. A situation sometimes is different in Indian scenario where postprandials are more important, and in that situation, probably these are some interesting patients where we can use iodic asp. First group would be patients failing to achieve glycemic control despite optimizing non-insulin therapies. We have number of patients reluctant to take more pricks. So a single prick, which gives us both a basal insulin, Degludec, and a fast-acting aspart, which addresses postprandials also. Patients with postprandial glucose spikes, where this works very well. Patients at increased risk of hypo, including nocturnal hypoglycemia. Patients who may benefit from a reduced injection burden or a less complex regimen. Patients requiring flexibility of the timing, and a very important group in our clinics, perioperative patients. Most of us manage them with a surgeons and try to control pre and intra-op hyperglycemia. But when this patient goes home, again he has to take insulin for couple of weeks depending on the duration of surgery, postoperative expectations of the patient. In this situation, a single co-formulation like this, where we can address a 24-hour control with a good fasting by basal insulin and appropriately time of this co-formulation before a major meal, will probably take care of postprandial hyperglycemia. Single prick, normalization of fasting blood sugar, mostly postprandial, will give a good postoperative outcome, healing, and probably the patient, surgeon, and a metabolic consultant would be happy. So this wonderful co-formulation, I think one has to use in our clinical practice, and the position which we have discussed is probably right. So summarizing, real world evidence is important because it often provides a more comprehensive understanding of how a therapeutic option works in the real world rather than via standard RCTs alone. This is a real world picture. The real world evidence of iodine gas complements the data from RCT and establishing its effectiveness and safety. Iodine gas is a simple and convenient solution which offers total control of postprandial and fasting plasma glucose, suitable for insulin initiation and for intensification. Thank you very much for patient hearing.
Thank you, sir. That was a very lucid, a very crisp, concise, and a good presentation. We invite questions at this time, please. So please come to the mic.
There are two ways we can use Degludec and aspart. One is you start simultaneously or increase the Degludec. And when it is not controlled, then you add aspart. What we have seen is when you add the aspart, the pre-dinner blood sugar is still high. In that situation, do you have to give it twice a day aspart?
Yeah, this is a very common practical problem in our clinics. And when we were using premixed insulin twice a day, to certain extent, we were definitely able to manage this. As you rightly said, all our meals contain lot of carbohydrates. So there are situations where a single iodine gas may not be able to manage all the postprandials. And in this situation, as you rightly pointed out, that we may have to give this iodine gas co-formulation before breakfast and before dinner, so that some of these patients will have all postprandials and fasting normal.
I have been through a situation where we had to give aspart at breakfast, at lunch, and at dinner, because every time our calorie intake is quite high.
Yeah, I think there the strategy would be different. We can use Degludec single injection, and all the 3 meals you can use preprandial insulin of your choice. And this is a very common situation which we see in our OPD.
Thank you. I think on the behalf of the Hello Diabetes Academia, I thank both these esteemed speakers, Dr. Shaila Sheikh and Dr. Indurkar, for a phenomenal talk. Requesting everybody for a big round of applause to both of them, and handing it back to the organizer for the next session, please. Thank you.
Thank you very much, dear all speakers and our navigator. Thank you very much for giving us this joyful ride of insulin, your insulin. So I request please stay there on the stage. And I request Dr. S.N. Deshmukh sir to please felicitate our navigator as well as our speakers with this token of love. Please. Thank you very much, everybody. And request all the delegates, now they can use the safety door which is behind you and can exit. And you can join us at the inauguration at the hall next to it, that is Hippocrates Terminal. Till the time you can have your comfort, you can be comfortable and can have tea in the meanwhile. And we'll be starting the inauguration within 10-15 minutes. Thank you very much. Thanks a lot.
Yes, so a very good afternoon. After having a long inaugural ceremony, so now let us start immediately for the next session because we are running short of time. So for the next gliptin plus gliflozin cockpit, I invite the chairpersons, Dr. Vinod Khandait, a renowned cardiologist from Nagpur, to join as a chairperson, and along with Dr. Ashish Dengra sir, whether sir has reached. Yes, sir, please join. Dr. Ashish Denga, sir, has he come to the hall? Okay. So he will be joining with you, sir. Now I hand over mic to Chairperson Dr. Vinod Khandait, sir.
Thank you, Allied Diabetes, for this opportunity. I think it's already too much late. We are running 1 hour behind schedule. But since it's a conference on diabetes, and every second 1% dies of diabetes, India is the leading capital of the world, and most of the mortality is because of cardiovascular events. And I think there are many new molecules which are having a beneficial effect in terms of reducing CV events. May I request the captain, Dakshata Padde, to straight away take off the flight and tell us something about this combination therapy on vidagliptin dapagliflozin. Please.
So good afternoon, everyone. Hi, Ashish. Dr. Ashish Dengra has come. So sir, I
Thank you,
request
Vinod,
sir to
sir.
please join.
It's a pleasure to share dais with you, sir. So we were just in the inauguration ceremony for more than an hour. And we just experienced when there is a presence of power couple, what can happen? A magic can happen. So same way, me and few of my friends, we call this combination of vildagliptin and dapagliflozin a power couple. And we just witnessed what can happen with the power couple. So let's see. I'm going to use few quotes during my presentation. So few of the slides, initial few slides, everybody has gone through this. But for power couple, it's never a different issue altogether. Your battle is my battle, and we fight it together. That's the agenda a power couple has. So this combination also has accepted that this battle is our battle, and together they are going to fight 6 out of 8 sides of ominous octet, so that the victory will be easier. So this is diabetes burden. Everybody knows the figures, 90 million in Southeast Asia. This is the huge burden we have to, this is the battle we have to win together. IDF 2021 10th edition numbers are going to explode to 124 million by the year 2045. These are few distinctive features whenever we are treating diabetic patients. It's not just fasting, post-lunch and HbA1c, but we are going to look at few features so that we are managing that diabetes and prevent comorbidities. So genetic predisposition, definitely very important. Low protein, low fiber diet and high carb diet. When it comes to environmental factors, then despite low BMI, we have high visceral fat and early beta cell defects. So these are the two things we need to address to whenever we are treating our patients with type 2 diabetes. High incidence of prevalence, CVD, 8% of type 2 diabetic patients already at diagnosis have peripheral vascular disease, and then low awareness, undiagnosed, unavailability of trained staff or helpers. So we have a huge burden to fight with. This slide also, I'm going to skip diabetes, hypertension, inflammatory cascade, genetic factors, everything playing together, leading to pleiotropic side effects, and cardiovascular disease is exaggerated in type 2 diabetic patients. So once again, just to repeat, it is not just glycemia which is important when we are treating diabetic patients. We need to look at adiposity, visceral adiposity. Never think of obesity as per, the whole picture. Is the central obesity and visceral obesity we need to look into. Cardiometabolic risk, metabolic and other vascular factors. Please do not forget to evaluate peripheral vascular disease in any type 2 diabetic patient with any number of duration of diabetes. Tolerability. Whenever we are initiating any oral hypoglycemic agent, there are only two concerns with respect to side effects, hypoglycemia and weight gain. And we have now 14 years of vildagliptin and almost 8 years of SGLT2. These, both the drugs have proved that there is no hypoglycemia and no weight gain as such when given only on the background therapy of metformin. And definitely adherence is very important. Initiation is important, but adherence and compliance is also very important. So these are the few factors we need to look into whenever we are treating people with diabetes. I'm going to skip this slide. Same thing, hypoglycemia, weight gain needs to be addressed, and at the same time, the drug has to be cardiac safe or maybe cardiac superior. These are the two factors we need to look into. So whenever two people are coming together, they want to get married, I'm just going to quickly go through the biodata. First is vildagliptin, probably groom. It is a DCGI approved DPP4 inhibitor, 14 years since approval, weight neutral, and it is affordable. Now we know that vildagliptin is affordable to any person with diabetes. Mechanism of action, I'm going to skip these slides. Basically, it is glucose-dependent insulin secretion, so there is no hypoglycemia, and it decreases glucagon secretion. So hepatic glucose output is suppressed, and eventually hyperglycemia is taken care of. In pharmacodynamics, obviously, it increases glucose sensitivity by reducing glucotoxicity. It improves insulin and glucagon ratio, and it improves pro-insulin and insulin ratio as well. So this is basically systemic review and meta-analysis of 69 studies of vildagliptin. We have gone through the data of more than 28,000 patients, and it has reduced HbA1c significantly without causing hypoglycemia and weight gain. There is no significant incidence of pancreatitis, and it is effective, safe, and it is a very good option, particularly as an add-on to metformin or maybe as a monotherapy when metformin is not tolerable. Cardiovascular safety, not many trials, but this VIVID trial, subject size was around 254. Objective was to basically see the safety with respect to patients with heart failure. HbA1c difference was quite significant compared to placebo, and there was no worsening of heart failure, so it is cardio superior. Now this is European multi-database non-interventional post-authorization safety study in which basically there was no increased risk of adverse CV events, and including risk of CHF, vildagliptin versus other OADs were compared, and there was no increased risk of any cardiac event. Now coming to dapagliflozin, it is again a DCGI approved SGLT2 inhibitor, multiple pleiotropic benefits. So in extra glycemic effect, where it scores is multiple pleiotropic benefit, it is cardioprotective, renoprotective, and I would add that it is hepatoprotective as well. And it is affordable. Mechanism of action, I'm going to skip these slides. Neurohormonal effect, the cardioprotective effect, renoprotective effect, we have already gone through this multiple times, and we have another 10 sessions on dapagliflozin in detail in next 2 hours time. So I'm going to basically speak about the combination. So these are landmark studies. Whenever we want to reconfirm our belief in any molecule, we need studies, we need evidences. Declare to me 58, DAPA-HF, DAPA-CKD, and Deliver. These are the trials which has reconfirmed our belief in this molecule. So Rajiv is here. Dr. Kovil has labeled this combination of vildagliptin plus SGLT2 inhibitor, basically gliptin plus SGLT2 inhibitor as a class of 2 effects as a power couple. This was the first lecture we presented in his lecture, and he had given that title. So they never have the same character. Whenever we are looking at any power couple, they don't have the same character, but they have the best understanding of their differences, which is very important. So when you are combining 2 drugs, literally speaking, when you are looking at this from marital biodata point of view, you need to have these characters when you are combining 2 drugs. Now, looking at ADA guidelines, standard of care has always advised that you have that stepwise escalation or stepwise addition therapy. But now, if your A1C is about above the range of 1.5 or 2% above the target, initial therapy has to be a combination therapy and sensible combination therapy. Don't wait for combining each and every, adding each and every drug. Don't waste those every 3 months looking at HbA1c. Maybe we will wait for 3 months and let's look at next HbA1c. You have to be proactive. So incorporation of high efficacy, high glycemic efficacy therapies is the main thing. And basically these therapies should have some additional beneficial cardiovascular and renal risk reduction. ADA has advocated that you have to start this combination or individual therapy in cardiac and renal patient, but I would go one step ahead and say that every patient who has probably undiagnosed CVD or undiagnosed CKD, so keep it in mind and be aggressive in starting this therapy, this combination therapy as initial therapy, probably on the background of metformin or without metformin. And as we know that there is hardly any risk of hypoglycemia and weight gain. Now, what is the expert opinion? Appropriate use of SGLT2 and DPP for FDC based on glycemic factors. So first is lifestyle and modification. This is how the patient comes in our cabin and how we should be thinking. These are the expert guidelines to optimize your clinical approach. So treatment naive patients where metformin is contraindicated, A1C is above 8, straight away you can start this combination. In treatment naive patient is already on background metformin therapy, and if A1C is above 9, you can straight away start this combination therapy. And uncontrolled patient on metformin and A1C is more than 8.5, still you can start this combination. So I would say be proactive. If A1C is above 8, don't wait for next 3 months or next 6 months for consecutive A1C to come down. Overcome your clinical inertia and be aggressive in starting this combination therapy. So this power couple is a true example of teamwork. In team, what do? We divide the task. Everybody has some assigned duty and then they multiply the success. So let's see how this combination is dividing the work and getting successful day by day. So SGLT2 and DPP4, they act on kidneys, pancreas, intestine. As I mentioned that 6 out of 8 sites of ominous octet are taken care by this combination therapy. And one more thing I would like to mention that glucagon goes up with SGLT2 therapy, which is not actually expected, which is not actually beneficial. But with DPP4, glucagon comes down. So that gets balanced. So they have differences, but they are balancing each other's problem. Same way, so it is preferable to use combination therapies having complementary mechanism of action, target different pathways. addressing multiple pathophysiological abnormalities of type 2 diabetes. So we just mentioned this, except probably at the intestine level, incretin effect and brain neurotransmitter defect, all other sites are taken care by this combination therapy. So muscle level, pancreatic level, and with respect to insulin and glucagon, they have dual effect. And rest of the sites are taken care by monotherapy of individual agent. So this power couple is unstoppable. You know why? Whenever one partner feels down, the other quickly resumes the role of lifting up the other partner, which is so important in any couple's relationship. But in power couple, it actually happens like this and instills new dose of optimism. So together, they reduce glycemic variability. We all know that now. We all talk in terms of TIR. So TIR is maximum. Of course, there is mostly meal-dependent insulin action, or SGLT2 is pancreatic independent. So hypoglycemia is less. Whenever for any glycemic variability, basic factor is hypoglycemia. So if hypoglycemia is less, glycemic variability is going to be less, and patient is going to be in TIR, that is in time in range, for the maximum time of the day. So this is one factor, which I just mentioned, that one factor is feeling down. When patients feel down with genitourinary infection with SGLT2, probably when you combine with DPP4, genitourinary infections are less, and the reason is interaction of DPP4 and SGLT2 proteins at the renal tubular cell membrane level, or the inhibition of the DPP4 enzyme present in pathogenic microbes. Simple. Fungal, the patients on SGLT2, they get mycotic infection. So on the walls of fungal wall, there are DPP4 receptors. So whenever you are introducing DPP4 inhibitors, the infection with SGLT2, the fungal infection with SGLT2, the rates go down. And this is a meta-analysis of many studies, and they have proven that alone SGLT2 and combination of SGLT2 and DPP4, genitourinary infections are less with combination therapy. So finally, power couple is two people who are pretty impressive. We just saw Dr. Sunil Gupta and Dr. Kavita Gupta, what a power couple can make a difference in the field of science and education. So they are pretty impressive separately, but together they can, they are true force to create special kind of magic. And what is the magic with this combination therapy? Sir, I just mentioned that the power couple, Sunil Gupta sir, Rajiv has labeled this combination of SGLT2 plus DPP4 inhibitors as a power couple, and we just witnessed that what a power couple can do in the field of science and academics. So I'm happy to present this power couple presentation today. So finally, power couple is two people who are pretty impressive separately, but together they are true force to create special kind of magic. And this power couple of SGLT2, vildagliptin and dapagliflozin, is safe, rapid, and they have sustained glycemic control. They have complementary modes of action targets 6 out of 8 out of ominous octet. They improve both insulin resistance and beta cell function. They help reduce body weight and blood pressure and many other pleiotropic benefits. Reduces pill burden, so adherence and compliance, which is very important in any treatment of people with diabetes. So adherence and compliance is better, and overall cost effective. With that, I would end my presentation, sir. Thank you so much.
Hello. Thanks a lot, Dakshata, for a wonderful presentation of power couple, Jay and Viru killing the gabbar of hyperglycemia. Rajiv, for you, the new word for power couple. So, any questions from the audience?
Indeed, it was a powerful presentation on the power couple. The power couple are my good friends. In fact, he is my batchmate. Sunil is here, and he presented a wonderful inaugural ceremony. Congratulations, Sunil, for this wonderful conference. As far as this molecule goes, I think this should be the first line of therapy in all diabetics, type 2 diabetes. Considering the mortality is in diabetes is because of atherosclerotic events. So, and recently, for the information of the audience, that SGLT2 inhibitors have been upgraded as class 2A indication in treatment of heart failure. So I think it's a wonderful combination of drugs. Thank you for clearing the mechanism of less UTIs with this combination. I was wondering how it must be prevented. And this DELIVER trial, the results will be out soon in August. They're yet to come actually. And that is something, the molecule will work in heart failure with preserved ejection fraction also. Earlier studies like DAFA, HF, and TIMI, that 58 trial that you showed, were in patients with reduced ejection fraction. So I think it's a wonderful panacea that we are going to have. Thank you so much for your wonderful presentation.
Thank you so much for sharing this, sir. And
Thank you. Any questions from the audience? So as Dakshata has told that if the A1C is above 8.5 or 9, you require combination therapy from first day because you have the target of reduction of 1.5%. So you have to act early to prevent future complication. This was the main message, that power couple should be used early, which we are using very late. Thank you. Thanks a lot.
thank you. Thank you,
Over
sir,
to the
Sunil
organizers.
Gupta, sir, and Kavita ma'am for making me part of this. More power to you, sir. Thank you.
Yes, thank you. Madam, please be there. I request our chairpersons, Dr. Dengra sir and Dr. Vinod Khandai sir, to kindly felicitate Dr. Dakshata Padhe madam. And I invite Dr. Sunil Gupta sir to kindly felicitate our chairpersons, Dr. Vinod Khandai sir. And Dr. Ashish Dengra sir. Yes, so now moving ahead, I call upon the chairperson for the next session of Dr. Rakesh Sahai, Dr. V.Y. Bansod sir. Sir is a senior consulting physician from Nagpur and ex-head of the department medicine, Government Medical College Nagpur. Sir, please join. And second chairperson for this session is Dr. Prashant Patil. He is a senior consulting physician from Nagpur. So here I hand over the mic to the chairperson and I request them to kindly proceed with the session.
Hello. Good afternoon. We are presenting Dr. Rakesh Sahai, who is an eminent diabetologist, and he is presenting his talk on achieving hemoglobin A1C is a new reality with vildagliptin and dapagliflozin. We know the incidence of diabetes is increasing. The mortality associated with diabetes is also increasing. And one of the important indicator for management of diabetes is HbA1c. If HbA1c is properly controlled, the various complications associated with diabetes mellitus can be minimized. Previously, we had 2 or 3 drugs initially, that was the insulin and pygonoids and sulfonylureas. And it has got, although these are the trusted drugs, but these drugs is associated with some of its own complications. So, since 1990, we have got a few drugs which are new in nature, and this drug is having lot of effectivity, and the dapagliflozin and vildagliptin has got some or other type of protective effect as far the cardiac mortality is concerned. So these are the, although new drugs, but these drugs will require, we are not very acquainted with these particular drugs. So the speaker will describe the various utility of this particular drug with the perspectives of its effect in maintaining the HbA1c. With this, I will request Dr. Rakesh Sai to present his talk.
So good afternoon to all of you, and at the outset I would like to thank the chairpersons for introducing me and also introducing the topic. The chairperson has given a very good introduction to the topic, and I would also like to thank Dr. Sunil Gupta and the power couple, as Dr. Dakshata has just said, the power couple of Nagpur for inviting me to this important conference. And she has actually, and I would like to thank Dr. Dakshata also, because we are going on a similar flight. We are going to the same destination. We are with a different crew in the cockpit, I would say. We have different chairpersons and a different speaker who is taking you to the same destination which you have already been to. So maybe you may see some other things on the way. You may see a few points of difference on the way, but essentially the destination is the same. What Dr. Dakshata has just given a very good presentation about how this power couple combination, as she has labeled it, she has very aptly said that the combination of SGLT2 inhibitor vildagliptin is a very appropriate combination in managing diabetes and how they complement with each other. So maybe I'll just add a few points here and there, but I'll essentially probably go a little fast because we are behind time, and also everything has been covered in the previous presentation by Dr. Dakshata. So what I would like to highlight is that, I'll just go through these aspects. Some of these aspects I may just highlight on a few points here and there, but mostly I'll go through, most of the presentation is going to be essentially similar to what Dr. Dakshata has highlighted. So we know that diabetes is a progressive disease and there is need for more and more therapies. Essentially the point is that diabetes is a progressive disease where there is a continuous decline in beta cell function, because of which something which works today may not work tomorrow, and we may need to add more therapies. And that is something which has to be kept in mind, that we need to be more aggressive in terms of managing diabetes effectively. And the reason why we need to do that is that we see that there are a lot of challenges. We have a lot of complications of diabetes. We were just speaking in the inauguration that we need to look at the situation of diabetes is not very good in our country, as was highlighted by Dr. Shashank Joshi. Highlighted what the idea for saying that every year there are about 6.8 million people today dying because of diabetes. So we need to prevent the complications of diabetes, and for that we need to see that we are able to achieve the target HbA1c. And if you are able to do that with confidence, as we are saying, that using a combination like this, a power couple combination, you can probably get to the target very effectively. And the challenges, as are listed here, are that we tend to have a unique phenotype where we have greater degree of insulin resistance, higher central adiposity because of the increased fat deposition in the central compartment, and a very rapid progression of pre-diabetes to diabetes. And similarly in the diabetes also, people have a rapid decline in the beta cell function. So unless we act fast and keep them under control, there is a more rapid decline in beta cell function. So even the degree of glycemic control you achieve is going to have an impact on the decline. If you're able to achieve a good glycemic control, then probably you're protecting the sort of slowing down the slope of decline in beta cell function. So that is why we need to be looking at this. And just to put things in perspective, we are seeing that in India, we are seeing that there is a average HbA1c is quite high across the country. You can see that the average HbA1cs are not less than around 8.5 across different parts of the country. This was seen in different surveys. And it's one important point here is that for every 1% increase in HbA1c, we said we have seen what are the benefits from the UKPDS and all that with 1% decline in HbA1c. With 1% increase in HbA1c, if you look at the increase in CV events, you can see that the events increase quite significantly, particularly if you're looking at major adverse cardiovascular events, 54% increase with every 1%, and that's for new events. That is, people who don't have a cardiovascular event. We are thinking that these people are safe. They are the ones who have a 54% increase, and those who already had a cardiovascular event, 89% increase. So that is the extent of problem that is happening if you're not keeping the glucose levels under control. And when you bring it down by 1%, you know this is well known from the UKPDS that you bring down the rates of microvascular complications and macrovascular disease significantly, and deaths by almost 21% if you are able to bring down the HbA1c by 1%. And what we see is that as I have shown in the previous slide also, more than 75% of patients are not under control. We need to act fast. We need to do that rapidly. We don't have to wait go in the traditional where we start with one drug, add another drug only after 1 or 2 years, and then add another drug, and that actually leads to a lot of inertia and a lot of damage. So we have now moved towards starting early, starting a combination early, looking at the HbA1c and deciding whether a person needs a single drug or more than one drug. And if you think that the person needs more than one drug, because we know that on the average reduction in HbA1c by any molecule is not more than 1%. So 0.1, 0.5 to 8%, 0.8% with these drugs, with metformin maybe 1 to 1.5%. If you have a HbA1c which is high, start with molecules that can bring it down appropriately, and see that the person gets a better control, and see that he does not he gets the benefit. But the challenges, there are some challenges that are there. As she said, that you need to, when you're trying to do this rapidly, you have a risk of hypoglycemia. So that was very obvious when we're using sulfonylureas as a mainstay of our management of diabetes, and we know that hypoglycemia has a lot of causes a lot of damage, not only to the individual but also to the entire society in terms of the cost of therapy go up, hospitalization is required, and all these things happen with hypoglycemia. So using medications and the fact that we have so many other things to manage along with diabetes. So these are the two challenges when you're looking at managing effective management of diabetes, and also the fact that there is multiple mechanisms are playing a role. So you need to have more than one molecule that can address each of these mechanisms. And those are other factors like low adiponectin levels, and the typical Indian phenotype where we said there's excess fat deposition around the abdominal cavity, there is around the viscera, and then there is a lot of early onset of diabetes, genetic factors which are predisposing to diabetes. And so how are these being addressed by the two agents that we are looking at? So we said that if you look at DPP-4 inhibitors, what are the benefits they have? They increase the adiponectin levels. Apart from the glycemic control they provide, they also increase the adiponectin levels. They improve the insulin resistance to some extent. They suppress the DPP-4 activity and thereby lead to improvement in the action of GLP-1, which has got many benefits. So these are the advantages of DPP-4 inhibitors. If you look at SGLT2 inhibitors and look at the same parameters, you see that they also have an effect of increasing the adiponectin levels. They also have a favorable effect on several adipocytokines, that is like adiponectin, leptin, and all this. So through all these mechanisms, they are providing effects beyond glycemic control. The glycemic control is certainly there with both these molecules, but beyond that also you have the additional benefits that have already been enumerated. And so what the guidelines say, as Dr. Dakshita has very, very aptly pointed out, that guidelines have changed over the last few years. You can say that if you look at the ACE guideline, what we are saying is that we are again looking at using therapies other than metformin even at onset of diabetes. And particularly there is the fact that has been recognized is that when there is a compelling indication, somebody has got a cardiovascular disease or renal disease, do not always think of metformin as the first therapy. Think of other agents. Think of using a DPP-4 inhibitor, a SGLT2 inhibitor or a GLP-1 analog when you have a compelling indication to use any of these agents. And then if you're looking at additional glycemic benefits, then you add metformin, you add DPP-4 inhibitors. If you still do not get under control, then you add a third agent like a SU. If you want to go with insulin, then you can go with insulin. So this is the algorithm that you need to follow. And also the very, very important fact here is that at onset itself, you look at the entry level of HbA1c, whether it's 7.5 to 8 to 9%, or whether it's more than 9%, or whether it is less than 7.5%. So based on that, you can decide on what should be the initial therapy. And if you look at this heat map, as you call it, heat map of various drugs, you can see that probably the coolest ones are these two agents, the SGLT2 inhibitors and the DPP-4 inhibitors. As you can see, DPP-4 inhibitors are blue throughout and only yellow for, say, maybe the heart failure and cardiovascular disease. You need to be a little cautious there. Whereas with the SGLT2 inhibitors, you have blue everywhere, green also some places. Green is the best, means that they have additional advantage. And the yellow part is only for patients who are in a catabolic state, like who can go into decay, or those who have got a genital mycotic infections, or when they have very low EGFR when you're thinking of starting this molecule. So that is how you see that these two agents stand out as good agents, and they take care of many of the unmet needs that are there. They don't cause hypoglycemia, they don't cause weight gain, they provide beyond glycemic benefits, they provide cardiovascular and renal benefits. So these are the things that you're looking at when you're choosing medications, and if you look at the combination therapy, as Dr. Dakshita has very rightly pointed out, they tackle most of these abnormalities that are there. Maybe 6 out of the 8 abnormalities are tackled already by the DPP-4 inhibitors. The SGLT2 inhibitor acts on the increased glucose resorption. So almost all of them, except for the neurotransmitter dysfunction, are tackled by a combination of these two molecules. So, and the unique synergism, she used this same slide where she showed that, the increase in glucagon which happens because of the SGLT2 inhibitor is tackled by the DPP-4 inhibitor. That's why they are becoming a very complementary couple, which are able to sort of take care of each other's deficiencies and cash in on each other's advantages to provide the synergism. And that's what we have seen, the potential synergism which is there with both these molecules. I will not go into details of this slide because she has shown this these benefits, where we are saying that apart from the glycemic benefits, you have the non-glycemic benefits or the extra glycemic benefits which are there on the cardiac and renal benefits. And she has shown a good paper which looked at the recommendation regarding this molecule. I'll show you another study which has looked at a meta-analysis of all the studies that have been done with this combination. This meta-analysis had 7 studies and 2,082 patients. And across all these studies, we found that this combination led to better glycemic control, greater weight reduction without increasing the risk of hypoglycemia. And she has already shown the benefit in terms of reducing the urinary tract infections that occur only with the use of SGLT2 inhibitors. The combination probably has a little favorable effect on reducing the number of urinary tract infections, and precisely this data she has shown on the reduction in urinary tract infections, and she has already highlighted the fact that it is probably because of the fact that it reduces the DPP-4 inhibitor, reduces the DPP-4 activity in the microbiome or in the bacteria which cause the infection. And the other other reason could be that there is a greater reduction in HbA1c. There is a 1.5% reduction in HbA1c as against 0.7, 0.6% by only the SGLT2 inhibitor. So that greater reduction may also lead to lower risk of infections. So both these mechanisms could be contributing towards the lower risk of infections. And this has been shown that they have also analyzed whether you use simultaneously or one after another. If you use simultaneously, probably you have better lower risk of hypoglycemia also. So just like we said that the lower risk of urinary infections, lower risk of hypoglycemia also is, the reduction in risk of hypoglycemia is better when you use them together at the same time rather than when you use in sequence one after another. And so I think those are the points that I wanted to highlight. And we see that we have a good reduction in HbA1c to the tune of 1.5%. So if you have any patient who has got, whether or not he has got cardiovascular disease, if he has got a HbA1c which is say beyond 8.5, and you want to bring it down to 7 or less than 7, then you need to use this combination. This combination is a perfect combination in those situations, irrespective of what he's already on. If he's already on metformin, add this molecule. If he's not on metformin, then you can consider metformin also, unless he has a compelling indication for cardiovascular renal disease. If he does not have that, you can start with metformin, add this molecule, or you can, if he's already on metformin, add this molecule. And if he has cardiovascular renal disease, he or she has cardiovascular renal disease, then this is a compelling indication. There you use it even without metformin. So if you find a patient who has got a HbA1c of 8% and you want to use start medication, then you can start with this medication, wait for metformin to be added later on, start with this medication. This could be a good choice. So it's very suitable for Indian patients because of all the factors that we have spoken of. It helps in reducing the pill burden, particularly reducing the pill burden, and overall the cost effectiveness of this molecule is clearly brought out by all these studies. And you can see that they work very well, whether they are added on to either other oral anti-diabetic medications or added on to insulin also. Those who are on insulin also, this helps in reducing the dose of insulin, reducing the rates of hypoglycemia, and providing a smoother control, providing a better time in range, as she has shown us data on the time in range. And so this this combination has significant benefits and significant safety aspects, which make them makes this combination very unique, and it has these benefits beyond glycemic control. As we have seen, the chairperson in the previous session also spoke about the benefits in heart failure with reduced ejection fraction and also with preserved ejection fraction. That is some data which is coming out with dapagliflozin. It has already come out with empagliflozin. So it's clear that, we expect that this data is going to be very good in terms of both the types of heart failure. And we already have data on CKD and cardiovascular disease. So what I would conclude by saying is that, using this combination, you can be very confident of achieving HbA1c of less than 7% with a smooth journey. I mean, you could say that the ride is the flight to achieve glycemic control with this combination is going to be very smooth, with low risk of hypoglycemia and without weight gain. And it's fit for all patients with typical phenotypic, Indian phenotypic features. Combination offers synergy in glycemic control in patients with uncontrolled diabetes. Along with the glycemic control, they provide better cardiorenal outcomes. Combination provides potential reduction in incidence of genital infections and hypoglycemia risk, along with significant weight loss. And there is also a potential to delay disease progression. This is something which has not been proven with the combination, but it has been proven independently. That is, the glycemic benefit that is provided, it provides a reduction, improvement in the disease progression, or reduces the rate of disease progression. And we also have the cardiorenal benefits with the DAPA itself. But it's been shown in people where it's added on in people who have already pre-existing cardiovascular renal disease. But in a new, say in a newly diagnosed patient, or in a relatively small duration of diabetes, the benefit is certainly expected, but it will be shown over a period of time. And I think with that I will conclude, and I'll be happy to answer any questions.
Thank you, Dr. Sai. People have been scaring us that India is becoming the diabetic capital of the world, and the burden of disease is increasing. I would like to say that instead of considering it as a burden, we should consider it as an opportunity to serve and earn also. In most of the guests are from the nearby states, and most of us are from the different parts of the country, and everyone must be worrying about or knowing about the political crisis which is going on in Maharashtra, and it is difficult to know which combination would be giving us a stable government. But here Dr. Sai has convinced us that this combination will help us to give the stable HbA1c level of less than 6.5. If there are any questions, please.
Next exposition, this side.
Yeah. So the best part is the cost is nowadays come down because both of them have become generic. Somebody was yesterday saying that it's a cheap combination. I would not like to use that term because it denigrates the qualities of the combination. I would say it's a cost-effective medication.
In type 2 diabetes, the long-term treatment is there.
Yes, yes. So it is cost-effective. Both have become generic. That's the beauty of that. That dapagliflozin and vildagliptin both have become generic. That is, their patent is out. They are out of patent. So that's why they are available at a very economical price. Many companies are getting this molecule, and that same is going to happen with another combination that is going to come very soon. In the next month, you'll hear about sitagliptin and dapagliflozin. Sitagliptin has almost similar benefits as vildagliptin. In fact, all the factors that we have spoken about actually hold good for that also. So this combination, either of these two combinations is going to be very good, and it is going to be low cost. It is low cost, and it is going to be in the long run useful because these molecules have to be used over a long period of time. Yeah, you were saying so.
Yeah, sir. Nice points. Would you choose amongst gliptins. Another flagship gliptin is going to be off patent very soon, and I think people are knocking your door too.
Yeah.
Or secondly, with Vilda, is this a caveat you have NAFLD or a fatty liver disease or alcoholic, and you're throwing aminoacids beyond 3 times, and where vildagliptin has a red flag where you have to be monitoring? Vilda is specific. So
Yeah.
choosing among gliptins, as you are marrying it as Dakshita said, a
Yeah.
good power couple, but then
Yeah, yes.
amongst which?
No, I get your point. What you are asking is that now we are going to soon have sitagliptin also, and you have a combination of sita and DAPA. How good is this as compared to that? So sita DAPA has also equally good evidence, I would say, and Vilda is I would say no inferior in the sense that we have been using it. We have the long sort of experience of using it. When it was introduced in the market, when Vilda was introduced way back in 2007, there was a concern about whether it causes rise in serum, the SGOT and SGPT, and whether we should be cautious. There was a caveat there that we should be cautious.
That has been put to rest.
Yeah,
right?
that has been put to rest. So
Yeah.
that's what I'm saying. That has been put to rest, and we have a lot of data on even non-alcoholic fatty liver disease, which has not progressed to the stage where it is very high, where it's a chronic liver disease. There with raised enzymes, then either of them cannot be used. But when it is not gone to that stage, when it is just a mild rise in transaminases, either of them can be used comfortably.
As a cardiologist, I prefer somebody's symptomatic heart failure.
Yeah, so I would ask you the question, as a cardiologist, what is the difference you see between Vilda and Sita? So that is something which you can
there's a
tell
study,
us.
vivid study, probably you also quoted, and John Muckmurray, the Paradigm HF investigator, I worked with him a brief stint. He has full faith, and I also full faith in vildagliptin. If you have a symptomatic heart failure and multimorbidity, and a very symptomatic patient, a diabetic, Vilda over any other gliptin in that situation, a specific gliptin to be chosen. Other of a glycemic efficacy and overall CV neutrality and what other pleiotropic effects, I think any of these gliptins.
So I think you have very pinpointedly told us exactly the situation where you will choose between these two molecules. Rest of the situations, both are equal.
Thanks.
So this is not a question. One practical advice I want: whenever a patient comes to us, newly diagnosed patient, A1C around 9 probably, and we start on the background of metformin as recommended, this combination therapy. And this is a robust, glycemic lowering combination. So probably in 2 months' time or 3 months' time, A1C comes down, fasting post-lunch, absolutely normal. Now patient is also in a hurry to, stop one agent or one tablet. So do we continue this triple drug combination for long time, considering pleiotropic benefits and everything? Or do we knock off SGLT2 or Vilda from the combination?
Yeah, I think that's the challenge that we have to face. I mean, in the sense that is our responsibility there, to make the patient realize that what he's using is absolutely essential and it is going to be beneficial to him. So I think that is our responsibility there to make the patient understand that this is very important, and the day he reduces one of them, it's going to go up again. So
Okay.
it is our responsibility to make him, the way you do it, it's your choice how you make him understand.
But we continue the
But we
triple
have to
drug
convince
combination.
him that he has to use this combination. If he needs to see the long-term benefits, it's going to be required. This combination, this triple drug is required, and he has to use that.
Thank you so much.
Unless if is very significantly overweight, loses about 10 to 15 kgs, he can be, he's reversing most of the abnormalities that are there. If that is the case, then probably we can reduce it. But otherwise, most of our patients require to continue.
Thank you so much, sir. We are running short of time.
Yeah, thank you.
Over to the organizers.
Thank you so much. Thank you to our chairpersons. And Rakesh sir, can I request you to please felicitate our chairperson? Dr. Bansod sir and Dr. Prashant Patel sir, please. Can we have the mementos, please? Thank you. So let's all wake up after a little hyperglycemia postprandial, with some claps, please, for our speaker. Thank you so much. Thank you. Yeah. Thank you, sir. Thank you. So we move on to our next session, go with the guidelines in heart failure. And for that, can I request our chairpersons, Dr. L.L. Bajaj, sir, who's a cardiologist from Gondia, and Dr. Tejas Shah, sir, who's a leading diabetologist from the city of Mumbai, please. Thank you, sir. Do we have Dr. Bajaj, sir, please? Yes, sir. Dr. Prashant Advani, sir, is our speaker. It'll come on the screen. Yes, sir. You start. I think Bajaj sir is not here. We'll start, sir.
Thank you very much for the opportunity and good afternoon to everybody. For our next session, that is based on as we are sitting in the Gliptin cockpit, we have an eminent speaker again, Dr. Prashant Advani, who is going to highlight us on the topic that is go with guidelines in heart failure. Because as we know, there's a lot of work and there's a lot of studies coming out related to heart failure, and all the new drugs are now showing benefits in terms of hospitalization for heart failure. So going ahead with the journey, I hand it over to our pilot captain, Dr. Prashant.
I wanted to be in army, so I'm finally captain now. Yeah, good, thanks. And it's a nice symposia going on. Thanks Sunil sir and Novartis for the opportunity. So, I'm an diabetologist and just to change from clinician, endocrinologist. I've gathered here. It's a conference of repute, and we have been discussing diabetes, the mode of action of the drugs and the combos, power couples, the new thing Lakshana presented. We wanted to prevent what? Somebody said we wanted to prevent cardiovascular things, cardiovascular disease, heart failure. Thing is that ever since the mandate of US FDA, there are no drug makers. You have to undergo a safety trial. Then it was 3-point maze: cardiovascular death, यानी मौत हो गई heart की वजह से या circulatory system की वजह से, MI and heart failure. Heart failure was not there then; it's an elephant in the room. Then it has been now recognized ever since the trials of SGLT2 inhibitors. They started with Barag and they found that heart failure तो बहुत कम हो जाता है. So we now re-looked into heart failure as a syndrome coming from so many metabolic abnormalities we Indians have. So probably in our part of the world, we are at the receiving end for having different types of heart failure in a very bad shape, and I must be encountering at least 10 to 15 patients in various its form. It's a very monstrous thing. And thing is, the only pleasant and glimmer of the hope, it's very preventable and highly treatable. And we have a very robust armamentarium and wonder drugs in kitty nowadays. But we have to be very smart clinician in order to pass on the benefit to the patient sitting next to us. We have to streamline. It's an era of precision medicine, irrespective of the subspecialty we are practicing in. We have to be first good clinicians. So I'll tell about some basics, some physiological things, some pathophysiological things. Where do guidelines stand today? And one case, because case-based things recapitulate everything in a nicer way. So this is a diabetes conference, and I'm talking of heart failure. So I wanted to put it because diabetes is, if somebody is diagnosed with diabetes, type 2 diabetes I'm alluding to at 30, in late 20s, early 30s, could be early 20s also. Type 2 diabetes is not uncommon in early 20s. Ashish, you find early 20s type 2 diabetes nowadays, don't you? So the moment at the time of diagnosis, something is smoldering inside. We call it CV inflammation. At the time of diagnosis, we are just going by HbA1c 7.2. Yeah, this is one thing, but it's only a picture in the larger monstrous thing, an obnoxious thing, and a syndromic thing that's happening, and it's afflicting the overall cardiovasculature reserve. And this is my slide. I've designed in such a way you cannot single out the risk of heart failure in type 2 diabetes. So it is a common soil. You have the same like as all of you have pointed out, that everything starts from the very, very ill-gotten genetics, epigenetics, environmental interaction, and the phenotype that we have: central adiposity, visceral adiposity, peripancreatic, perihepatic fat, NAFLDs, whatnot that we have, and the obnoxious fat discharges all paracrine endocrine factors into the bloodstream and creates the inflammatory oxidatory milieu, and that is where one manifestation is type 2 diabetes, that which you are discussing, but there are so many other accomplices. So it's a common soil. There's inflammation, oxidative stress, reduced natriuresis, blunted Nipson activity, and blunted incretin activity. We Indians are receptive. As SISR's exposition or Takshitas, we Indians have blunted incretin activity. So we have to be supportive. So we have similarly, we have very, very friendly substances on a body. At the moment heart is afflicted, the heart is afflicted. It could be subterraneanly. You cannot probe within. You are not aware that your vessel, your endothelium, your cardiomyocyte, your extracellular matrix is on fire, and everything is smoldering every moment. And any insults on the size, shape, function, again, heart failure is a clinical diagnosis. You don't require rocket investigations or science to understand that. It's a complex syndromic illness, and you can just die. There's a basic medical Hutchinson book I'm alluding to, and that culminates into heart has to work on a higher filling pressures, or it's unable to eject blood properly. So we call it reduced ejection fraction, or preserved ejection fraction, or mid-range ejection fraction, HEM-FREF. This any alteration, we kickstart neurohormones in order to tide over, but they're on the chronic subterranean activation of these neurohormones, angiotensin 2, aldosterone, epinephrine, become flogger. They are myocardial toxin. We have to neutralize. Then we have therapies that we have neutralized it over many years, but we never had something to potentiate the goodies that we also circulate after, as we call them, endogenous vasoactive peptides, and that is inhibited by sacubitril, which inhibits neprilysin. Similarly, which we have DPP4 inhibitor, which inhibit DPP4. So the heart failure burden is immense because type 2 diabetes is so common. We are ignominious capital of the world, and incidence could be 3 to 5 crore people of heart failure, and diabetics could be 10 to 20 crore. Whatever you report, it is already beyond it. You cannot come to a final thing that type 2, how much is the incidence of heart failure in India. We cannot find it out. And I'm telling you, it's beyond what we report. And mortality is there. We say that it is malignant than malignancy. We know that one hospitalization and you are at a higher risk of subsequent one. And lack of GDMT. In any such aspect, any realm of cardiovascular medicine, you have acute coronary syndrome, heart failure, dyslipidemia, even in type 2 diabetes and individualization, we are not on GDMT or tailor-made medication specific. And in heart failure patients, suboptimal GDP, even a cardiologist start with half-hearted approach and probably never up titrates. It could be me also at times, and that leads to residual risk and recurrent hospitalization and very dreaded cardiovascular death and mortality that we are scared of. So again, I'm coming back to, if you have a heart dysfunction, it starts from myocardium. In HEF-REF, heart is the initiator of the syndrome. In HEF-PEF, heart is party to the systemic inflammation that is going on. So heart failure, PEF is a recipient, but HEF-REF, it is start. It is the initiator of the process, because the cardiomyocyte or extracellular matrix and afflicted by some processes. Here I'm alluding to metabolic processes. So chronic antagonizing of neurohormonal activity like ACE, through ACE, ARB or MRAs, we have been all aware of ever since late 80s to 90s. We had discovered there have been paradigm change. When I was in medical school in my MBBS, it was told in an MDs also, don't use beta blocker in heart failure. We know that how paradigms do change. But in spite of using conventional ACE, ARB or ILL as RAS inhibition, MRA and beta blocker, you have huge residual risk remaining. Where it is coming from, you have so many good things getting kick-started from LA and LV stretch. We call them endogenous vasoactive peptide, AMP, CNP. They are vasodilators. They are natriuretic things. They subside. They douse the fire, vascular fire, the inflammation. They ease the endothelium. They ease the plaque. But they are very ephemeral. They are circulated and they are destroyed. A very, very killing thing, neprilysin destroyed. We never had neprilysin inhibition researched upon by that thing. So that power couple, as Rajiv and all were discussing, a neprilysin inhibition along with RAS inhibition combined together. But it's not a couple, they are now single body. So there's beyond power couple, they are now the same two souls in one body. So here are the guideline recommendations. So we call them ERNI. We know that angiotensin receptor blocker and neprilysin inhibition. This has changed the vistas and gamut and perspective in heart failure, HFrEF management, and we all are aware of that. And now I'll be swift because we know that the guidelines have come out. They've been waiting for last 3-4 years. And this year, in this pandemic time, American College of Cardiology has given class 1A indication to start with ERNI, then conventional RAS thing that we have been doing for a long time because huge residual risk still remains in spite of a guideline directed initiated then. And also SGLT2 inhibitors have been promoted from 2B to 2A, now class 1B. So you have 2 trials, so class 1A because there are 2 trials, Emperor reduced and DEPA-HF, even in non-diabetics. And I told you, because diabetes and heart failure is a common soil thing. So irrespective of diabetes, heart failure has a similar syndromic and pathophysiologic process as smoldering. And I can elaborate on this thing because it's a diabetes audience. So you have now 4 pillars. So you have RAS inhibition in form of ERNI, angiotensin receptor neprilysin inhibition, sacubitril valsartan, YMRA. Heart failure specific beta blocker, it has to be, it would be criminal not to prescribe heart failure specific beta blocker in LV dysfunction, HFrEF. Then mineralocortical receptor antagonist, spironolactone or eplerenone. And SGLT2 inhibitor, heart failure specific, empagliflozin and dapagliflozin, no other gliflozin. Of course, sotagliflozin has been, but then it's not in India as of now. Rajiv, is it? Sotagliflozin? Okay, so I'll tell first what are the HFrEF syndromes. I'm not alluding to HF mid-range and HF MREF we call it, or HFpEF. In chronic HFrEF, hospitalized HFrEF or de novo, पहली बार heart failure हुआ और वो hospital आया, and then surgery के बाद भी उसका heart खराब है. So post surgery or post revascularization heart failure. So where do guidelines stand in chronic HFrEF patient? It has to be ERNI. There's nothing, it's ERNI everywhere. And this is ACC 2022, very, very vociferous and very, very conspicuous. It has to be started in class 2 or 3 patients. So class 1 you wouldn't recognize. You can have LV dysfunction, 28%, but still you can be class 1. So you have to, class 2 or 3, that's why it's symptomatic heart failure, stage C heart failure, class 2 or 3, it has to be, and then all other drugs as I was alluding to in the guideline. Then ESC 21, they did it first. ACC 22 followed the suit. ERNI is recommended as a first line. I'm making this statement, and it's very economical. If you do some bargaining or rationalization, this guy gets hospitalized, everything evens out. So very economical. Also, SGLT2 inhibitor in heart failure, irrespective of diabetes, very economical. So a hospitalized patient is very scared. You have cured him. One diuretic can cure him, or direct infusion can cure him. And now he's ready to get discharged. This is the right time. He's very recipient, very compliant. Initiate GDMT because suboptimal GDMT institution or titration is the leading cause of heightened mortality and morbidity in heart failure. So in a HFrEF patient, initiation of ERNI during hospitalization is mandatory. And we know that heart failure and kidney now are the other side of coins. And in heart failure trials, we are seeing kidneys or either co-primary endpoint or secondary endpoint or vice versa. So can you rule out it? If you do ERNI, as I told you, class 1A now, so you prevent worsening renal function also. So so this is again a cardio-renal axis is addressed not only it's ERNI, but then you have to see that you have done other pillars too. And also the scare, the bugbear of hyperkalemia is also eased out. So as compared to RAS, either ACE or ARB, ERNI's YMRA is very easy on potassium rise, and you can even symptomatic hypotension which is again a bugbear or a scare to prescribe is not the case. So ESC 2021 says that, of course, as is the time of discharge, you can write it, and they are now concordant on prescribe on this issue. What about de novo HFrEF? We see so many. Some guy was taking some diabetic pill, roaming around, never had anything, and suddenly comes with a heart failure admission. Or he reports some prior, few days prior to admission, some thoda thakan or other, some breathlessness, and goes to some pulmonologist, writes some derifylin, goes there, takes some inhaler, but then actually until he gives up. So these guys are diagnosed late, but they're quite younger, maybe non-ischemic, maybe because of metabolic syndrome, and these guys differ differently from the who have established HFrEF because of ischemic etiology or various other etiology. But in these guys also, if you have an admission, the risk is same. Then subsequent events of cardiovascular death, all-cause mortality, and heart failure hospitalization. And there also the guidelines have taken the cognizance of this. You have to prescribe an ANI there right at the beginning. Don't waste time in writing or some ACE or some AR, but wait it to fail and then reinitiate, because you are losing as a legacy effect. So this is a heart failure generated oxidative and inflammatory legacy effect, which we talk of legacy effect in glycemia, in vasomotion, in hypertension, in lipids. So this is here. So you have to start with there. This is again, I'm propounding my case through this. Post-revascularization, many patients, you go to some setup and he receives a stent. He doesn't receive anything else, but he receives a stent. And if a syndromic management is not happen, this guy will never improve, and then he'll end up in a poor LV situation. You are ambulatory class 4, very symptomatic. Even young guys are like that. So what to prescribe? Again, GDMT, same GDMT. Kick-started or spearheaded by Ernie. So medical therapy is very essential. Initiation of GDMT, the best GDMT is very must. Spearheaded by Ernie, as I'm again saying. So GDMT dosing and sequencing, you can go on, he or me can have a dichotomous opinion, but it is something which I'll tell you later. It is something of every wing of heart failure or neurohormonal antagonizer. You have to cut it hard right at the base. All the wings are cut in a lower doses rather than going full gun only with the one wing. So there are 4 pillars of, as I said you again and again, only one pillar cannot be substantiated or underpinned. You have to see all the 4 pillars. And a patient gets well just in 2 weeks, 3 weeks. You cannot be complacent. Are ye to ab theek ho gaya, stable. Ab kya change karne ka? Something is smoldering inside. What so you see as fitness or something, which is a very terrible mistake, both in coronary artery disease, ASCVD, and heart failure. If something is more than which is eating from within like a termite, and these processes are actually exsanguinating the cardio-parenchymal reserve, causing subtle architectural disarray, fibrosis, oxidation, and further causes it to remodel, and then suddenly one day finally either you have sudden cardiac death, these stable so-called quasi-stable patients have sudden cardiac death, or progressive pump function. So you have to intervene. You cannot be complacent. So there's a case, Nazneen, 53-year-old lady, female, moderately built, BMI 28, taking some antihypertensive pill from somewhere and going around, reports some shortness of breath or class 2 symptom, walking up flight of stairs, and then suddenly has a PND, nighttime breathlessness, couldn't lie down. Goes to some nearby setup. At ER, somebody does an echo, ejection fraction 32%, eGFR 72. And this is for the first time. We call it de novo. So these de novo patients, I was alluding at so many in India, but never been taken in any trial. So there's hardly any robust data trial with randomized RCT-based data. But then they have the similar prognosis once after that admission. So these guys benefit in the same way. So you start with, as I told you, if you start with conventional RAS, ye to abhi aisa hi pehli baar hua hai, so then you lose that legacy effect. So guideline recommendation comes here too. Again, ACC 2021. So they've very exhaustively reviewed everything. Pehle se HFrEF hai, pehli baar hua hai, pehli baar hospital se ja raha hai, don't waste time. And Indian patients are notorious for being non-compliant, either non-pharmacological way or pharmacological way. And we have so many devices and jugaad being done in India. So impact of circulatory vascular on de novo hospitalized is the same way. So it keeps them alive, keep them alive on planet Earth, and keep them away from hospitals. The hospitalization rate, subsequent cardiovascular mortality, all-cause mortality, quotients go down. Even in de novo patient, because this is something which is unstudied. But the guideline recommendation coming. So level of C, but class of 1. So that's 46% reduction in death with initiation of Vimata in hospital patient without prior exposure, because these guys are not aware that they are having a smoldering chronic CV inflammation which might suddenly lead to something. or sacubital valsartan show improvement in LVF. Also, you reverse remodel, you improve your LVF, you improve your compliance characteristics, you decrease your LV stretch, your chronic neurohormonal activation goes down, everything eases out, the fire is doused, and I'm done. So conclusion, why it's such a common heart failure, you cannot just complete in 15 minutes. So quadruple therapy, now we have 4 pillars for half rep. I'm not alluding to half rep, I've cleared the thing in the initial slide. So start with ANI. Then some issue, hardly any, shouldn't be any issue. Then ACE to be chosen, or not tolerated, then ARB to be chosen. This is me, I have written that way. 4 pillars at low doses better than less than 4 at higher doses. And you have a science behind it. And there's no time for delay. You cannot rest complacent, dear chairperson. And how would I initiate? I write Vayamada even at 88 systolic blood pressure. And there could be half BD or something, and then call him even less than 1 to 2 weeks and make sure that he receives all 4 pillars, and then follow it up against the art of medicine. And this is where you can see patient characteristics, comorbidities, presentation patterns, so many other things, economical, and then economic issues, and then tailor-made and cause him to have a reverse remodel, and many people recover their LV function through direct to ANI approach. So this lady, I've written sacubital valsartan ANI right at the time of diagnosis, and this lady is now totally asymptomatic and doing well, and has a good preservation of his cardiovasculature. So I think individualization is the key, and this is an era of precision medicine. And sorry, I'm late by. Okay, still the time is remaining. So go back to the case. Okay. So thanks for that. I acknowledge Manoj, Rajiv's presence here, Ashish, Sai sir, Karnataka. Yeah, right. No HFref there. Thank you. Okay.
Thank you. Thank you very much, Prashant. Thank you very much. Welcome any questions from the audience, if there are any.
This is a hardcore heart failure thing. It's a diabetes conference.
Just one quick question, Prashant.
Yeah, please.
Regarding, there have been a few studies with SGLT2s in acute heart failure also.
Yeah.
So what has been the take from cardiologist point of view of using SGLT2s in a patient in an acute setting?
So yeah, not acute setting. They shouldn't be catabolic. They shouldn't be catabolic. Acute heart failure is a catabolic state as of now, and these guys are trying, the researchers. Likewise, they are trying these pillars right at the time of discharge, or once they are stabilized. In ANIs, in Pioneer HF or transition trial, they have been given just after 12 hours of stabilization. This guy is diuresing, no longer sweating, hemodynamic is stable, no symptoms, ANI. Just after 12 hours of the acute breathlessness. But SGLT2 inhibitors are also being tried in the same situation, and there have been stray reports coming that they are also doing the same thing. With dapagliflozin, I think you guys follow all the things. Manoj, anything you are aware of? As he's asking. But the guidelines are not incorporated yet in hospital initiation of SGLT2 inhibitors. But of course, otherwise, so I told you in the beginning, I write it, even in non-diabetic. So probably what I see in 1 year from now, or could be 6 months from now, this would also be the case. Many people are off-label doing this thing already. But then you have to take a call. Maybe they are very sicker, and SGLT2 inhibitor wrongly prescribed can turn the cards otherwise. So I think you have to choose the patient. But otherwise, a very good bet and a very, very safe thing and they have the tendency to change the natural trajectory for heart failure here also. A conjunction of ANI works very well, and also other pillars.
Thank you. Thank you.
Tejas sir, can I request you to felicitate our speaker, Dr. Prashant Advani sir, please?
If somebody has forgotten, Sai sir, ये आपका है क्या चश्मा? अच्छा, इस पे SGLT2 लिखा है.
Thank you. I just have a quick announcement to make that the organizers have requested that all the speakers please curtail their talk, make it a little crisp, and complete in 15 minutes instead of 20. Thank you. Thank you, sir. So thank you, Tejas sir. We commence to our next session. No, during this talk we'll get to. Thank you. So we move on to our next session, evolving evidence with newer DPP-4 evogliptin, and for that, can I request our chairpersons, Dr. Suhas Kanfade sir and Dr. N.P. Tolani sir, to please come on the stage and introduce our speaker. Suhas sir is a senior physician from Nagpur, and Tulani sir is a senior physician from Nagpur as well.
Well, very good afternoon to all of you. At the outset, let me thank Dr. Sunil Gupta for organizing such a wonderful conference. And we thank him for inviting us and sharing these sessions. Dear friends, now the focus has changed to the incretin system. And now we have got a talk on the DPP-4 inhibitors, a relatively new inhibitors, that is evogliptin. And the speaker is Dr. Ashish Dhingra. I'll ask my co-chairman, Dr. Kanfare, to introduce him, please.
Dr. Ashish Dhingra is a Director, My Diabetes Thyroid Care Research Center, Jabalpur. Diploma in Diabetes, Cardiff University, UK. CPS Diabetology, All India Institute of Diabetes. He is postgraduate certificate course in diabetology, advanced certificate course in diabetology, certification course in diabetology, certification course in evidence-based diabetes management, certificate course in management of thyroid disorder, certification course in diabetic food management. He was ordinance secretary, Jabalpur Diabetes Update, Jabalpur Thyroid Update, MMRF, Insulin Workshop. President API, President Jabalpur Endocrine Society, Ordinance Secretary, RSSDI MP Chapter, Vice President, RSSDI MP Chapter, Honorary Secretary, Founder of Mahi Medical and Research Center, Member of AACE Endocrine Society of India. Award recognition, received so many awards. I don't waste time to read that, and I advise him to start his lecture.
Thank you, respected chairpersons. And at the outset, I would like to thank Dr. Sunil Gupta sir to invite me to discuss this important topic, evolving evidences with newer DPP-4 inhibitor, that is evogliptin. And we know that there are many molecules available and coming, the new molecules are coming in the pipeline. So DPP-4 is not a new for us because there are 14 years since we are using it. But evogliptin, what is different with this molecule? You know that it is a selective, potent and reversible inhibitor of DPP-4 enzyme. It is extensively studied for its efficacy and safety, and first approved in South Korea in 2015, then in Russia and India by DCGI in 2018 for the management of type 2 diabetes in the patients as a monotherapy or with metformin in 5 milligram of dosages. Why it is different or new? Because you know that whether all DPP-4 inhibitors are same or not, let's see. So DPP-4 enzyme with the binding site, basically they bind with S1 and S2 site of the enzyme, and there are the other two sites also, that is S1, S2 dash and S2 extensive. Basically the binding is mainly with the S1, S2, which is the fundamental required for DPP-4 inhibition, and the other parts are the additional required. If required, they are for the more inhibition of DPP-4 enzymes. So class 1, class 2 and class 3. What are the class 3 gliptins? They are the sitagliptin, tenaligliptin and evogliptin. So why they are different? Because they bind to the other extra sites also. So class 1 are Vildasexa, they bind to the S1, S2. Lina LO are the class 2 which bind to the additional S dash and S2 dash. And S3, class 3 are the sita, tenali and evogliptin because they are binding to the S2 extensive site also. So evogliptin, apart from binding to S1 and S2 sites, they bind to the S2 extensive, and that's why they are having more inhibition of DPP-4 enzyme, and they bind by non-covalent binding. Why it is important to discuss the evogliptin? Because of the pharmacokinetics, the DPP-4 inhibition is very robust, and it is half-life is 32.5 hours, and the accumulation index is only 1.38 to 1.5, and it is unchanged by food. And according to the studies, they have shown that it is not an inducer of cytochrome P450, and renal clearance is very less. It is excreted unchanged by 27 to 34% only. So no dose adjustment is required in the renal patients. And in the hepatic patients, you can use in the mild to moderate liver dysfunction patients. So beauty of this product is DPP-4 inhibition remained more than 80% of the time of the day, 1.5 to 2.4 fold increase in the GLP-1 levels, and 25 to 35% decrease in the postprandial glucose levels. So the international studies have been done, and phase 3 study and many more studies have been done which have shown that the evogliptin 5 milligram monotherapy significantly decreased HbA1c without any side effects, and it was well tolerated, and in patients who are on diet and exercise. So the Brazilian population study, bridging study, have also shown that once daily treatment with evogliptin was safe and well tolerated, and there were very few side effects when it was compared in the various population, and with the sitagliptin, evogliptin, they have shown the HbA1c change was nearly same. Now, Evergreen study, which was presented in ADA 2019, it was a comparison of Evo versus linagliptin, and they have seen the efficacy neck to neck with the Evo and Lina, and they have shown that they were at par at the 12 weeks, and at the glycemic variability part, they have shown that the MAGE was much ahead, reduced by the evogliptin as compared to linagliptin, and standard deviation of glucose was also very less with the evogliptin. So in the nowadays what we are seeing, that glycemic variability should be reduced and it should be maintained at least. So TIR should be improved and TBR and TAR should be less. So the maximum time the patient should be in the glycemic range. So they are giving, evogliptin is giving the advantage of this. The change in A1C from baseline at 24 weeks was again significant with the evogliptin 0.94% reduction. So the glycemic variability was also reduced in all the parameters like MAGE, SD, average glucose in 24 hours. So to conclude this study, in 24 weeks or in the 12 weeks, it was non-inferior to linagliptin, and it was safe and effective anti-diabetic treatment in patients who were not having good control with diet and exercise. At 24 weeks, they have shown the improved CGM with the variability was reduced a lot with the evogliptin arm as compared to the linagliptin. So it is giving good control with less variability, which we require for prevention of future complications. In renal dysfunction, this study have proven that it is safe in all grade of renal dysfunction except the patients who are on dialysis. So you have to avoid this drug in patients only on those who are on dialysis, because there are no studies done, and in the kidney dysfunction you can use easily. In hepatic impairment, again, the studies have shown that you can use this drug till in mild to moderate dysfunction, and we use usually insulin in severe grade. So you can use this drug evogliptin in the mild to moderate hepatic dysfunction also. The NAFLD, which is very common in our diabetic population, because we are seeing obese patients with diabetes, you go for sonography or SGPT-OT, you find that there are patients with NAFLD. So in this study, they have seen the MRI PDFF, which detects the fat cells in the liver, and they have shown there was significant reduction in the fat cells, as the sitagliptin study have also shown that it reduces the hepatic fat content at 24 weeks. So evogliptin in non-alcoholic fatty liver with diabetes, 24-week trial was safe and showed a trend in reducing liver fat in type 2 diabetic patients with NAFLD. And when the evogliptin was seen on the arm of cardiovascular risk, because you know every molecule requires now cardiovascular safety. So when it was studied in the South Korea, a nationwide population-based cohort study was done, and they have shown that demographic and clinical characteristics of patients with type 2 diabetes treated with glimepiride, DPP-4 inhibitor, SGLT2 inhibitor as second-line agent in South Korea. In the 31 lakh patients, they have done the seen the data, and the comparison was between the glimepiride users, DPP-4 inhibitors, and SGLT2 inhibitors. So what they have found, that use of evogliptin was either decrease the risk of CVD or had no association with increase in the CVD risk, or as compared to the other DPP-4 inhibitors or SGLT2 inhibitors. So the data of 30 lakh patients was showing that it has no CV adverse effects. The clinical evidence with metformin evogliptin combination has again proven that it is having good efficacy when it is compared with the combination therapy versus sitagliptin metformin or evogliptin metformin. Various studies from India, Evolution India study have also shown the positive benefits. You can see the evogliptin 5 milligram added to metformin 1000 milligram has improved the glycemic control with very less chances of side effects or any side effects of nausea or vomiting which we see with the DPP-4 inhibitors in the initial stages. And when compared with the sitagliptin, it was non-inferior to sitagliptin in HbA1c reduction. Again, the same study was done in the Indian population because we require the studies in the Indian population. Again, you can see the Evo 5 milligram with Sita 100 milligram is showing the same efficacy of 0.5% reduction. Multinational global study, again, when added to metformin, they have shown non-inferiority with the sitagliptin in this study at 24 weeks. Safety of evogliptin was again proven. It has very little side effects when compared with the meta-analysis. Safety again proven to be safe. Evogliptin with metformin, latest Indian data in 2021 is showing the percentage change of HbA1c of 0.9 to 1.45%. Change in the fasting and PP was significant when it was added in the patients who were already taking triple drug therapy. When we add evogliptin, the study was published in the RSSDI 2020 and it has shown the significant reduction in the HbA1c and fasting and postprandial glucose. The Indian data on CGM published in 2020 RSSDI, we know that every molecule we know now that we require CGM data to prove its efficacy to reduce the glycemic variability. So evogliptin has shown that it is patients were before 15 days of addition of evogliptin and after 15 days of adding. Both the CGM were done and they have shown that the blood glucose level before and after was reduced significantly and percentage in target range. So patient को कितने समय better glycemic control में रह रहा है, that was improved with the evogliptin. So before 15 days without evogliptin and after 15 days with evogliptin, they have shown the improvement in the glycemic variability. So there was decrease in 1.2% HbA1c in this study, which was published in ADA 2021, and CGM analysis revealed that there was very less chances of glycemic fluctuations when it was used in patients who were already on insulin, and even the dosages of insulin was reduced. So effects of evogliptin on metformin glimepiride combination when added as a third agent, again in 185 patients this study was done, have shown the A1C reduction from 8.8 to 7.8%, and fasting PP was significantly reduced at 6 months of study. So the combination therapy in Indian population with metformin 1000 milligram and evogliptin 5 milligram have shown the better control, and compliance improves with the single pill, and the patient is having good control of glucose with less variability and with the single pill. So what we require in the present era, दवाइयाँ कम हो, compliance बढ़े, patient एक गोली खाने के लिए तैयार हो जाता है, 2 गोली. But if you write the separate drugs, the patient says बहुत सारी दवाई हो रही हैं. So the motto of this topic is that the newer gliptin, evogliptin, is giving good control. You can see when we compare the characteristics of different gliptins that it is OD dose, high selectivity with good DPP-4 inhibition. 80% of the day, the DPP-4 inhibition is achieved with no QT prolongation. So ongoing evidences are also, studies are going on. Many studies are going on in India, Korea for the evogliptin when they are comparing with the SGLT2 inhibitors, or in the naive patients in the CV mortality reduction. So all these studies will be we will be seeing in the coming few years. So what to discuss in the nutshell, I summarize my talk of evogliptin that it is truly once a day potent anti-diabetic agent with longest half-life of 32.5 to 39.8 hours with established renal, hepatic and CV safety without the need of any dosage adjustment in the renal patients or hepatic patients till moderate dysfunction. The evergreen study, a 24-week study, when compared with linagliptin, it was at par, non-inferior to linagliptin with good glycemic variability reduction. And with the 3 head-to-head studies against Sita, Evo have been proven that to be non-inferior. Even the Indian study, Evolution study, have shown the same results. So the fixed drug combination of Evo with the metformin has given the good fixed drug combination for the management of diabetes with improved compliance and less chances of side effects. So we can use this drug as a second line, first line, or third line or fourth line agent for management of diabetes. If we get the good control with less glycemic variability, the future complications will be less. So that's why this combination therapy is a boon for diabetic patients. Thank you. Thanks a lot for patient hearing. Thank you.
Thank you, Ashish, for a wonderful talk on the evogliptin, a relatively new gliptin, and we have got one more DPP-4 inhibitors, which is non-inferior to linagliptin and sitagliptin. I don't know whether it has got some price advantage over the linagliptin, because these linagliptin and sitagliptins now they are going
No.
off patent. So whether it will be more economical, I don't know. I just wanted to know one thing. With the advent of now GLP-1 agonist drugs, what will be the future of these DPP-4 inhibitors? Do you see?
See, as the GLP-1 like oral semaglutide is also available, but the cost and the pattern of the intake of medicine, it is very cumbersome. Patient has to take empty stomach, wait for half an hour, because many patients of diabetes have thyroid dysfunction also, so they have to take thyroxine tablet also. गैस हमारे यहाँ सबसे ज़्यादा प्रॉब्लम है इंडिया में, हर पेशेंट को है. तो GLP-1 oral to take is very cumbersome and it is very costly, because we have seen in our clinical practice that patient शुरू तो करता है कि when we say them कि weight loss होगा, you will be have good control, but the 3 milligram we have to start, then 7 milligram, then only you will see the results. If injectable patient is ready to take, it is wonderful drug. But in our society, the prick is a very phobia is there. So in the era of GLP-1, still the DPP-4 will be there, because they have the different mode of action, and we know that diabetic patient of our Indian population, average HbA1c, still after getting so many drugs in the pipeline, we are in the 9.5 to in the 9 range. Only 10 to 15% of patients are able to achieve the A1C of 7. क्योंकि हमारे यहाँ शादियाँ हैं, त्यौहार है, और बहुत सारी चीज़ें हैं जो हमको A1C अचीव करने में प्रॉब्लम देता है. So compliance is also very big problem. So due to the easy use of the DPP-4 inhibitors and little tricky or cumbersome use of the GLP-1 oral agents, I think so that DPP-4 will be ahead of the GLP-1 oral agents.
DPP-4 going to step, I think.
Yeah.
Even this. Any questions from the audience? We can have one question at least.
Ravin, price कितना है? 19 rupees is the price.
If cost is not concerned, then which gliptin you will use?
If cost is the concern, not concern.
How to select the DPP-4 inhibitors?
See, we have seen that it is non-inferior to sitagliptin and having the good efficacy, decreased glycemic variability. We can select this drug in apart from the Sita or Vilda, because Vilda has to be given previously twice a day. But the recent molecule is OD dose also, but what are the side effects on the hepatic part we have not seen still with the OD dose. So we have to wait and watch. So we can keep it as a second line agent after Sita, I think so.
Thank you. There are no questions. We'll stop.
Thank you. Thanks a lot, respected chairpersons.
Thank you, Dr. Ashish Dingre, for your session, and would like to request our chairperson to felicitate Dr. Ashish with the memento.
Thank you. Thank you, sir.
Thank you. And we'll request again Dr. Ashish.
Sir, आपका momento.
To facilitate our respected chairpersons.
Yes, senior. Thank you. Yeah. Thank you. Thanks a lot.
So, ladies and gentlemen, we are taking you to the
Thank you,
glip closing
Dharmendra Malay.
cockpit.
Thank you.
We are taking you to the Glyphlosil cockpit for the next session and would like to invite our chairperson, Dr. Nalini, for the next session. Dr. Nalini ma'am, she is head of Department of Medicine, NKP Salwa, Nagpur. Over to you, ma'am.
Hello. Echo thanks to organization that invite me as a chairperson and chair this session. My topic is emerging evidence in type 2 diabetic patient with dapagliflozin, and speaker is Dr. Manoj Chawla. So big CV, Dr. Manoj Chawla, he is a MBBS and diabetologist, FRCP Edinburgh, director and consultant diabetologist at Lena Diabetes Care and Mumbai Diabetes Research Center. He is a consultant diabetologist at SR Raheza Fortis.
Thank you. I think, ma'am, it's there. Thank you so much. Right?
So, sir, we can start because we are running shortage of time.
Yes. So, Chairperson, Madam, rapporteurs and organizers at Hello Diabetes, thank you. I'm going to be speaking over the next 12 odd minutes on the emerging evidence with dapagliflozin. So, well, I think that's the theme here. So, let's welcome to what I would say Gupta Ji Airways, that we all are enjoying the flight for the last 2 days. So, let's start with the glycemic efficacy of DAPA and the unmet need. Now, every time that we talk about each drug and its efficacy in managing diabetes, there always is an unmet need. And dapagliflozin is one such drug which fits into the place and does additional A1C reduction, whether it is used as add-on to metformin, add-on to the combination of sulfonylurea met. You look at it in combination or in comparison to even once weekly GLP-1, and you see in terms of A1C reduction, you're getting significant results with dapagliflozin add-on to almost 2%. And same would be the case when you compare it as an addition of DAPA to a sitametformin combination or even with insulin. You look at the other aspect which is important today is the weight aspect, and when you add dapagliflozin, there is significant further reduction in body weight. So you compare to placebo, when added to metformin, there's a 2.9 kg reduction. And similarly, you will see in every aspect of addition of therapy, you get weight reduction. Important to note that when they even compared the weight reduction to once weekly exenatide therapy, which is a GLP-1, you see better reduction with dapagliflozin to the tune of 2.2 kgs and 3.5 kgs weight reduction. Now, this has been an interesting paper and concept work by Professor Anup Mishra and team, and they've been doing the work on the perihepatic and the peripancreatic fat, which now is known as a factor which worsens the metabolic condition. And any aspect of therapy, whether it's lifestyle modification or a drug which is able to decrease the hepatic and pancreatic fat, will have favorable outcomes. So they saw in this study that after 120 days of DAPA treatment, there was significant decrease in the liver fat fraction and the mean pancreatic fat fraction after DAPA therapy. Now, though we all wanting to treat our patients with diabetes do focus on glycemic reduction, we do realize that glycemic reduction conventionally over the years, the various studies that we see, they helped us bring down the sugars, but they haven't changed a lot of cardiac endpoints. More specifically, the heart failure events never reduced in patients where you did intensive glycemic control. So when you look back the old studies, and when I say old studies, in the past, all the studies were conventional treatment versus intensive treatment of glucose. So you look at the data from UKPDS, Accord, Advance, VADT, in all of these, you find that in spite of glycemic reduction, you're not seeing any benefits in heart failure reduction. You also move on to look at the cardiac risk, and again, every time in a trial that you try to compare conventional to intensive therapy, and you can see the differences here between conventional and intensive, much better blood pressure control, better A1C reduction, better cholesterol, use of AS, aspirin, and so on. You are able to reduce the residual nephropathy risk, but you're not able to eradicate it. So in spite of good intensive treatment, you will see
50% of the residual nephropathy risk still remains, telling us that we need to do beyond just glycemic reduction. Now, when we spoke about heart failure and nephropathy, the important aspect is, are these really relevant and important? What is the burden of cardiorenal disease today in patients with type 2 diabetes? It clearly is proven now that renal and cardiovascular disease are closely interconnected. Whether you have today the altered energetics in your patients with diabetes, the hypervolemia, inflammation, ischemia, neurohormonal activation or RAS overactivation, all of these in your patient with diabetes lead to cardiac and renal comorbidities, and both these systems usually should be considered together. So when you look at these comorbidities, do they really coexist and what really are the numbers? So important to note that almost 24 of your patients with type 2 diabetes will have heart failure as their first cardiovascular or cardiorenal complication. Also important to remember that 58% of your patients with type 2 diabetes will develop some form of CKD in their lifetime. So today, when you're treating your patients with diabetes, ignoring the fact that these patients have a huge cardiac and renal comorbid potential would not be fair to our patients. So cardiorenal disease is the most frequent first comorbidity. There's an interesting retrospective analysis where they did for more than 1.1 million patients. And they found that initially the majority of patients over a 4.5-year follow-up, when they saw at the base, these patients majority were free of any cardiovascular renal disease. At the end of 4.5 years, they found that 18% of that cardiovascular renal disease free population did develop some form of cardiovascular or renal disease manifestation. And you can see here the percentage of different cardiovascular renal complications: heart failure 24%, CKD 36%, peripheral arterial disease, and so on. But what was important again as an outcome from this retrospective analysis was, compared with the comorbidity-free patients with diabetes, cardiorenal disease was associated with a greater risk of mortality than the other risks. Whether you talk about MI, peripheral arterial disease, it was the cardiac renal. Those who had cardiorenal diseases would have higher chances of mortality. We also look ahead at the prevalence and identification of CKD. So when there were surveys done across different years, they found that when you look at patients of any stage of CKD, close to 40% patients have had some of the CKD presence in patients with diabetes. So the prevalence has been consistent over time. Also, that when you look at the distribution of markers when you're trying to identify CKD, very often if you miss to calculate eGFR or look at the urine albumin creatinine ratio, you will miss those patients with early CKD. So as seen here, these two are extremely important markers, and if you don't start calculating those or looking at those, you will not pick up patients who are on stages 1 to 3 of CKD, and you will find them or catch them much later when they have progressed to stage 4 CKD. Cardiac function also tends to be compromised early in your patients with type 2 diabetes. So when you look at the patients with diabetes, 68% of these patients had, for a median of 5 years who were followed up, showed some signs of left ventricular dysfunction in the absence of any ischemia. So you will see the breakup here. 25% patients were having both systolic and diastolic, 16% patients having diastolic dysfunction, and 27% having systolic. In the past, we were picking up probably only these 27% patients and missing out on a lot of patients who had diastolic dysfunction. So earlier diagnosis and management of asymptomatic left ventricular dysfunction today is extremely important to prevent the long-term complications. So let me ask you that if you're enjoying the flight, shall we serve you with some more data on these aspects of where dapagliflozin can help? So let's have a look at the prevention of cardiorenal outcomes. And we focus on prevention of kidney disease. Now we go back to the DECLARE study, which was the cardiovascular outcome trial for dapagliflozin. What's important to note, as compared to the other CVOTs, which was the EMPA-REG and the CANVAS, the population in DECLARE was different. So almost 60% of patients in the DECLARE study were those who had multiple risk factors but did not have established ASCVD. If you also look at the GFR was much higher comparatively in patients. The average GFR in DECLARE was close to 85 as compared to 75 and 74 in the other cardiovascular outcome trials. So you had a relatively healthier or normal renal function population. in spite of that, when you look at the renal endpoint, it showed that in the renal endpoint, there was 47% relative risk reduction in the DAPA arm as compared to the placebo arm. DAPA had a favorable effect on albuminuria across the baseline urine albumin creatinine ratio categories, including patients with normal albumin excretion. So if you look at the second, the deterioration from the baseline fragment, you will be able to appreciate that not only there was improvement in patients who had micro and macroalbuminuria, but even if you compare those patients from normal who would have progressed to micro or macro in the placebo segment, did not in the DAPA segment, telling us that the benefit of dapagliflozin on the renal endpoints was irrespective of the baseline UACR or the albumin excretion rate. What about prevention of hospitalization for heart failure? Another important aspect. So DECLARE, as I said, enroll patients who were early in the disease continuum, including almost 60% patients without established atherosclerotic cardiovascular disease. And this is where, if you see, DECLARE was different from the EMPA-REG, which had almost 99% with established ASCVD, CANVAS, and even VERTIS CV. Yet, when you look at the outcomes from DECLARE, when you look at the composite of hospitalization for heart failure or cardiovascular death, you get a 17% relative risk reduction in favor of DAPA as compared to placebo. You look at the MACE events, though it did not achieve statistical significance, there was numerically lesser number of MACE events for DAPA as compared to placebo. You look at specifically only hospitalization for heart failure, and you get a 27% relative risk reduction for DAPA as compared to placebo, in spite of baseline patients only being 10% with existing heart failure. So you're still seeing the benefit in this healthy population. And this is important because when you treat your patients out there, are 99% of your patients reflecting the EMPA-REG population, which is all of them having ASCVD, or in general 20 to 25% of your patients will be having heart disease, and the rest is predominantly for primary prevention. And hence the data from dapagliflozin and DECLARE becomes so much relevant for our practice. When you look at the safety data across the major studies done for dapagliflozin, be it DECLARE-TIMI, DAPA-CKD or DAPA-HF, there were no concerns for any serious adverse events, be it volume depletion, fractures, amputations, which may have been a concern earlier, urinary genital infections to some amount, but nothing really beyond that which caused any concern for its usage. What about the guidelines then? As a result of all this data, what do the guidelines say? Well, the standards of medical care in diabetes, the ADA 2021-22, essentially tell us the same thing, that today, besides lifestyle therapy, you're going to be looking at the presence of comorbid conditions. Whether your patient has ASCVD or heart failure or CKD, your choice of drug is going to be SGLT2 inhibitor much, much earlier. The only place they will put GLP-1 before is for ASCVD, but if your patient cannot tolerate it or cannot afford it, you will offer them the benefit of an SGLT2 inhibitor. You also look at the ACE algorithm for glycemic management, and you will again see here that today they speak about whether you should use monotherapy or combination therapy from the word go, but interestingly they also talk about the need to use SGLT2 inhibitors irrespective of the baseline HbA1c. If your patient has CKD, if your patient has heart failure, you will use this drug irrespective of the A1C and with or without metformin. And this has been another additional interesting recommendation for primary care, which also, if you notice here, they'll speak this word that consider SGLT2 inhibitor or GLP alongside rather than stepwise. And which is why I put this recommendation, and that take home is important, that use drugs like dapagliflozin alongside your metformin where they are not contraindicated rather than stepwise, because you want to offer the benefit to patients with high CV risk, very high CV risk, or heart failure or CKD much, much earlier. So let me conclude by putting all the three innovator SGLT2s in perspective for a take-home message. In terms of primary heart failure outcome data, you see that for DAPA as well as EMPA in their cardiovascular outcome trials, the specific heart failure trials, you do not have one for canagliflozin. You look at mortality benefits for reduced ejection fraction heart failure, you see that for DAPA and not the other SGLTs. You see primary renal outcome data for DAPA through DAPA-CKD and CANA through the CREDENCE study, but not for EMPA yet. All-cause mortality reduction, again, restricted only the benefit for dapagliflozin. And finally, when you look at the reduction in hospitalization for heart failure and CKD progression in general, that's one benefit that you see across for all the SGLT2 inhibitors, to be fair to the data from all the three cardiovascular outcome trials. So with that, let me thank you for sitting patiently and enjoying this flight. And I want to leave you with this slogan and thought as we enjoy the rest of the conference today and tomorrow. Thank you so much, Chairperson.
Thank you, Dr. Chawla. Timely you have finished the talk in your allotted time. I have one question. It reduces the weight. The obese person, non-diabetic, can you use?
So an obese person who has CKD, who has issues with urine albumin creatinine ratio, or who has heart failure, today we know this drug is approved as a drug even irrespective of the glycemic status from heart failure and CKD progression. Should this drug be used as a weight loss drug even if it causes? No. Right? So it's neither approved nor should be used. What people try off-label is a different aspect. But as I said, unless you have those two conditions or diabetes, of course, I wouldn't use this drug for just that benefit of the weight loss which is seen.
Yeah, it is all text says it is a cardiorenal problem, it is protective with diabetes, it reduces the HbA1c. What is your experience regarding? You use that drug?
In terms of HbA1c reduction?
Yeah.
So I think its HbA1c reduction potential is quite good. And I would say in terms of the oral drugs, it's only secondary to sulfonylureas. Yeah. Much better than the DPP-4 inhibitors.
Other anti-diabetic
yes. So it's only
drugs.
Secondary to SUs and probably metformin.
So last question, it is a SGL2 inhibitor. It acts as the proximal renal tubule. It excretes the sodium. Does it reduces the serum sodium level?
No, it does not cause any hyponatremia. So in terms of any of the electrolyte imbalances, there is no
role of the dapagliflozin.
No
because we are using in the renal failure.
There may be some instances of hypovolemia in the elderly and hence a word of caution there. But in terms of hyponatremia due to SGLT2 inhibitors, that's not been a problem.
Okay. Right. I welcome one or two questions from the audience.
There is a hand raised there.
Is there any rule of 5 milligram of dapagliflozin?
So very interesting, but there is no data except in patients with type 1 diabetes, where there have been some papers where they have used 5 milligram. It's not approved, it's still a lot of caution to be used there. So if you scan the literature, there will be 5 milligram usage in type 1. In type 2 patients, the data with 5 milligram is extremely poor. There are, I think Dr. Rajput wants to add to that. There are some data, but in terms of otherwise what you get here, the large number of 5 milligram is not there. Dr. Rajput.
Actually, for type 1, no SGLT2 inhibitor is to be used. It's again off-label use, and if we follow country rules, government rules, not to be used in type 1. As far as 5 milligram is concerned, it is only in patients with hepatic failure. If you see the product monograph, they themselves write, the innovator, the Forsiga, they themselves have tested that in patients with hepatic failure, child puke category A and B, you can use a reduced dosage of 5 milligram. Apart from that, whatever data has been generated, it is done only with 10 milligram dose. So please do not use 5 milligram in patients of type 2 diabetes.
True.
And your question of hyponatremia, why it does not develop? Actually, sodium is absorbed not only from proximal tubule, it is also absorbed from distal tubule, loop of Henle. So there are a number of pathways ahead of proximal tubule. So whatever sodium is going from that area is reabsorbed in distal tubules. But the glucose is not absorbed apart from proximal tubule. So then glucose is excreted out.
Thank you. Thank you, Dr.
Right.
Thank you, sir.
Thank you.
We move to next topic.
Excuse me. It's a wonderful talk by Dr. Manoj sir. I request Dr. Rajput sir, please felicitate Dr. Manoj sir with momentum. Please, sir. Big round of applause, please. Thank you, sir. Please, over to you, ma'am.
Now we move to next topic. I invite Dr. Nitin Tiwari. Welcome, sir.
Thank you.
Sir is going to talk on the deadly duo of heart failure and CKD and evidence with the dapagliflozin irrespective of the diabetes. Sir, can we start?
Yeah, thank you everyone for waiting, and thank you ma'am for the opportunity. So the earlier speaker has made my job easier. I'll be focused in my approach. Being a cardiologist, I will not talk about the diabetic control, but yes, I'll talk about the cardiac evidence which we have about dapagliflozin. And in particular, I'll be talking about the deadly duo of heart failure and CKD. What evidence do we have? There are 64 million people who have heart failure. They are increasing every year. There is a 24% suggested increase in rise by 2030. 50% mortality in heart failure at 5 years, 90% at 10 years. Heart failure mortality rates is similar, in fact worse than many of the leading cancers. A lot of economic burden. And over 50% of patients have HFpEF. Now HFpEF is a very difficult diagnosis to do, heart failure with preserved ejection fraction. But I think with the time, it is actually increasing with the diagnostic modalities which we have. As you can see, the percentage of patients in heart failure category, right, HFpEF patients are actually increasing from 40% to around 56% over the last 2 decades or so. And heart failure with a reduced ejection fraction is easy to diagnose. People can pick up easily on an echocardiography, and actually they are decreasing with better treatment which is available. And what are the reasons for heart failure with preserved ejection fraction which is increasing? I think the most important reason is increased life expectancy. The more serious, the more aged the population, HFpEF is more commonly seen in females, elderlies, obese, diabetic with nephropathy, with COPD, and atrial fibrillation. Such patients are having more HFpEF. And as we look at the survival of the cardiac patients also is increasing with angioplasty, with bypass and other modalities. So naturally, and the lifestyle disorders like the obesity is also increasing. So they are the reasons that we are getting more of HFpEF patients now. But on an average, 50% of patients have HFrEF and 50% have HFpEF. A word about CKD. CKD impacts 1 in 10 people globally. 2.6 million people receive renal replacement therapy. Many developed nations spend a lot of money on that, and this incidence is going to increase in 2030 to up to around 5 million. Now there is a close association between cardiac and kidney pathology, as we all know. Chronic heart failure, there can be genetic predisposition, environmental risk factors are there, and low cardiac output and calcification in the endothelium can actually increase the atherosclerosis and eventually also the kidney damage. There can be chronic hypoperfusion, increased venous pressures, and eventually the progression of the kidney disease is there. So they are interconnected. And to add insult to an injury, there is anemia, metabolic abnormalities, volume overload. As we all know, anemia is a big contributor in heart failure. As per the iron CRT trial or FAIR HF trial or FMHF trial, it has been clearly mentioned that if you correct the anemia in patients of heart failure, especially with the ferric carboxymaltose, then I think the patients, they have a lesser morbidity and mortality and lesser hospitalizations as compared to patients with other heart failure. The cardiovascular events, they lead to increase in incidence of CKD, and CKD increases the cardiovascular. There is a vicious cycle. And if you look at CKD patients with heart failure, they are all interconnected, whether patients have HFpEF or HFrEF. As you can see in this diagram, there will be a significant difference between the patients who are CKD versus non-CKD, whether they have heart failure with preserved ejection fraction or reduced ejection fraction. What about diagnosis? Now this is an important slide for heart failure. Now most important thing is to suspect heart failure by the risk factors, like the patient is diabetic, obese, and cardiac disease is there, family history is there, smoker, and hypertensive, atrial fibrillation. Symptoms and signs, we all know. Symptoms and signs are very easily picked up. We should understand that symptoms mean orthopnea is a very significant symptom, PND is a very significant symptom. At times, bend apnea is a common symptom. Patient bends, maybe for tying his shoelace or for any reason, for picking up something, he bends and he gets breathless. That is bend apnea. At times, there is platypnea. The patient lies down on the left side and gets breathless. So these are the major symptoms. Apart from the ascites and peripheral edema and breathlessness and all the other symptoms, they are non-specific symptoms. As per the ECG is concerned, we look at left ventricular hypertrophy on ECG and a history of old MI and evidence of an old MI, especially anterior. Look at LBBB, look at atrial fibrillation, LA enlargement. These are the findings which we look at in the ECG. Now, NT-proBNP is a very significant marker for diagnosis of HFpEF or HFrEF. In fact, in heart failure with reduced ejection fraction, NT-proBNP levels are even more raised. In fact, in many of the studies, it was concluded that if the NT-proBNP levels are 1382 or more, just a cutoff, say 1400, I'll say, then the mortality, it actually triples. So we have to try and target the NT-proBNP level lesser. So 125 nanogram per ml is the usual dose for NT-proBNP, which is better, NT-proBNP or BNP. So naturally, NT-proBNP is a better marker to diagnose or to treat heart failure. BNP is not very specific, and it is metabolized by the neprilysin enzyme also, in RNA in particular. So that can actually change. So it is not very reliable for diagnosing heart failure. Echo is a very important parameter. We all know that. HFrEF is a very easy thing to diagnose. Anybody can diagnose, although there can be an inter-observer variability of around 40-50% on echocardiography. Diastolic heart failure can be diagnosed by diastolic parameters like E by E prime ratio, and then LV filling pressures can be looked at, and there are various other parameters. But more importantly, I'll come to the, eventually after diagnosis with clinical thing with the NT-proBNP, with the echo, we come to diagnose the type of heart failure. And as per the American College of Cardiology, heart failure with reduced ejection fraction is ejection fraction less than 40%. Mildly reduced ejection fraction is 40 to 50%, and more than 50 is improved, rather preserved ejection fraction. But there's something called as improved ejection fraction. With the advent of ARNI and SGLT2 inhibitors and various MRA, and I'll come to that, the ejection fraction at times improves in many of the patients, which you might have seen in your practice. So what is improved ejection fraction? That is, to begin with, the ejection fraction is less than 40%. There is a 10-point or more improvement in ejection fraction, and eventually the ejection fraction is more than 40%. So suppose to begin with, the patient has an ejection fraction of 32%, and then there is a 10-point improvement, say around 42% it becomes, and eventually ends up being more than 40%, then it's an improved ejection fraction. And I think we can see more and more patients of improved ejection fraction. Here it is the same classification, 40, 40 to 50, and more than 50. But it doesn't mention about improved ejection fraction. That also is an entity. Definition and diagnosis of heart failure with preserved ejection fraction is very challenging, as we all know. There are a lot of comorbidities which can mimic that. BNP levels at times can be misleading, especially in CKD patients. And echo has an inter-observer variability because the ejection fraction is always an inter-observer variability kind of thing. Somebody might say it's 40, somebody might say 45, but still I think we'll have to take up the challenge. All heart failure subtypes may exhibit similar signs and symptoms. As I've mentioned, whether HFpEF or HFrEF, the symptoms are similar. The symptoms are not lesser or more. In fact, I'll tell you about a patient of an angioplasty. I did an angioplasty. Despite the angioplasty, after 5 days, she came to me. This lady had severe breathlessness. She could not walk to the echo room also. And when I saw an echo after 5 days of an angioplasty, which was a good result, she had a severe MR. And ejection fraction was around more than 60%. I started her on SGLT2 and ARNI, and within 5-7 days, she was absolutely fine. MR had also gone, zero MR. So many a times we don't suspect, that's why we don't see. Now, what is the evidence for expanding role of SGLT2 inhibitors in CKD management? As has been mentioned, it blocks the proximal glucose and sodium reabsorption, and naturally there is no hyponatremia because there is something called the SGLT2-1 also, and the sodium gets reabsorbed in the distal tubule, so there's no hyponatremia. And there is increased sodium delivery to macula densa, and eventually there is a tubulogranular feedback which decreases the intragranular pressure and decreases the proteinuria. DAPA CKD was an important study which included around 4,300 patients. 32% patients were non-diabetics and 68% were diabetics. And it was quite safe. There was an all-cause mortality reduction of 31%, 39% reduction in the composite endpoints of renal disease progression like ESRD and eGFR decline. 29% decrease in heart failure and cardiac mortality also. So it was a wonderful study, and it can be clearly given in patients with heart failure. DAPA-HF is one of the first and largest study of SGLT2 inhibitors, and it shows that in 4,700 odd patients, You can see the similar outcomes, 26% decrease in heart failure as well as cardiac death. And the number needed to treat was hardly 19 to 20. So that's a quite significant number. And renal benefits were also passed on in the DAPA-HF study. As you can see, the benefits were seen as early as 28 days. In DAPA-HF, 21% risk reduction in sudden death also. Now, this is a significant finding as per the ARNI also has shown that 20% reduction in sudden cardiac death. Now, this is an important parameter because in early stage of heart failure, there can be more sudden cardiac death. Preserve-HF study was a study of DAPA and on biomarkers in preserved ejection fraction patients. Inclusion criteria were like this, but most importantly, they looked at the Kansas City Cardiomyopathy Questionnaire, KCCQ score, and there was a 6-point improvement in the score. Better the score, higher the score, better the patient. 6-minute walk test also improved by 20 points. As you can see, generally there was a very large or moderate improvement in patients' quality of life. And I think in our practice, quality of life is a very important parameter to judge the diagnosis and the treatment of a doctor. So I think it's very important for all of us. Safety has already been covered. It was quite safe. Except for volume depletion, there were no major issues. There were no fractures. There were no amputations, no CKD progression. In fact, there was a protection of 50%. No increase in genitourinary infections, no UTI. So it was quite safe. So dapagliflozin significantly improved symptoms and physical limitations in patients with HFpEF in just 12 weeks. The treatment effect was large. Effects were consistent across all age groups of patients and all subgroups of patients. It was very well tolerated. Now a word about DELIVER study. DELIVER is one of the largest studies. In fact, apart from this 17,000 patients, this had around 6,200 patients. DAPA versus placebo was compared, and what they found, it is the most contemporary clinical trial, and they found that improved ejection fraction patients who were hospitalized or off therapy were included. And the primary analysis showed that adequate power in both the full studies population and the subpopulation also. Completed by March 22, and the detailed results will be available by August this 22. But it has shown that it again is consistent with the other studies. Here you can see by 5th May, I think that there was a significant improvement in heart failure, hospitalization, and CKD progression in the studies. The guideline update. This is an important slide. 4 foundational drugs start with an ARNI or an ACE inhibitor, ideal in ARNI, a beta blocker, whether bisoprolol or carvedilol or metoprolol, MRA and DAPA or EMPA. Any of these, all these 4 should be added within 4 weeks. This is a very, very clear indication as per McMurray et al. And Milton Packard et al. LVF less than 35%, narrow QRS can consider an ICD implantation, broad QRS can consider CRT implantation. Sinus rhythm, continue with this. You can see at any stage of heart failure, as per the diuretics are anyway needed, but you can see at whether stage A to maybe B or C or D, whichever stage of heart failure is there, SGLT2 can actually be given. But if you can look at more than 50%, beta blockers don't have that much role. But lesser the ejection fraction, beta blockers have more role. And ARNI also doesn't show major benefits if ejection fraction is more than 60%. But SGLT2 inhibitor is one of the drugs which can actually be given in all kind of patients of heart failure. As you can see here, all drugs, diuretic, SGLT2, ARNI, MRA and ARB can all be given in ejection fraction more than 50% or equal to 50%. So this again, as mentioned, the 4 foundational drugs which have been shown to increase, decrease the mortality and morbidity should be added as early as 4 weeks, because if you go by conventional method, you start an ARNI first or maybe then wait every 2 weeks and try to increase it. That takes around 6 months. And most of the rehospitalizations, they occur within first 3 months of heart failure. So ideally, you should start a lower dose of each of the 4 foundational drugs. Then I think you can achieve a major reduction in the morbidity and mortality rehospitalizations. What Milton Packard and John McMurray suggested is start with a beta blocker and SGLT2, and then within a week or 2 start with an ARNI and then an MRA. But it can actually be, vice versa also. And one important thing, ACE inhibitor and ARNI generally should not be given in hyperkalemia, where SGLT2 actually can be given. ARNI doesn't have major data with ejection fraction less than EGFR less than 30%. But yes, we have EMPA up till 20, DAPA up till 25. So to just summarize, any patient with glycemic status, whether with diabetes or without diabetes, can all be given this drug. And mean EGFR was 85 to 66 to even 43 in DAPA CKD. And this molecule is here to stay. It will decrease the heart failure, hospitalization, and cardiovascular deaths. And more importantly, the eGFR decline and ESRD progression also is decreased. Thank you.
Thank you, Dr. Nitin Tiwari. Timely you have finished it. One question from me. That patient has cardiac problem and renal, no diabetes. Can we use
Yes,
SGLT2
you can use.
inhibitor?
You can use.
Without
Especially with a
diabetes?
heart failure patient, there is enough data which we have. If the patient has a cardiac issue, you can always give. GLP-1 agonists are better if it is a cardiac disease, not a heart failure. SGLT2 inhibitors generally have more effect on heart failure. It's a class effect. And I beg to differ from the previous speaker about DAPA. I think EMPA also has enough data about cardiac heart failure reduction. But yes, cardiac mortality reduction is with EMPA as well as DAPA both. In fact, EMPA was the first. EMPA-REG outcome showed more cardiac mortality reduction, 38% mortality reduction with EMPA-REG outcome trial. So I think both are good. Yes, this canvas study and this canagliflozin is slightly behind EMPA and LINA, and both EMPA and DAPA are recommended by the American College of Cardiology also. So any patient with heart failure, whether irrespective of diabetic status, you straight away start an SGLT2 inhibitor. The reason being that it is a very easy drug to give. You don't need to monitor potassium. There is no hyperkalemia. There is no hypertension. If you compare an ARNI has 17% chance of hypertension, 11% chance of hyperkalemia, 12% chance of increased potassium, which is not there with this molecule. Just have to look at volume depletion. The diuretics you can decrease. You don't need to titrate also straight away. 10 mg is the dose, whether EMPA or DAPA. Straight away start with the 10 milligram OD dosage. You don't need to gradually increase it unlike in an ARNI. So I think it's a wonderful drug.
I welcome question from the audience.
It's same, yes. HFpEF or diastolic heart failure, they both are same. The only issue is it's a difficult thing to diagnose. Many a times you have to suspect. And I think in such patients, echocardiography is normal, and many a time you neglect that, okay, it is not a heart failure. But I believe you can look at NT-proBNP levels in such patients, and many a times it is in thousands. So you can always diagnose that.
Just eco-wise, I was asking one question about diastolic heart failure. In your busy schedule, just 2 or 3 parameters, can you tell which we should, as a physician, what we should
LA volume
for
index,
diagnosing?
LA volume index, LV end systolic volume index, E by E prime ratio. These are the parameters. LV posterior wall thickness, LV mass. There are many parameters which we can look at. You can advise to get a look at diastolic heart failure to whoever you are advising in echocardiography. Just tell them you have to look at diastolic heart failure.
No, I am myself doing echo.
Oh, then that's great. And that's a wonderful thing.
Okay,
So look at LA volume, LV volumes, LV end diastolic volume, LV end systolic volume, LA volume around more than 34 ml per meter square, LV end diastolic. You can always calculate that. But more important is E by E prime ratio. You can look at septal wave, lateral E wave, septal E wave, get a ratio of them. I think that is good enough. Thank you.
Thank you, sir. Now we will hand over mic to the chief
Thank you so much, sir. I request Dr. Rajiv Povil, sir, please come on the stage and felicitate Dr. Nitin Tiwari, sir. And now I request Dr. Nitin Tiwari, sir, please felicitate our chairperson, Dr. Nalini ma'am. Thank you so much. Now I welcome our next chairperson, Dr. Sanjay Ambatkar, sir, and Dr. Praveen Panch, sir. Please come on the stage, sir. Dr. Sanjay Ambatkar, sir, is a MD Medicine Consultant Physician, Director, Kalparoots Hospital, Life Member of IMAMS, CSI, DSI, and SCCM. And Dr. Praveen Panch, sir, is MD Medicine, DNB Medicine, and is at the Prana Hospital, NABH. So over to you, sir.
Thank you. Good afternoon. Thanks to Dr. Sunil Gupta for giving us this opportunity. Till now, We have already listened to the 4 presentations on dapagliflozin. Now let me invite Dr. Rajiv Kovil and Dr. Tejas Shah to initiate their dialogue. 10 reasons why affordable dapagliflozin transform the diabetic care. Over to you, sir.
So much, chairpersons, and thank you all of you all here. This is how was ADA?
ADA was good, tiring, hectic, but because the sessions were good this time, many new things again to learn.
Okay. Worth the money?
That's a difficult question to answer. Yes, it was when we were going after 3 years post-COVID. Things have changed in US. That's what we realized after going this time.
And the shopping was expensive.
Things were very expensive, but the traveling was a bomb.
So that's the reason I didn't travel, because I think that things have become too expensive, and I think it's very important that cost is a very important factor. Unless you have 2 doctors, one is a urologist and one is a diabetologist like Dakshata is. How many of you all believe that affordable SGLT2s have transformed diabetes care? Can we have a show of hands? Only for all of us, so we don't have anything to do. We can close the session. What do you say? Everybody believes.
So we already have a winner, I think, Rajiv. That this is what some people of India were waiting for, I think. The best of molecules at the best of cost if we get. I think things turn out very easy for us to treat our patients.
Absolutely, complete. If you look at this, that the trajectory after 2021, when DAPA has come in, you can see there's a 7-fold increase. Where were all these doctors when they were branded gliptins? So they created 7-fold more prescribers for gliptins, the generic DAPA. So it's been a boon for all of us. Also, if you look at the combination of DAPA, this is probably the 4th talk of dapagliflozin in the series. That's why we have got completely non-scientific talk. We are completely non-scientific people. We never talk science. We bullshit all the time, and that's what we get. DAPA plus metformin is 3 times. What do you say, Tejas? How much has your percentage increased in this?
So if you go back even one and a half year, we all were scared of using this combination because of the cost. We were all talking about the side effects. We were worried about the impact it will have. Patients will continue or they won't continue. But suddenly when we got this same molecule, the same combinations at a rate which is affordable, I think it turned the tide completely. Now we are not worried about the compliance. We are not worried about the adherence. We know patients are going to continue this for a longer period of time. And that's what is important.
How many of you all believe that the recommendations in the algorithms to use SGLT2s are strengthening after year after year? Can we have a show of hands? It's only one person, so we have to now convince the rest of the people. So that's easy, because if you see ADA 2022 makes a very, very important statement that it's even in patients, forget about patients who have not having these problems, but these patients who are high risk for heart failure, chronic kidney disease or ASCVD, independent of baseline HbA1c was always there, or the use of metformin is added. So earlier if you were on so this was what the ESC had said in 2019, that this should come earlier. The ADA also says the same. And in our poorer market, they say that cost, the Indian companies have given us best medicine. What's your take on the cost is no longer an issue?
Yes, we were always, whenever we used to talk about these guidelines, then when we used to come to this last column of cost, we used to then rely on sulfonylureas and pioglitazones. We were always saying that is where they are the saviors for our patient, and that's where we need to use them first. But now with an affordable SGLT2 available to us, I think slowly we are moving away from the older drugs, and we are going towards bombarding our patients with the best of the drugs, with the newer drugs like SGLT2s or dapagliflozin from the very beginning, with or without metformin. That's what the ADA 22 also has emphasized it.
Only problem is that the cardiologist thought of it first before we did. So in 2019 only they came up with this guideline that it should supersede metformin. We did it 2 years later, but still, we should have done it earlier. Again, possible reasons for the SGLT2 surge and strong recommendations in India. Obviously,
one thing is clear,
this is one reason, that there is a lot of cost that is saved. The combination again saves cost. And if you look at all these things put together, a lot of effectiveness, durability, because we all know that we are an out-of-pocket country, and if we can have good, affordable, accessible, cheaper medications, we can see more number of patients and we'll have more number of credibility with our patients also. And
this talks about the availability aspect. We are always again worried that it should be easily accessible to our patients. The drug should be available at each and every corner of our country. That is important. Our population is staying in different villages, and where we were always skeptical about the availability of these newer drugs because MNCs couldn't reach at these places. And that's where our Indian companies have been able to do this. Now we have a basket of combinations, not only with dapagliflozin, but we are going to have dapa plus vilda, dapa plus sita, soon dapa sita met combination. And so an ideal way of treating a diabetic patient is something which is there in our basket and available at every corner of our country is what we are going to get.
I agree with you. Only Cyrus behind is not looking up, but that's the truth that a lot of Indian companies are taking over. And DAPA for me is like soda. You have it with whiskey, you have it with vodka, you have it with brandy. It is very, very good. So whatever combination you do it with, and you have that kind of SKUs which are coming in as such. And we are not only talking about just about cost here. So a lot of data. If you look at Declare, DAPA HF, DAPA Secret, Tejas, you want to go through the data?
Yeah, so if you look at the trials which came in when dapagliflozin came in, Declare came in first. That was the largest of the trial at that time with 17,000 patients approximately. Uniqueness of Declare over the other two trials which came before that was that it had 40% of the patients with multiple risk factors and almost 60% with established CV disease. So we were treating patients who we see in clinical practice on our OPD basis every day. Those were the kind of patients that were there in Declare. And the result was there to see, showed a 17% relative risk reduction in terms of the hospitalization for heart failure was reduced more by almost 30-35%. For patients who had multiple risk factors, there was it showed non-inferiority, but it showed superiority in terms of CV that for patients with established CV diseases. Followed by DAPA HF, again came in, that was the first trial that came in with patients with diabetes as well as patients without diabetes, with patients with established heart failure. So that was the first trial that came out and it showed wonderful result.
Absolutely. And then the DAPA CKD came at the background of Credence, and the difference was the primary endpoint where Credence had an endpoint of doubling of creatinine and this had an endpoint of 50% reduction in EGFR. Importantly, DAPA CKD had a lot of patients below a EGFR of 30, and they had around 14% below EGFR of 30 and around 11% above an EGFR of 60. Majority was stage 3 chronic kidney disease, and what it showed is that apart from progression to harder end stage kidney problems, which is dialysis, transplantation, they also had emergent benefits in the heart, and that's what is crucial. And the feather in the cap for DAPA CKD, if you compare it to Credence, was the all-cause mortality. The all-cause mortality was different because the all-cause mortality was not seen in Credence. Probably if you had taken them longer, it could have. Again, when we see a cardiovascular study or a chronic kidney study, and it is again re-emphasized with a real-world evidence which shows similar kind of picture. Whether it's the blood pressure reduction, the A1C, the EGFR, and the BMI as such. And if you look at all the CVOTs which DAPA has done up with, right from, so the Declare told us that we could prevent new onset heart failure. The DAPA HF told us that we could treat patients with heart failure. And now we have the top line results of Deliver. I think at the ESC you will have the complete thing coming in. Top line results said even in patients with HFpEF, there is tremendous reduction in the 3-point MACE and again mortality. So you have a drug which has all the scientific evidence, and I believe at 1/4 the rate of the branded gliptin as such.
There was another again data which came up with dapagliflozin which talked about the benefits in patients with reduced ejection fraction. The earlier studies which were there had patients where established reduced ejection fraction may not be there or that was not clearly defined. But there were dedicated studies here, like DAPA-HF was shown. There is the preserved heart, where patients with preserved heart failure were there. There is the DELIVER trial which is coming up or which is ongoing, which shows data with patients with preserved ejection fraction. That means between 40% to 50%. And those were the patients who were enrolled in this study. And the interim analysis of DELIVER study is also showing great promising results.
And again, as Dr. Tiwari and earlier Dr. Advani, all of them emphasize that now an anti-diabetic drug from earlier has now come into the armamentarium of cardiologists and nephrologists and is one of the 4 pillars in treating HFrEF at least. And you also have data which will come with dapagliflozin in acute decompensated heart failure and in acute MIS cells. And again, I spoke about the renoprotective effect of DAPA-CKD and how it can be treated in patients with diabetes, without diabetes, non-diabetic chronic kidney disease, and especially in IgA nephropathy. There are more than 1,000 patients in that particular study.
So this is following which the ADA addendum this time in May 2022 has added this, that for patients with type 2 diabetes and diabetic kidney disease, use of an SGLT2 inhibitor even at a GFR of up to 30 is permitted. And for DAPA has this recommendation already there that you can use it for patients at a GFR of more than 30.
We're not going into details. We know that, as I said, it's like soda, you add it to anything and the sugar goes down. And we all know that. But apart from that, also heart failure goes down, chronic kidney disease goes down, BMI goes down, there is fat loss, and all those stories of urosepsis, Fournier's gangrene, euglycemic ketosis are all buried because a lot of these studies have not outcome studies. They actually look at a lot of adverse events and none of them have shown that. Again, if you go through the SKUs, you have a lot to choose. So all the Indian companies are going to come up with a software because we won't remember the names in future because there are Jalra D, Jalra DP, Jalra DPC. So it will be very difficult, but they believe we'll come up with a software which will help us do this. But a lot of FDCs, and we are the FDC capital of the world. Another audience poll is that how many of you all will consider DAPA combinations of DAPA metformin as your first drug in drug-naive patients. Also going ahead that you will have DAPA-CETA also coming in, you will have DAPA-CETA-MET also coming in, and I believe DAPA-SU is also going to come in and DAPA-SU-MET may come in, I don't know. So how many of you all would use combinations as first line therapy? Irrespective of
the baseline, A1C baseline.
So Dakshata is the only person. All the rest will again be starting because earlier we were not using these drugs because there's a specific indications and we were told that you could use it only when the cost is an issue. Today we have strong evidence, we have strong data, and we also have cheaper drugs. So it's important that we give these benefits to our patients. These are all value added benefits because at this ADA, though I couldn't afford to go to the ADA, I listened to it, and one of the debates at the ADA that what is the primary target in people with type 2 diabetes? Is it weight loss of 10% or an A1C of 7%? And very interesting debate that if you get down your weight by 10% and look like Rajesh Rajput, you will get your HbA1c below 7%.
Yeah. There were sessions which argued about whether obesity is the thing which should be treated first now in diabetes or it's just the blood sugar.
Yes.
So that is important. So adiposity and Asian Indian phenotypes are well known. We have a different in terms of, and when we compare ourselves to Caucasians, and that's where the importance of multiple therapies in the very beginning becomes more important. And of course, there are various clinical other benefits that we are getting for SGLT2s. Now we are seeing the usage, the basket increasing in patients with NASH, for patients of prevention of kidney disease. The DAPA-HF showed data that it could help in prevention of diabetes also. It prevented new onset diabetes in DAPA-HF data. So multiple new indications are going to come up in the future is what we are going to see for ahead.
This bell is like the quote, reminding us that we need to go. So there's dapagliflozin, we know have a lot of benefits. We'll go fast, and as I was telling you that you're going to have a lot of data coming in acute situations where you have DELIVER is scheduled next month, sorry, in September. You have things with acute MI, which is DAPA, MI. You have in atrial fibrillation. You have in lean people with NASH. So there are a lot of data which will come in this particular segment, and probably the end result is that our patients will get a lot more of these drugs, and we will put patients first here, and probably the benefits will go to a lot more patients that we have today. So the last poll, we are sure that we have more than 10. Do you want to quickly mention that, Tejas, because I have Alzheimer's?
I think we have covered them all, yeah.
So we have 10 reasons we gave you that we should be using dapagliflozin much higher. The 7 times rise of dapagliflozin clearly tells that India has accepted the generic dapagliflozin much better. Again, how many of you all believe that the combos are going to improve the quality of diabetes care in our practice? Hand show. So I think everybody believes in that, and that's extremely important. Tejas, would you like to close?
No, I think, I hope we have been successful in putting through the point that we wanted to, that we have got a molecule which is having all the benefits in terms of cardiovascular risk reduction, heart failure, hospitalization, renal benefits, glycemic control, weight loss, and blood pressure reduction at a cost which was not affordable to most of the patients in India, but now we can reach as many as possible and give them the benefit as early as possible.
Thank you all for a patient hearing. Thank you so much.
Thank you.
Thank you, Dr. Govil and Dr. Tejas Shah. We had such a wonderful duologue. We feel it's not just duologue, it was like all the audience was also involved in that thing. So I thank you, Dr. Govil and Dr. Tejas Shah, for that. Thank you. Thank you for organizing such a wonderful Hello Diabetes Academia and inviting us as a chairman. Thank you very much.
To felicitate our dashing duos from Mumbai, Dr. Rajiv Chawla and Tejas Shah. Sorry, Rajiv Govil and Tejas Shah. Sorry, extremely sorry for it. And also will request our speakers to felicitate our chairpersons, Dr. Pant and Dr. Sanjay. And to move ahead, would like to invite the chairperson from the next session, Dr. Prasad Jode and Dr. Sunil Kumar. Will request Dr. Prasad Jode and Dr. Sunil Kumar to come on the desk and proceed for the next session.
We are thankful to Dr. Sunil Gupta and the team of Hello Diabetes Academia to give us opportunity to chair this session. Dr. Rajesh Rajput sir is Senior Professor and Head Department of Endocrinology, PGI MS Rohtak. Now, as we are lagging behind, without wasting much of the time, I request esteemed speaker, Dr. Rajput sir,
Thank you very
to
much.
go ahead for the talk. Sir.
Right. So, good afternoon, ladies and gentlemen. Well, you have listened 10 reasons to prescribe dapagliflozin. I think the 11th reason is that this is a 4th lecture in a session only on dapagliflozin. So obviously you have probably listened lot of time, same things in a different ways. So I am not going to be a new one, but I am going to put the things in perspective and will give you some evidences which will tell you that where actually the molecule can be used, although it has already been discussed that presently in patients of type 2 diabetes, right from newly onset type 2 diabetes to patient with multiple comorbidities, we have now enough evidences that SGLT2 inhibitor and that too specifically dapagliflozin can be used. Now when we have to manage patients of type 2 diabetes, what is our goal? When we were students, we were taught only goal is to manage hyperglycemia. And that too, goal is not known to which degree we have to reduce glucose. But over years, we have learned that management of diabetes is not control of glucose, but to prevent complications. And we have learned that these goals are control of glucose, which we were taught. Then these goals should be met with safety. That is, patient should not develop hypoglycemia, should not have weight gain, and should not have other side effects. Patients of diabetes, because of common soil hypothesis, have number of metabolic complications. So all these metabolic complications has to be controlled simultaneously, and long-term control of comorbidities has to be done. So the entire paradigm of management of diabetes has changed over last 20 years, and that is why diabetes has become a subject in itself. What should be the properties of an ideal anti-diabetic agent in type 2 diabetes? I have tried to summarize in this slide, and if you go through this slide, that is control of glucose, insulin independent secretion, risk of hypoglycemia, probably still we do not have an ideal anti-diabetic agent. Scientists are still searching for it. And this is a very interesting data which very few of you might have seen, that before DPP-4, GLP-1 and SGLT2 era, if we see previous drugs which were used to manage diabetes, the amount of risk removed and residual risk remains. Now concentrate on these two columns and see the comorbidities. With the traditional drugs which we are using for management of type 2 diabetes, as you see clearly, the residual risk for heart failure is 100%. For 3-point MACE, 91%. For MI, 85%. For stroke, 96%. For CV death, 110%. Which means whatever we are actually talking of now, all the evidences have generated in last decade. Before that, we do not have any evidence, and that is why management of glycemia has changed totally. I will not discuss this slide in detail. SGLT2 inhibition, we know they have number of properties apart from glucose lowering, but important property is, this patient is losing a molecule of glucose into the urine, and each molecule of glucose is equivalent to 4 kilocalories of energy. On an average, irrespective of SGLT2 inhibitor which you are using, on an average, 80 to 120 grams of glucose is lost. You multiply it by 4, 80 into 4, 320. So on an average, 320 kilocalories of energy is going to be lost, which means some weight loss is going to be observed in patients of type 2 diabetes when we are using this class of agents. They have glucose lowering efficacy on board, whether you use comparison to placebo, as an add-on to sulfonylurea, as an add-on to DPP-4, GLP-1RA, with whatever drug you are using. They causes weight loss, and they have a beneficial effect on blood pressure also, which means they have pleiotropic benefits. So moving from there, initially I still remember the initial launch of dapagliflozin in one of the EASD, when actually the drug was launched as an anti-diabetic agent. From anti-diabetic agent, the drug has moved now to an agent which can be used in patients of type 2 diabetes with multiple comorbidities. And we have to look at the data. 3 important data sets which have appeared, DECLARE. We will not discuss them in detail, just we'll go through them quickly because these have already been discussed. DAPA-HF and DAPA-CKD. Now in DECLARE TIMI58 trial, if we see, patients were given dapagliflozin 10 milligram and compared with placebo. And what is the primary endpoint? The primary endpoint is combined 3-point MACE and cardiovascular death. When they have looked at this combined endpoint, they have shown superiority by 17%. In contrast, 3-point MACE only shows non-inferiority. At the same time, these were not primary endpoint, but in exploratory analysis, it was observed that there are benefits in reducing renal endpoints also. This is the story from where actually renal trials started, that the drug might be doing something good at the level of kidneys also. And then when they have done risk stratification based on whether patient has multiple risk factors or established atherosclerotic cardiovascular disease, irrespective of that, the benefit for hospitalization for heart failure and reduction of renal endpoints is observed. Now, based on this, some important information, and this is by Subodh, where he has given this beautiful diagram and used by a number of speakers, that dapagliflozin can be used across spectrum of patients of type 2 diabetes. If you see the benefits of dapagliflozin, this slide will summarize. That is, if you want to see its benefits on 3-point MACE, you will not observe in those who does not have an established cardiovascular disease. Those who have a prior MI or those who have an MI more than 2 years ago, means have an established ASCVD, there is benefit in 3-point MACE, and number needed to treat is only 38. At the same time, if you see benefit in terms of hospitalization for heart failure and renal benefits, they are seen across the spectrum of type 2 diabetes, irrespective of the fact that they are having established ASCVD or only risk factors. And here NNT is 53. Moving there, DAPA-HF trial. Now, DAPA-HF trial, drug is tried in patients irrespective of the fact whether they are having type 2 diabetes or no diabetes. Now, what DAPA-HF has shown, it is one of the largest trial with SGLT2 inhibitor in patients of heart failure with reduced ejection fraction. 45% of the patients were having type 2 diabetes. 55% of the patients were having no diabetes. And what has been observed, 26% relative risk reduction in hospitalization for heart failure with superiority, and NNT is 21. What is important is that the benefits are observed across different class of agent, irrespective of background therapy, diuretic use, anti-pro-BNP, baseline ejection fraction or EGFR, which means again across spectrum of heart failure, when dapagliflozin is used, it has shown its benefits as well as its safety. Now, moving from, on basis of this, US FDA has approved class 1 indication for dapagliflozin, and I will come to this point again when we come in real practice, when to add in patients of heart failure SGLT2 inhibitor or dapagliflozin. Now, DELIVER is another step. DELIVER is a trial where SGLT2 inhibitor, that is dapagliflozin, is used in patients with preserved ejection fraction. And if you remember, currently there is no approved therapy which is going to change the outcome of patients of heart failure with preserved ejection fraction. In this group of patients, this is summary of entire trial which I have tried to do on a single slide. As Raji has told you in last lecture, next month final results are going to come, but on net it has been shown that Forxiga, which is actually the innovator molecule for dapagliflozin, has met its primary endpoint, which is reduction in composite of cardiovascular death and worsening for hospitalization for heart failure in patients with preserved ejection fraction. Mind you, there is no drug which has proved to be beneficial in this group of patients. So based on this, across spectrum of HF patient, again probably SGLT2 inhibitors can be used. Third evidence, DAPA-CKD. Now, why this drug is beneficial in patients of CKD? Again, I have tried to highlight number of mechanisms through which the drug is beneficial in preventing the progression of CKD. Mind you, after 2000, when we have ACE and ARBs, there is no new drug which can change the outcome of patients with CKD. And ACE and ARBs act on efferent side of the tubule. There is no drug which is actually acting on the afferent side of the tubule. SGLT2 inhibitor are acting on afferent side of the tubule. So this is a new drug in therapeutic armamentarium for management of CKD patient. Again, this is a design and the results of DAPA-CKD. As you see, 39% relative risk reduction in composite outcome, and then there is a significant reduction in individual endpoints, and that too at a safety which is almost comparable to placebo. So third important indication where the drug trial has to be stopped prematurely, and it is recommended that the drug is to be used in all patients of CKD irrespective of their glycemic status. The next important question is, in what type of CKD patient can we use it? CKD can be caused by glomerulonephritis. It can be caused by ischemia or hypertension. Now, in this paper in their Lancet, they have shown irrespective of etiology, that is whether it is chronic glomerulonephritis, ischemic nephritis or hypertensive chronic kidney disease, drug is found to be useful. Thirdly, based on these evidences, again drug has been given approval. Very recently, this publication has come up, dapagliflozin used in non-alcoholic fatty liver disease. Obesity is prevalent in patients of type 2 diabetes. More than 80% of the patients are either overweight or obese. And doing ultrasonography for so many reasons is not uncommon. And patient comes with NASH, that liver mein fat jama ho gaya. For this again, this is a gray area where we do not have any approved medication except loss of body weight and in some indications pioglitazone and vitamin E. Now in this research paper they have shown that with use of dapagliflozin there is decrease in liver fat, there is improvement in enzyme, although whether it is going to reduce the fibrosis we are still not clear, but definitely we have positive results in this direction. Another important area, especially again in type 2 diabetes, is OSA, obstructive sleep apnea, which is again as a result of overweight and obesity is quite common. Now this is again a very recent publication where it has been shown that with use of dapagliflozin there is improvement in apnea hypopnea index, which is a measure for obstructive sleep apnea. So friends, there is an evolving indication where we can use dapagliflozin across spectrum of disease, but what we have to remember? We have to remember that for what indication you are choosing the molecule. If you are choosing this drug for reducing glucose, that is control of glycemia, then it is best effective with eGFR more than 60 ml. If patient's eGFR is less than 60 ml, then glycemic lowering potency is almost close to placebo. Your glucose is not going to come down. If you are using for pleiotropic benefit, you can use the drugs for eGFR up to 30 ml. Then glucose control is not going to happen with the drug. For that you have to take help of some other medications. So you have to choose your patient, you have to measure your eGFR, and then you have to expect the benefit out of these drugs. Now based on these evidences, you have seen in the first lecture, now in 2022, the guidelines has modified slightly. Initially there is only one column of ASCVD/CKD. Now what they have recommended, if you have ASCVD, then you have two drugs. If you have HF, SGLT2 inhibitor is drug of choice. If you have CKD, irrespective of proteinuria or no proteinuria, SGLT2 inhibitor is drug of choice. If you want to prevent hypoglycemia, again SGLT2 is figuring. If you want to avoid weight loss, again SGLT2 is figuring. And cost, where this is ADA guideline, so they recommend only SU and thiazolidinedione, but with availability of generic drugs now, probably SGLT2 also should be figured here, at least for our country. If we see this guideline from American Heart Association, across spectrum of heart failure, right from stage A, B, C and D, and irrespective of ejection fraction, again SGLT2, right as a class 1 agent to class 2A agent is recommended across spectrum of these patients. How to use it? This is a very important question because these are established therapies, ARNI, beta blocker, mRNA and SGLT2 inhibitor. Which drug is to be used? Now this is a wonderful paper published by McMurray et al. That we should not wait much. If you see as a step 1, when we see a patient of heart failure, we should initiate them on beta blocker plus SGLT2 inhibitor. Within 2 weeks, we should go to a next step, which is ARNI. And then within next 2 weeks, we should add MRA, which is aldosterone or eplerenone. That is how the addition of drug in a patient of heart failure with reduced ejection fraction should be done. This is 2023, which still has not come, but this recommendation has been given to Kidney Society, where they are now recommending that SGLT2 inhibitor again should be added as a first-line therapy in patients to prevent progression of CKD. So I am showing you even the evidences which has not published as of now. Now lastly, to summarize, new mantra for management of type 2 diabetes is prescribe SGLT2 inhibitor, control glucose with eGFR more than 60. If your eGFR is less than 60, patient has comorbidity and you have to protect heart and kidney and has to save life. Again, SGLT2 is a new mantra for type 2 diabetes. Thank you very much.
Thank you, Rajput sir. It's a wonderful talk. Really, this DAPA becomes soda. और इतना सोडा कि लग रहा है ये मैजिक बुलेट जस्ट लाइक एस्पिरिन जब स्टार्ट हुआ था इसेमिया सो दिस डापा ऑल्सो बिकम मैजिक बुलेट ऑफ दिस डायबिटीज मेलाइटिस सो डापा कुछ दिन में हो सकता है कि इसको सोडा ही बना दे या पापा बना दे क्योंकि इसका नाम ही प्रोनाउंस करना इतना मुश्किल है कि इंडियन फार्मास्यूटिकल कंपनी हो सकता है डापा को पापा बना दे या सोडा बना दे जैसा अभी राजेश सर ने और तेजस ने बोला कि और इट इज़ रियली ए वंडरफुल ड्रग एंड बुलेट ड्रग
It's a wonderful drug, but the only problem is like DPP4 inhibitor, this drug has got some side effects also. For where physicians has to be educated and even the patient has to be told how to use this drug, how to monitor about those side effects. Now that is only other side of the story, which unfortunately with DPP4 nobody is looking for any side effect. So this is another side of the story that we have to choose patient carefully. We have to look for some side effects. If those can be managed, definitely based on data, this is a wonderful drug.
Thank you, sir. Thank you, sir. As we are running a lot of time, so thank you, sir. Thank you so much.
We'll just request our chairperson to felicitate our respected speaker, Dr. Rajput. And also would request Dr. Rajput to felicitate our chairpersons also. Meanwhile, I would request, we will move to the next session of Insulin Cockpit and would like to invite our chairpersons for the next session. Our chairpersons for the next session are Dr. Debashish Chatterjee and Dr. T.C. Rathod. I humbly request to both of the chairpersons, please come on the desk and take over for the next session and take us through the Insulin Cockpit. आगे.
Hello. Now we will move from gliptin to gliplosin cockpit, and today's topic is just rather comparison of first generation and second generation basal insulins regarding the variations of glucose, TIR. As such, glycosylated hemoglobin is a surrogate marker of glucose, but regarding the CGM, this comparison will be a best option, and none other than Dr. Joshi will elaborate the things. Thank you.
Thank you, Dr. Rathod, Dr. Chatterjee. This is a Sanofi symposium, that's the conflict of interest. And as he rightly said, in the next couple of minutes, what we will talk about is tackling the triune of hypoglycemia, glycemic variability, time in range. Because the buzzword is changing from A1C to time in range. And what's new in the next generation basal insulin. So that's really the scope of it. We are going to discuss mainly 4 points. First is, as Dr. Rathod said, the concept of GV or glycemic variability, time in range in clinical practice. Because as an endocrinologist or diabetologist, we should all have our glucose in range and avoid hypo and hyperglycemia both, and what are the new normals with the advent of SMBG and CGM both. Then second, we'll discuss what are the global recommendations. Then we'll look at addressing the hypoglycemia, GV and TIR with basal insulin which is currently available, and compare the generation 2 or next gen basal insulin analogs in light of TIR. So we have moved from the triad, fasting, PP and A1C, to actually a hextad, in which now we look at nocturnal hypoglycemia, hypoglycemia and glycemic variability. So from 3 to 6er. So we have now wanting to have fasting, PP, A1C nocturnal hypo, total hypo, and GV. So that's really the new 6. So what is GV? GV or glycemic variability is fluctuations of peak and valleys, and you can be intraday, that is within the day, or day to day, interday. And fundamentally we know that when there is a lot of variability, it leads to a lot of oxidative stress and severe hypoglycemia, and even sometimes hypoglycemia unawareness. So clearly glycemic variability is associated with cardiovascular damage, endothelial dysfunction, cognitive impairment, myocardial infarction, increasing mortality, and so on and so forth. So that's why we want to have that. So for the same A1C, there are many phases. You can have a A1C of 7%, which is controlled, and you can have a scenario 1, scenario 2, and scenario 3, in which scenario 1 you can have the time in range in 58% high while low in 24%, and it could vary. So the whole idea is to minimize variability for the same A1C, and that's really the goal today, and we can achieve that. So when this whole parameters, and these are our arbitrary parameters, were defined, it was defined that time in range is time spent by the human being in glucose range between 70 to 180. And the whole idea of time in range is to minimize the time spent in hypoglycemia. So there is a level 1 and level 2 hypoglycemia, level 1 and level 2 hyperglycemia. So TIR is 17 hours, 70 to 180. That's the green zone. The red zone is TBR, below 70, level 1, 54 to 69, level 2, very low, below 54. That is around less than 1 hour. So our target for human being is to keep our TBR below 1 hour. In the low range, at least 17 to 18 hours of the day we should spend in range, 70 to 180. And then high or time above range, level 1, 80 to 240, and above 240 is level 2. And at least try to keep that little hyperglycemia also as much as in range as possible. Try to keep it below 6 hours. That's really the true story of the TIR. Now, what are the outcomes if TIR is not maintained? If we don't maintain the time in range for less than 17 hours, and it is deranged by 10%, the retinopathy risk increases by 64%, nephropathy risk increases by 40%, neuropathy risk by 25%. And we see this in practice. We see some patients whose A1C is 7% come with a foot, some people come with rapid decline of kidney, some people suddenly come with a bad eye disease, and it's all linked to time in range. So there is very good now surrogate evidence through time in range to show that the surrogate markers of micro and macrovascular complications, including carotid intima thickness, is there. So the time in change or time in range evolved. First time in range was defined in 2012 in the type 1 diabetes space. In 17 they said let's use CGM because in 2012 CGM was not popular. 2019 the ATTD had an international consensus. The ADA said we should have the TIR range. 2020 now there is a ACE algorithm for goals of safety. 2020 ADA has advocacy of goals, and now 2021 and 2022 now on the just couple of weeks back at the ADA and at Stockholm in ESD, they have this tool for hypoglycemia. So our targets are very clear that for type 1 and type 2 diabetes, 70% keep it between 70 and 180, level 1 less than 25%, and level 2 less than 5%, 180 and 240, and below 4% less than 70, below 1% less than 54. If somebody is elderly, high risk type 1, type 2, then the target is 50-50. And pregnancy or type 1 diabetes, it is 70, 25, 4 and 1. And pregnancy, GDM and type 2 diabetes, it's tighter. So larger proportion we want to keep it in range. So obviously the TIR is based also on age groups, including India. There are Indian recommendations, and you can see here that we try to keep whether you're adolescent, pregnant, elderly and adults. In adults and adolescents, it is reasonable to have 70 to 80% of the time in range, while in pregnancy we need 80% of the time in range, and elderly also we try to keep it 80% of the time in range. So we are trying to get better and better in time in range. People who have high risk of hypoglycemia, like renal disease, liver disease, people who are microvascular complications, macrovascular complications, concomitant infections including COVID and tuberculosis, we are trying to keep it as much in range as possible, at least between 70 to 80%. So the whole idea is that we need to demonstrate time in range or glucose in range. So as a clinician now, you just don't look at fasting PPA1C, look at hypos, look at nocturnal hypos and try to keep your glucose in range. And can that insulin which you are using address that time in range? And among the insulin, which one has a better TIR? So the glycemic variability has two things. One is peaks, which is mainly the prandial glucose excursion, and secondly are the lows, which is caused by the hypoglycemia if you delay food. So one thing is very clear, that the basal insulin glargine effectively controls PPG excursion by hitting the fasting. The basic formula of glargine is, it is given at bedtime to fix the fasting, so that the hepatic glucose output is reduced. And basal offers flexibility for prandial glucose even through OHS. The risk of hypo is clearly less with glargine compared to NPH, and the risk of hypo is clearly less with glargine compared to premix or co-formulation. So that's clear cut. Hypoglycemia erodes confidence in doctors, all of us, we all see that. Hypoglycemia is the most feared side effect. 1 in 5 people with type 2 diabetes achieve an A1C below 7%, 2 in 5 will have a minor episode. 77% of people who experience hypoglycemia after 6 months of insulin stop their insulin within 1 year. So that's really the evolution. And the second generation moved from NPH to glargine, to detimir, to degludec, to U300. That's really the migration. And the next generation insulins are U300 glargine and degludec. And they have been developed with lesser variability and prolonged protracted duration of action, and they are standards of care. Fortunately for these insulins, we have head-to-head studies. Head-to-head randomized control studies, and BRIGHT study was the first head-to-head study of U300 glargine versus degludec, where dose titration was done, that means initiation and intensification, to achieve glycemic targets. And clearly they were the same, but the challenge was that the incidence during titration of hypoglycemia was lower with U300 glargine head-to-head compared to degludec. So that is a clear winner there, that it was clearly less and the events were lesser. Even for nocturnal hypoglycemia in the initiation phase, in the BRIGHT study, U300 scored over the degludec. And if you look at incidence of any time hypoglycemia, 26% less. Any time confirmed hypoglycemia below 54, 37% less. Any time confirmed hypoglycemia, 23% less. Any time hypoglycemia less than 54, 43% less. And any event of nocturnal hypoglycemia, 35. So 1/3 superiority to 2/3 superiority was achieved. And therefore, you do not get early hypoglycemic events in the titration phase. And therefore, there is less likelihood of discontinuation. So probably U300 has a significant advantage of the hypoglycemia risk reduction in the titration period of insulin-naive patients with type 2 diabetes. Head-to-head data is there. What about second generation basal insulin to address GV and help people to be in range? This is the T1-DO CLAMP study. Compared to degludec, in a single center randomized double-blind euglycemic CLAMP study, with the same dose, Tim Bailey clearly showed that the U300 glargine provides less fluctuating steady state levels on the pharmacodynamic profile with the equal distribution. And there is excellent data now, new data, which was published by Lucidi et al., showing in diabetes care that there is a lower variability with U300 glargine, with 22% greater peak with degludec and lesser variability with glargine. So clear data is there. And also now we have a TIR study of head-to-head glargine versus degludec, where they looked at head-to-head comparisons with CGM and how many people achieve time in range. And Kawaguchi et al. Clearly showed that there is comparable time in range of U300 glargine, but the time below range or the hypoglycemia was significantly or markedly lower for U300 glargine for all categories of hypoglycemia, whether it was the any time nocturnal or severe hypoglycemia. So that data is clear cut. And also the flash glucose monitoring study by Yamabe et al. Clearly showed that the percentage of time in nocturnal hypoglycemia was significantly lower of U300 glargine compared to the degludec treatment. So 1K real world evidence in type 1 diabetes with CGM, where type 1 diabetes were switched from first generation basal insulin analogs to U300 versus degludec. The CGM data was analyzed and again the data was clear cut. Even in real world setting, the safety and efficacy of U300 glargine, though was similar, the glucose in range or time in range was more with U300 glargine compared to the degludec insulin. And the InRange study, which was the first multi-center head-to-head CGM study of U300 glargine versus degludec, which was a multi-center study, where Bataluna et al. Concluded that though the efficacy was similar in type 1 diabetes, in terms of glycemic variability, hypoglycemia was similar. So what are the key messages? Sunil told me to try to finish a little earlier, so I'm trying to finish almost 8 minutes early. Glycemic variability and time in range is associated with significant hypoglycemia, diabetes complications and reduced quality of life. So we must measure it. Ideal to do it through CGM. We have a lot of flash libre systems available with us. Many other CGM systems are available with us. Even now we have Indian systems which are available from us. Second, we don't measure it, so though we don't know it. But a lot of our patients are swimming in hypo or hyperglycemia. And the second generation basal insulins demonstrate lesser hypoglycemia, improved glucose variability and lesser time in range, particularly with U300 glargine. So head to head, in the basal second generation insulins, U300 glargine has lesser hypoglycemic risk during the titration period with better glycemic variability and TIR profiles. Thank you for a patient hearing.
Thank you, Dr. Joshi, Padma Shri. He is known for his new innovative concepts. Due to short of time, they have instructed me not to have a questions. Rather, if you have any personal queries, that can be discussed with Dr. Joshi. Thank you. Second. Questions after second.
I request Dr. Sunil Gupta sir, please felicitate Dr. Sasan Joshi sir. Please sir. And I request Sunil Gupta sir, please felicitate our chairperson sir.
And for the next session, would like to invite our next chairperson, Dr. Santosh Kochar. Please come on the desk.
Good evening, everybody. It's my pleasure to be here and chair the session for none other than Dr. Sunil Gupta. So, transforming into clinical practice, science into clinical practice.
Thank you, Dr. Kochar. Thank you, Dr. Shashank, for keeping the time very much in range, so that we are trying to cover up the 1 hour which we are a little late for. My disclaimer that this particular session has been sponsored by Sanofi. Now my talk has been made little easy after Dr. Shashank's talk, that we are talking more on to second generation long-acting insulin analogs, and we will try to cover it with the impact of delay in the initial insulin initiation. I feel insulin initiation itself is a big challenge. Insulin up titration and intensification is a second channel. And these challenges have to be faced, is being faced by almost every clinician every day. And unfortunately, because of irrespective multiple reasons, either it could be the knowledge gap between the clinician and the insulin per se, or acceptability of insulin for the patient. So all these are multiple barriers of initiating insulin therapy, but we'll try to address few of the important barriers. Hypoglycemia has been covered by Dr. Shashank. So impact of delay, if you don't initiate insulin well in time, what can happen? That's one. Timely initiation with the basal insulin. What are the benefits if you start insulin well in time? What are the benefits we have? And the practical consideration, how can we make the life of a person who is on insulin easy so that he doesn't stop after starting insulin after a few days. So what is the impact of delayed insulin initiation? We have a wonderful study, and we do have an original author of this real world data which has been compiled by Dr. Shashank Joshi and his team, which was published in 2021. And this is landmark study, is the first large-scale longitudinal prospective observational real-world study investigating the management and the complication in type 2 diabetes across the country for almost 3 years. And they have observed that 4 out of 5 people have uncontrolled diabetes in India. Less than 1 in 4 Indians with established type 2 take insulin. So only 24% people there on insulin. Average HbA1c still is 9.2. And we expect that our patient should achieve less than 7. Young people should achieve less than 6.5. But unfortunately, almost 75% of a patient are still above 9. Delaying insulin initiation and continuation of oral hypoglycemic agent. This is data from around 81,000 plus patients of type 2 diabetes taking 1 or 2 medicines. And they have observed there is a significant delay in the treatment intensification. In insulin, almost 50% of patients with type 2 diabetes for more than 7 years delay, and they remain in poor glycemic state despite all education programs, all conferences like RSSDI, Hello Diabetes Academia, Mayo Clinic, every conference, but still there is a gap and we are unable to do so. And we know that poor glycemic control leads to bad metabolic memory. I don't need to remind you this, that early control of blood glucose from the diagnosis, within 6 months of diagnosis, you should try to achieve your target. Suppose you target a patient, this young patient, I want HbA1c should be 6.5, try to achieve that goal within 6 months. And then with this early control of blood glucose will have its payoff in the long run after 10 years, 15 years, that he or she will be protected from microangiopathy and macroangiopathy. And this has been endorsed by the DCCT extension trial, that's called the ADDICT study, and UKPD extension trial in type 2 diabetes. So microangiopathy, macroangiopathy can be protected or they can be delayed further because of the early control of diabetes, and this is called as metabolic memory. You can impart good metabolic memory by good control, or if you don't control it, the person will remain in bad metabolic memory. And poor glycemic control results in irreversible mitochondrial or the vascular changes, which then progresses to the long-term complication that's called as bad memory. And this is data, again, UKPD, this is data from DCCT trial. In delay in treatment, intensification leads to micro and macroangiopathy. Timely initiation with basal insulin is being recommended by almost everyone across most of the global bodies. RSSDI says premixed as well as basal can be given. Now, this is a UKPDS trial which was conducted in young type 2 diabetes or type 2 patient at the time of within the first year of diagnosis. And what they have shown is early in insulin initiation might improve the metabolic control better. And there is a comparison between the conventional approach, insulin alone, and sulfonylurea plus insulin combination. And the early addition of insulin to the oral agent monotherapy maintain blood glucose level for long 6 years. And this is one of the good data from this trial. Early initiation significantly improves the chances of reaching the goal, which I told you. And we should try to monitor blood glucose more frequently and try to act fast rather than waiting for one drug, acting for 3 to 4 months, waiting for another 3-4 months, waiting for 4 months, and achieving. I feel we have to be aggressive enough, achieving the goal more faster, because an early and the more aggressive intervention provides a more rapid glycemic control and improves the glycemic profile, protect them from the complications. Now, this is a Be Smart basal early strategy to maximize HbA1c reduction with oral therapy. And what they said, basal only regime is the most convenient for type 2 diabetes. Start with 10 units per kg per day, or you can start with 0.1 to 0.2 unit per kg per day, depending on degree of hyperglycemia. Then you should try to up-titrate the dose on every 4th day. There are 2 methods. You can do it 1 unit per day, or you can have 2 units every 3rd or 4th day. Initiate it well in time. Basal insulin should be injected at an appropriate time, whatever time has been given to you. If it is glargine 100, within 1 hour window period. If it is glargine 300, it is 3 hours, 3 plus 3, that's 6 hours window period. The analog provides better flexibility, and glargine 300 offers more flexibility versus glargine 100. So metformin could be, what about oral drugs? Whenever we start basal insulin, metformin could be continued if there is no contraindication. Incretin-based therapy, SGLT2 inhibitors, of course, should be continued. Thiaglitazone may be reduced or may be discontinued. And sulfonylurea may be continued at smaller doses, but the doses should be reduced to avoid hypoglycemia. What are the benefits? Basal insulin is capable of restoring the residual beta cell function in short term, providing a basis for a better response to the different maintenance therapy. So we are preserving the beta cell health. Early initiation attenuates the microangiopathies if you try to achieve it less than 6.5. Early basal insulin acts to lower the risk of hypoglycemia and weight gain if you start basal insulin. What are benefits through this second generation, which is called as 2G0300 glargine? The difference between glargine 300 versus 300. 100 is were developed to overcome limitation of earlier NPH insulin, and they are now being well established. The longer 300 glargine unit is a more concentrated glargine, which have shown to have a better glycemic variability, which Shashank has already shown. So it has less GV, less risk of nocturnal hypoglycemia, overall hypoglycemia, with the same durability of action. And this is supposed to be one of the good insulin. Now, what is the difference between the two insulin? The volume of the insulin 300 glargine is almost 1/3 as that of the 100, which is a very simple mathematics. 100 IU per ml versus 300 IU per ml. Smaller subcutaneous depot, and there is different absorption kinetics, more gradual release versus the glargine 100, and has a PK/PD which is more favorable, and it has same molecular structure, but the mode of protraction, once you inject it at the subcutaneous level, it forms the precipitation, and the metabolism is almost similar. Better efficacy, lower high risk of hypoglycemia, and lower risk of weight gain versus glargine 100 when it comes to comparison with the 300 glargine. Less weight gain, and the dose requirement seems to be little higher, around 14%. Now, someone is already on glargine 100. How will you switch over? If you switch over, the pain is less, it is easy to use, force to the inject is less, and switching preferences, switching from first generation to third generation, it is 1:1 unit. You don't need to reduce the dose of the insulin. Switching from 100 to 300 might be associated with better quality of life to the patient, because you have a window period of plus minus 3 hours. So if you say 8 o'clock in the night, you can take it from 5 to night almost 11. So 6 hours window plus minus 3 hours. Better efficacy, longer duration of action, greater administration flexibility. Its pain is actually separate pain. It doesn't look like other pen, and the cartridge of this glargine 300 doesn't fit in any of the other pen, and that is it is customized for only glargine 300. So there is no chance of having, getting confused, because this is very commonly it happens that my pen was stopped working, so I went to the medical store, took another pen, which was of some other company, and the cartridge, they put it with another company. So this kind of mistakes can be corrected by using a customized pen. Easily titrated, low risk of hypoglycemia, more patient satisfaction, less weight gain, better efficacy. Practical consideration, around 0.0 unit per kg body weight. The preferred timing of as per the patient's preference, any time of the day. All OADs can be continued, can be safely titrated using daily once in 3 or weekly titration, either in once in 3 days or weekly, up to around 0.5 unit per kg body weight. And what are the unique advantages? Duration is more than 24 hours, less glycemic variability, flexibility of plus minus 3 hours, low hypos, low weight gain, and safer titration. And the pen is customized, as I told you, easy to use and less volume because it is concentrated, and lower injection force, which is required by using this pen. Believe me, our patients are more happy with this pen versus the earlier pen of Glargine 100. It has dedicated cartridge. There's no wastage of insulin in this cartridge, and it seems to be much better as far as patient user friendly and the satisfaction of using pen is concerned. When you use this, it has a dedicated replaceable cartridge. Dose you can have up to 80 units per day, and you don't waste any insulin. Capacity almost 450 units, and 1 unit dose adjustment, short dial extension, hold time is just 5 seconds. So to summarize, early insulin initiation is crucial for achieving better glycemic control in type 2 diabetes. Glargine 300 demonstrated superior glycemic reduction and is also reported to have convenient medication with both patient as well as the physician. It has array of advantages over the first generation as far as efficacy, safety, and hypoglycemia is concerned. And the delay in treatment of intensification might create a problem, might increase the risk of complication. So initiate early, titrate appropriately, and try to achieve good glycemic control within 6 months of diagnosis. That should be the final message for any type 2 individual. Whenever you feel that my maximum or higher doses of oral drugs not doing well, switch over to insulin as early as possible. Thank you very much for patience listening.
Thank you, Dr. Sunil. And now the captains can be asked questions.
So now I request Dr. Shashank Joshi to please join here for question answer session. Yes, quick, one question. The mic is not working. You can be a little louder, beta. Are mic there?
We don't have time and range concept. Now we have a time range concept. So apart from evaluation and monitoring, can be extended to diabetic diagnostic criteria time and range?
So that's a good question. Can we extend, or can we use CGM as a or can we use these devices to diagnose diabetes? And increasingly you will see as time goes by, you might get such a definition coming up. But currently the diagnostic markers, both for diagnosis of diabetes, were based on one cutoff, whether it's type 1 or type 2, and is called as retinopathy cutoff. So the threshold was used on development of retinopathy, whether it was fasting, whether it was postprandial, whether it was A1C. What was the cutoff where the retinopathy incidence went up? That is how the original diagnosis was made. There was always a global debate between ADA and WHO. WHO predominantly went on challenging glucose and prandial glucose, which is an Asian problem. If you see the whole world, the predominant diabetes is between the Suez Canal and Japan. That is where 70% of the world diabetes population is living, people living with diabetes. And that is basically where you use a GTT. While rest of the population was fasting PP and A1C, ADA said just do fasting and A1C. And time in range right now is not a diagnostic cut point. It is only a treatment evaluation tool. So the likelihood of it being a diagnostic cut point is still in its infancy, if you ask me.
If you'll be stop here with the permission of chair, you can take it clear. Thank you very much.
Thank you.
Dr. Kocher to continue for the next session as a chair and invite our respected speakers for the next session, Dr. J.K. Sharma and Dr. Sadasiv Rao.
So this is to be
I will request Dr. Sunil Deshpande to come and join as a chairperson for the next session. Neeta ma'am is
not getting impacted.
Everyone knows IITs, IIMs, AIMS. Very few people would remember TIFR, that is Tata Institute of Fundamental Research. In short, core issues are ignored. Applied issues are always discussed. We have two stalwarts talking about the core issue of beta cell preservation. Please go ahead, sir.
Sir, actually, if beta cell preservation was there, we would be happy. But suddenly, here, our organizer Sunil Gupta has changed it to gut microbiome and diabetes. Maybe he's a little bit angry on me, or he had some grudge on me. So he had this topic for me, and he just told me, just stand beside Sharma ji, and he will do all the talking. So I came here, and I learned that he also told the same thing to Sharma ji also. So we'll try to do our best.
Right.
Yeah.
I agree, you can do your best, but on what topic exactly now?
Gut microbiome and diabetes.
Right.
So
You're welcome, sir.
Yeah, in clinical practice, as far as I know, my father was a general practitioner who used to prescribe Sporolac for people when he's treating children with diarrhea. That's my first interaction about the gut microbiome and all. And so later on in practice, when we have been using antibiotics, a lot of antibiotics for a long time, especially in treating diabetic food, we have been prescribing lactobacillus and probiotics. So we'll go into the detail, we'll see what's going to happen. When did this biome actually started? So, well, it's from time immemorial, Hippocrates has stated that all diseases begin in the gut. So it's not new. And what is a microbiota? It's a complex ecosystem of microorganisms living in different segments of the human body, such as the gastrointestinal tract, skin and respiratory system. And it's considered as the second genome for the human body, responsible for 98% of the genetic activity of the organism. Yeah, and if you look at the gut microbiota, human gut hosts 100 trillion microorganisms and thousands of species, weighing an average around 1.5 kgs. And microbiota changes from infancy to adulthood. And around 95% of the total microbiota constitutes about the bacteria in three major groups, which represent the firmicutes, bacteroidetes, and actinobacteria. And so, especially if you see on the skin, every square centimeter of the skin hosts about 1 million of microorganisms.
So, good evening, friends. Till 10 years back, up to 2012, we have not been hearing much about these microbiota. And during these 10 years, any talk on gut microbiota and diabetes was being assigned to the gastroenterologist. But thanks to Dr. Sunil that this time he has given us this opportunity to go through this. And this is a very fantastic topic, and in the times to come, we all will be looking after this. And not only this, especially in people who are with pre-diabetes. So right at that time, patient diagnosed with pre-diabetes, we will have one more armamentarium with us to get it into control and to reverse to the normal. As Dr. Sadasiv have already narrated,
95% of the total microbiota, there are three major groups which represent. They are the firmicutes, the bacteroidetes, and the actinobacteria. Please do not go about the much complicated terminology. But what exactly they are and what they do? When there is genetic background, which we all have, during the delivery procedure and the breastfeeding by the mother, bacteria in the amniotic fluid, and we all have heard that the colostrum that contains the antibodies, that is very supportive and that is very preventive immunologically also for the child. The various functions, they are affected by the age of the person, by the antibiotics we consume day in and day night, the lifestyle of the people, and especially the diet. So these are very four important factors. When we come to the metabolic functions and the protective and structural functions of these microbiota, in metabolic they have amino acid synthesis, dietary fat absorption, fat soluble vitamin absorptions, calorie removal, production of short chain fatty acids, composition of bile acid, lipid energy metabolism, activation of glucose homeostasis, and we can see here that whatever mechanism is there for the pathogenesis of diabetes, for the pathogenesis of the diabetic complications, micro and macrovascular, there is a role of these microbiota. They have a protective function like prevention of the pathogens, colonization, dietary fat absorption, fat soluble vitamins, and many more, and structural functions like the gut permeability regulation, leading to the inflammation, intestinal architecture regulation, and the immune system and the barrier functions. So, yes.
I'd just like to add. So actually, this microbiota whole story actually starts even how the baby is delivered also. If the baby is delivered through the vaginal route, it gets its microbiota from the vaginal tract of the mother. And if it's delivered through the cesarean section, it gets its microbiota from the hospital environment. So this starts even at the origin of birth. And so as soon as the baby is born, the food that is given also decides the microbiome. So one thing is that if it is breastfed, you know that if a baby is breastfed, immunity, it gathers immunity and it gets a good microbiome. If it's given a cow's milk, you know the interaction of cow's milk to type 1 diabetes is well known. A lot of studies are there. So this, and Dr. Sharmaji has talked about the genetic background, which plays always a very important role. And right from the early age, so the microbiome is labile until 2 years of age. 2 to 7 years is stable, and from the 12th year onwards, every person develops their own unique microbiome. And yeah, next.
Now when we come to the mechanism of gut microbiota affecting the insulin resistance in diabetes, what is we are concerned for today, and it is through the microbial component and the metabolic products. As we have already talked about the genetics, the diet, and the medications, then we see that lipopolysaccharides through the TLR4, there is low-grade inflammation and ultimately leads to insulin resistance. Now another thing is that there is very important effect on the bile acids through the liver and the pancreas, and then secondary bile acids through the FXR and the insulin sensitivity. So ultimately what they do, they have effect both on the insulin resistance as well as on the insulin sensitivity. And then you must have heard that the fecal matter transplantation, which has become the talk of today, and then effect on our various medications like the metformin, alpha-glycosylate inhibitors, probiotics and prebiotics. And probiotics, prebiotics we heard every day. Even the curd with probiotic curd, prebiotic curd is also available. So there is a complex mechanism of gut microbiota which affect and ultimately lead to the insulin resistance and diabetes. Now, there are...
I would just like to add, we'll go back again. So one thing is, just like what we are talking about the fecal transplantation, if you take a leaf out of the veterinarian studies, wherein they gave for the stool or feces of the diseased animal was given from the healthy animal. So, that way they took care of the microbiome. And so, I think how the half of the elephant eats the feces of the mother to develop the microbiome to eat the vegetarian food and all, and digest the animal products. Yeah, please carry on.
So the impact of gut microbiota on whole host metabolism, if we look at, then there are multiple sites, and we can see here that at the fat storage and the adipose tissues, at the gut, enteroendocrine metabolism, at the brain leading to behavior and motor activity, periodontitis, which is also a very important, tissue lipid composition, cardiovascular disease, blood vessels, effect on the liver through fatty liver metabolism, hepatic steatosis, and the energy metabolism in the skeletal muscles. So the gut microbes, they have become very important and they affect the every system of the body. Now, what is the gut connection to diabetes?
Yeah, we are concerned as diabetologists, what is the gut connection to diabetes? Why should we be talking about the microbiome? So, both type 1 and type 2 diabetes have a gut connection. We'll learn about in the next slides. So, in diabetes, there is a lack of uniformity in the gut microbiome profiles. So, the human metagenome-wide association study showed significant correlation with specific gut microbiomes, bacterial genes, and metabolic pathways in type 2 diabetes patients. So, in these patients, it showed a higher level of lactobacillus compared with the non-diabetics. So, diabetics had higher levels of lactobacillus when compared with non-diabetics, and also this lactobacillus is correlated positively with fasting plasma glucose and A1C, while Clostridium correlated negatively with fasting plasma glucose, A1C, insulin, and C-peptide levels, and also plasma triglycerides, and positively with adiponectin and HDL. And if you look at the gut microflora, it contains of the bacteriotes, Thetaiotomicron. I am not able to even spell it out. It's a secretion of antimicrobial molecules, defensin and angiotensin. They are secreted by the intestinal Paneth cells into gut, which fight the intestinal microbiomes. So, deficiency of these bacteriotes causes type 1 diabetes, where there is altered aggression, autoimmunity leading to type 1 diabetes.
Now, a very common term, oxidative stress, which we have heard number of times, and the pro-inflammation in type 2 diabetes. We have seen in several studies from Madras Diabetes Research Foundation, Chennai, that demonstrated the association of oxidative stress and pro-inflammation with type 2 diabetes. And these are the various studies, increased oxidative stress in patients with type 2 diabetes and its vascular complications. So oxidative stress is one of the pathogenetic mechanism of this. And the increased inflammatory stress again in patients with type 2 diabetes and its vascular complications has been elucidated and it has been published in a number of national and international journals. Now, gut connection to type 2 diabetes.
There is an intricate relationship between intestinal microbiota and the development of metabolic diseases like type 2 diabetes. So, there are the two hypotheses, the storage hypothesis and the inflammatory hypothesis, I think, which will be detailed in the later slides. So, obesity, and does the gut microbiota have any role in obesity? So, the occurrence of type 2 diabetes mainly attributable to overweight and obesity. The interplay between behavior, genetic and environmental factors are the principal contributors to obesity and its incidence, type 2 diabetes incidence. Among the ambient determinants, gut microbiota appears to be one of the crucial mediators of obesity and the pathogens of diabetes. So, microbiota possesses protective function in metabolic regulation and play an active part in glucose and lipid metabolism. Extrinsic and intrinsic factors lead to perturbations of the gut microbiota, which result in a shift from the normobiosis to dysbiosis of microbiota.
Now, the gut microbiota and how they differ in intestinal homeostasis versus dysbiosis. The short chain fatty acid, the hypothesis there is normobiosis and dysbiosis, and this will be explained by Dr. Sadasiv.
So, if you look here, in normobiosis, you have more of the firmicutes, And whereas in dysbiosis, the bacteriotes are more. That means the imbalance in these, actually the microflora or microbes is the causation of the, whether a patient has dysbiosis or normobiosis. And again, here you can see the short chain fatty acid production is reduced, intestinal monosaccharide absorption also reduced, energy withdrawal from carbohydrates reduced in normobiosis, hepatic demolipogenesis, fatty acid loading in adipocytes, and also finally, whereas in dysbiosis you have the immune response is decreased, and again, so the short chain fatty acid production is increased, intestinal vice versa is there. Intestinal monosaccharide absorption also increased, energy withdrawal from carbohydrates, hepatic de novo lipogenesis, fatty acid loading, all these things opposite of what is normal happens in dysbiosis. As a result, you have.
So now in the next half a minute, I will try to summarize. The high-fat diet modulates the composition of gut microbiota, promotes metabolic endotoxemia, and triggers the development of metabolic disorders. And then when we come to the difference in the immunopathogenesis of type 1 and type 2 diabetes, again there is a role of gluten, milk, and in dysbiosis in type 1 and type 2, type 1 and LADA, and another role of metabolic dysfunction, obesity, dysbiosis in obesity and type 2 diabetes. But coming to very important, what are the various drugs? They have an effect. The drugs like metformin, thiazolidine diones, the alpha-glucosidase inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors, and the prebiotics. They have different action on the different microbes. Certain microbes, they have a better effect, they have a positive effect, and certain other microbes, they have a negative effect on the development of diabetes. So the potential therapeutic interventions regarding the microbe and diabetes in the coming time, they are the genetically modified bacteria, prebiotics, probiotics, even the niacin, and they start from the fecal microbiota transplantation. So fecal microbiota transplantation. Second is the fiber, the dietary fibers. Then comes the role of the essential amino acids like the niacin, the leucine isoleucine and the valine, and also the exercise, which is very, very important. So dear friends, this topic and this subject needs further research from the diabetologist's point of view. And it is good. Thank you, Dr. Sunil, for keeping this topic and giving us the opportunity to read about this topic. We don't know how much we have delivered, but the subject is very, very vast.
So finally concluding, we have crossed our time. So it's very clear that as science looks to the future of microbiome, will be a very promising frontier, just as Sharma ji has told us. It can be foreseen that the gut microbiota will be used not only as a biomarker for diabetes, but also as a target for potential therapeutic treatments. Through the intervention of gut microflora, it will eventually be possible to achieve a more precise and personalized diagnosis as well as treatment of diabetes. Thank you.
Thank you, and would like to ask our chairperson to felicitate both the speakers. May I ask Sunil Gupta sir, please just join for the felicitation.
Now I invite our next chairperson, Dr. Sunita Kumbalkar and Dr. Prasant Popalkar. Please come on the stage. Thank you so much, all of you. Thank you. And now I invite both of the chairperson on the stage, please. Over to you, Dr. Prasant sir. Please introduce the next speaker.
I don't think this
Yes,
introduction is required.
Very
We'll
good evening to
directly-
all of you. And we
And
are
no any introduction required for Dr.
Yeah, no
Sunil, sir.
introduction is needed. That is our work is reduced. So only about the topic that diastolic dysfunction when it occurs and the person has hypertension, some comorbidity, and with the echo we see EF. In that case, apart from very few therapy, they have proved fruitful. Except diuretic and the control of risk factor, we cannot go for any other thing. So I think the sir is open for his to deliver his topic regarding the same Emperor Preserve trial.
Thank you very much, Chairperson. Thank you, MOC, for this honor. Very brief, 10 minutes talk. We started with SGLT2 as a inhibitors as a glucose lowering therapy. Somehow, cardiologists have come, means we realized that it can be given to patients who have pre-existing cardiovascular event or disease and then the risk factors. Till that time, everything was going well. Suddenly, we realized that a lot of cardiologists started writing this drug even in non-diabetics. And then the data has come. Now it is even for diabetics, non-diabetics. So practically every person with diabetes with compromised LV or maybe reduced ejection fraction are being put on this particular molecule. And we are a little afraid that now this molecule has gone from our hand and going to cardiologist's hand. Suddenly then you get the renal outcome data and then you say, oh, nephrologists started using in non-diabetics, diabetics as well as non-diabetics. So maybe then nephrologists will again come and will, snatch away everything from us. Then suddenly you get data from NAFLD that non-alcoholic fatty liver disease, again SGLT2 inhibitors is beneficial. Now gastroenterologists are also coming. So we are all in threat that this molecule is not going to remain with us for long period. Multiple players are there as far as the specialties are concerned. This particular session is sponsored by BI. So I'll be very brief and try to give some carry-home messages. I am not a cardiologist, that's my disclaimer, and I'll try to be there what is there in the slide. Diabetic cardiomyopathy outcome, implication of SGLT2 inhibitors. I feel cardiovascular disease and type 2 diabetes it's a common soil hypothesis that you have almost common risk factors, age, gender, South Asian, family history, physical inactivity, unhealthy diet, obesity, low birth weight, inflammation, hypertension, dyslipidemia, smoking, everything. It's called as common soil hypothesis that both of the diseases have almost the same pathogenic or the risk factors. Patient with type 2 diabetes, this is data from UK Biobank prospective cohort, around 8,000 middle-aged participants from South Asian ancestries of around 4.5 lakhs of European population. And what they have found is, amongst the South Asian people versus European, we are almost 2.3 times higher risk to have coronary artery disease versus Caucasians. And the hazard ratio for heart failure again is around 1.83. That means somehow Indian or Asian population is more likely to have coronary artery disease as well as the risk of heart failure. And we call now it as a diabetic myocardial disease, which can be defined as a myocardial disease in patient with diabetes that cannot be ascribed by hypertension, coronary artery disease or any other known cardiac cause. And there are various mechanisms which it could be because of the metabolic effect of the higher free fatty acids, insulin resistance, structural damage to the myocardium because of the fibrosis, extracellular matrix changes, autonomic dysfunction, which we know they are already there, decreased heart rate recovery, so resting, increased heart rate, reduced perfusion due to small vessel disease. The multiple explanations for having diabetic myocardial disease or cardiomyopathy. And this is this metabolic changes because of the hyperglycemia, insulin resistant, hyperinsulinemia. You have increased free fatty acids causing we know that glucose is toxic to the vessels. We know lipid is also toxic to the vessels. Lipotoxicity, glucose toxicity, AG theory, the advanced glycated end products, which increases the fibrosis and that remains for multiple decades and it cannot be recovered. So these are some of the theories and oxidative stress. All of them are responsible for myocardial damage, LV hypertrophy and cardiomyopathy and diastolic dysfunction. Now 46% of the people with type 2 diabetes have LV diastolic dysfunction, and before SGLT2 inhibitors have been launched and the data has come for heart failure, till that moment most of the clinicians Though the echo report used to come to us, we never ever really respected diastolic dysfunction because we did not have any drug those days. But if your data says every second type 2 diabetes patient may have diastolic dysfunction, and over 1 in 4, so 25% of the type 2 diabetes who are above 60 years of age may have previously unknown heart failure. So there's a big gap between the care versus the data we have, the burden we have. So all patients, if you say almost 23% prevalence of undiagnosed heart failure in 60 plus patient, 28% female on an average, so 25%. And this data of around 581 patients who were diagnosed to have reduced ejection fraction of more than 60 years of age. Most of the guidelines, ADA guidelines now clearly says that if the patient has associated chronic kidney disease, coronary artery disease or heart failure, SGLT2 inhibitors should be the drug of choice. And especially the GLP-1 analog does not have this data, it is only for SGLT2 inhibitors. Now ADA clearly actually has shown SGLT2 inhibitors. I won't go too much in detail of it because we earlier already had the talk on this, but heart failure patient, we had earlier data for the reduced ejection fraction, but now you have a data even for preserved ejection fraction. So how does the SGLT2 inhibitors mediate what is the pathophysiological mechanism, how SGLT2 inhibitors might be helping the patient with cardiomyopathy or heart failure through preload reduction to directly affect on the myocardium as well as the afterload reduction. So the various mechanisms, I'm not going to go in detail of it, but they are responsible for benefit of this drug. Main reason possibly increasing renal glycosuria, and may the vascular, the hemodilution itself could be, the hemoconcentration, it can also be one of the reason. Apart from that, it reduces LV hypertrophy, LV remodeling, it reduces fibrosis and multiple other mechanisms on the beneficial effect on the endothelium, the vascular tree, stiffness, and some of the beneficial effect on the autonomic neuropathy. And this is another data which has been actually hypothesized that this could be the reason. The metabolic flexibility of the healthy heart is lost because of the heart failure, featuring a glucocentric metabolism and preference for the ketone bodies, while the capacity of the oxidized fatty acid and the branched chain amino acid is impaired, and that is why the remodeling gets impaired. So what does this empagliflozin does here? It has a dependent glycosuria, leads to modulation of the cardiac metabolism with reduced glucose oxidation and increased use of ketone bodies. We should know that ketone bodies are beneficial for the myocardium. So as well as the fatty acid and the branched chain amino acids, which is parallel with the improved LV function and geometry. And that is why you get some benefit in the function of the patient with reduced ejection fraction. And this is a data I feel everyone knows about the EMPA-REC trial, that you have almost 38% relative risk reduction in the overall population of when you talk about the risk reduction in CV death, and even Asian population, the risk reduction is almost up to the range of 56%. So they are one of the wonderful molecule. There are other heart failure trial, and that's why we say SGLT2 inhibitor is more of a class effect rather than the molecule effect. So you have a data now from DAPA-HF, from as well as from other trials. Empagliflozin, recent study have shown a benefit in reduced ejection fraction. Both study have shown clear benefit in primary outcome. Empagliflozin showed additional benefit in the renal outcome. DAPA has shown also benefit in mortality and independent of the glycemic. It's not the benefit or the credit is not going to the glucose control, but credit is going to the effect of the molecule on the basic pathophysiology of heart failure, whether it's a dapagliflozin or coming from DAPA-HF data, or whether it is emperor reduced from the empagliflozin. And these are total evidences which is from DAPA-HF, emperor reduced, DAPA-CKD, and it's all, if you go through on the right sides, everything is in favor of the SGLT2 inhibitors, whether you are non-diabetic population or whether it's a diabetic population. So you have got wonderful data coming from DAPA-HA, dapagliflozin, Emperor, empagliflozin, DAPA-CKD, Canvas, Credence for canagliflozin. The reduction in the hospitalization of heart failure, and few of them also shown reduction in the mortality.
The reduced ejection fraction start with less than 40%. The normal ejection fraction we say it is more than 50%, but what about between 40 and 49? So they have come out with another classification, mid-range heart failure between 40 to 49, and they have shown that the relative reduction in even mid-range heart failure by around 29%. The number needed to treat is 21. That's the number is better than molecule is. And even if you see the patient with preserved ejection fraction, and we have more than 50%, there's 70% risk reduction of the cardiovascular death or hospitalization for heart failure, the composite outcome. And this is a very recent data of May 2022, where the DAPA-gliflozin and the DAPA-HF phase 3 trial have demonstrated that it has an effect in heart failure regardless of the ejection fraction. So high-level results of the phase 3 showed that the dapagliflozin has reached to a statistically significant clinically meaningful reduction in the primary composite endpoints of cardiovascular death or worsening of the heart failure. The trial was conducted in patients with heart failure with mildly reduced or preserved ejection fraction, which has been defined as less than 40%. This is a summary of cardiovascular death or hospitalization for heart failure in patients, irrespective of the group, whether you have low medium, you have ASCVD without prior CVD event, ASCVD with prior event, with preserved ejection fraction, with middle range ejection fraction, or ejection fraction, irrespective of any of the class of patients, this SGLT2 inhibitors have shown categorically significant benefit to the molecule versus placebo. So finally, you have the American Heart Association, Cardiology Organization, HFSA, and all joint recommendation. If you ask a patient with type 2 diabetes with either established CVD or at high cardiovascular risk, SGLT2 inhibitor should be used to prevent hospitalization for heart failure and the rest of the things. For patients at the risk of heart failure, the regulatory peptide biomarkers
Care, including a cardiovascular specialist optimization of GDMT, can be useful to prevent the development of LV dysfunction. Patient in heart failure with preserved ejection fraction, SGLT2 inhibitors can be beneficial in decreasing hospitalization and the mortality. And this has been again shown with a class 2A evidence and has been proved to be one of the beneficial molecules. So as I told you in the introduction of the lecture, that this molecule has started as a glucose lowering therapy, then cardiovascular risk in patient with either pre-existing cardiovascular disease or the high, more than three risk factors, and then followed by heart, then chronic kidney disease, and now NAFLD, and very soon it's going to even come for Alzheimer's disease in future. With this important message, I would like to conclude here and stop here. Thank you very much. Over to you, Chairperson.
Thank you, Dr. Sunil Gupta. But I want to add one thing, that dapagliflozin should be given in 10 milligram dosage, that is full dose. With 5 milligram, the benefit is not that much as far as heart failure is concerned. So the SGLT2 inhibitors are going to be a next aspirin for the diabetes. With that, anybody want to ask some questions?
I feel we can stop here if there's no question.
Thank you, Gupta sir, and the team for giving me this opportunity.
Actually, we have international symposia, which is very, very interesting. Please wait for it. One of this, yesterday we had 4 sessions from all speakers from US. And sir, I'm telling you, I could not get up from this chair after listening to them. Today we have 3 such sessions. Don't miss that. Thank you very much.
Thank you.
I just want to make one comment.
I invite our next chairperson, Dr. C.S. Pilurkar and Dr. Akhil Meman, sir. Please come on the stage. So over to you, sir. Please introduce the next speaker.
Good afternoon, everybody. I welcome all of you here in this session. Here is the next topic is, first of all, I will introduce the friend of mine, Dr. Narayan Devgaonkar, very good name. He came from Nashik. He is MBBS MD, Medicine, FICP, FRCP, London. More than 30 years of experience in clinical practice. Organizing Secretary of RSSDI 2023. Chair-elect Maharashtra RSSDI State Chapter. Governing Council member of API. Past President Maharashtra Association of Physicians. Organizing Secretary for MAPCON, RSSDI and Indo-US Emergency Medicine. Former Joint Secretary, Indian College of Physicians. Former Member Board of Studies, Postgraduate Medicine and Allied Subjects, Maharashtra University. And Honorary Secretary State, RSSDI Chapter. So many long list of for under his name. The next topic for him is alcohol and diabetics in Indian context, for which I welcome Dr. Narayan Devgaonkar. Please go ahead.
Good evening. At the outset, I would like to thank Sunil Gupta for inviting me here as a speaker and congratulate him for such a wonderful conference. You have got a different concept, different ideas, Sunil. Congratulations. I would like to thank my friend Chandrasekhar Gillurkar, who was investigator trial for COVID vaccine. To give him a big hand. Basically, he was the first person from Maharashtra, that too from Nagpur. He was a yes. Yes. I know he's daring and all these things. So, congratulations, Chandrasekhar. The topic which has been given to me is alcohol and diabetes. I think this topic is very close to heart of everyone. So, here I am not here to recommend how much to take alcohol or whether to take it or not. I am going to enlighten on Indian studies which has been published about the alcohol and diabetes and how much, suppose it is to be consumed, how much is safe for you and how much you are supposed to take and at what interval you are supposed to take and how much quantity also you are supposed to take. All of us know that alcohol is harmful and those people who are not taking alcohol, we must advise them not to take it. But those who are taking alcohol, there are so many studies which has been published. Moderate quantity of alcohol is supposed to be the beneficial in patients of diabetes as well as in patients of coronary artery disease. This is a national data which has been published. It is a national non-communicable disease monitoring survey, which was a cross-sectional survey, which was published in 2017 and 2018. What was the alcohol use among adults? The mean age of initiation of alcohol in Indian context is almost 22 years. There are 18.9% of people who have ever consumed alcohol, then 15.9% of the patients who have consumed in last 12 months, and in 12.6% of patients who have consumed alcohol in last 30 days. This was the survey conducted in 2017-18. And for every one woman who consumed alcohol, there are 12 men who have consumed alcohol. So the percentage of male is very high as compared to female. Heavy drinking episodes, 1 in 10 men reported to drinking more than or equal to 6 standard drinks. One standard drink is equivalent to almost 10 ml, which contains 8 grams of alcohol. And in one drinking occasion, alcohol use related changes among those who consumed alcohol in last 12 months, most common change reported daily or weekly was being unable to stop taking alcohol in future. This was the study which has been published. Among those who consumed alcohol in last 30 days, maximum number of standard drinks in one drinking occasion is in 44 years, it is 5.9, 45 to 65 years, it is 7.2. This is the graph which has been showing that standard drinks less than 3 is 17.4% of people. It is, 3 to 5 standard drinks, it is in 38.2%. And more than 6 standard drinks, which is supposed to be the more than required. So 6 standard drinks are allowed, and it is said to be a moderate consumer of the alcohol. And this is more than 6 is maximum number of people who are consuming. It is 44.4%. The source of alcohol in these 2 in adults consume alcohol purchased from unauthorized drinks particularly. How many lifestyle advice from doctor or health worker against alcohol use are given? Men it is given for 10.9%, women it is 1.7%, urban it is 5.5, rural 6.7, and total is 6.3. There have been data consumed. What is an alcohol unit? 1 unit of alcohol is 10 ml or 8 gram of pure alcohol. Alcoholic drinks come in a different strengths and sizes. Units are a way to tell how strong the drink is. It takes an average adult around an hour to process 1 unit of alcohol so that it is cleared from your blood. It varies from person to person. If healthy reach to low level, it is safest not to drink regularly or more than 14 units a week. It is spread across multiple days throughout the week. What do 14 units look like? 6 or more pints of beer a week, 6 or more medium glasses of wine in a week, or 14 or more shots of spirits, that is 80 heavy percentage of alcohol which contain. It is like this. Most important is how alcohol and diabetes care. So alcoholic patients who are consuming high quantity of alcohol, patients are likely to go for hypoglycemia and diabetic complications. Alcohol consumption is associated with decreased food intake, correlates with a decreased willingness to adhere to the dietary regimes which we advise in day-to-day practice in diabetes. Alcohol interferes with the attention of diet and medication due to impaired judgment. It may also impair other self-care behaviors like exercises, glucose self-monitoring. Heavy drinkers with diabetes have poor insulin adherence. They don't take insulin properly, and even if they take, they don't take a proper dosage. They appear to have decreased motivation to adhere to the treatment regimes. Even moderate drinkers have reported to have poor adherence. These are the different studies which have been published. Alcohol consumption is inversely associated with the advanced diabetes self-care behaviors. So, highest rates of additional morbidity were found among those who were heavy drinkers. And significant negative association between alcohol use and self-care behavior was found. That means the patients who are chronic alcoholic, they don't properly behave as far as diabetic diet or diabetic medicines are concerned, indicating that greater alcohol use was significantly associated with poorer diabetes treatment adherence. This is the original article which has been published. Clinical care and delivery, can we predict future improvement in glycemic control? In this study, those participated who reported that alcohol use was the reason of their poor adherence, were more likely to have unchanged HbA1c levels at a 12-month follow-up compared to those who don't consume the alcohol. What type of care and what you have to advise day after the night before? The patient who has consumed alcohol, what happened on the next day? 16 patients with type 2 diabetes having age of 39 plus or minus 7 with a duration of diabetes for 15 plus or minus 11 years, who consumed alcohol on regular basis, less than 28 units per week. Patient over the CGMS for 36 hours on the 2 occasions separated by 2. After the alcoholic drink, patients reported more than twice as many hypoglycemic episodes per day than after the placebo drink. So this is a self-reported hypoglycemic episode compared with the alcohol and with placebo. Non-reported episodes of severe hypoglycemia requiring the assistance of another individual. What is alcohol and hypoglycemia, which is very common in patients who are consuming excess amount of alcohol because of the degradation of glycogenesis. Gluconeogenesis is reduced and glycolysis is more. Alcohol may be associated with hypoglycemia in number of ways. Ingestion of even small amounts may impair the ability of the individual to detect onset of hypoglycemia at a stage when they are still able to take appropriate action. Hypoglycemia per se may be mistaken for the intoxication of the alcohol. So patient behaves like a intoxicated person even if he is hypoglycemic, so he doesn't get a proper care or proper treatment. Alcohol directly impairs hormonal co-regulatory response to low blood glucose levels. Small amounts of alcohol can augment the cognitive deficits associated with hypoglycemia in individuals with type 1 diabetes. Influence of alcohol on cognitive performance during mild hypoglycemia. What are the implications in type 2 diabetes? To examine the effect of mild hypoglycemia with modest alcohol intoxication on intellectual performance. Patients with type 1 diabetes, this was the study. Hyperinsulinemic glucose clamp was used to study the 17 subjects on 4 occasions. When the patient is euglycemia, he was compared with placebo, euglycemia with alcohol, hypoglycemia with placebo, and hypoglycemia with alcohol. Alcohol and hypoglycemia both independently impair their cognitive function, and together the effects are additive. Moderate alcohol intake and markers of inflammation, as already I have said, and endothelial dysfunction among diabetic patients. Moderate alcohol intake may have a beneficial effect on markers of inflammation and endothelial dysfunction in type 2 diabetes. This is a study which has been published, and it has been studied relation between alcohol intake and inflammation in 126 patients who returned blood samples in the health professional follow-up study and confirmed to have type 2 diabetes as blood was drawn. In this particular study, it has been shown that there is a reduction in inflammation and endothelial dysfunction. Diabetic patients with alcohol use and quality of life, relations with prescribed treatment compliance among other old males. The greater alcohol use was related to poor prescribed injection compliance and stronger expectations of immediate positive consequences of drinking alcohol were related to the several indices of lower quality of life. So the metabolic effects of alcohol in the form of wine in persons with type 2 diabetes mellitus. Diabetes participants who drank 1 glass of wine per day for a 3-month study period had a lower fasting glucose levels compared to the abstainers. But there was no difference between groups in postprandial glucose levels. Patients with type 2 diabetes should not be discouraged from using alcohol in moderation. Meta-analysis of the relationship between the alcohol consumption, coronary artery disease, and mortality in type 2 diabetes. There was a meta-analysis conducted in type 2 diabetes patients. Rates of coronary artery disease and coronary heart mortality were significantly lower in all 3 categories of alcohol consumers, whether it is consuming less than 6 grams per day, whether it is 6 to 18 grams per day, and if it is more than 18 grams per day compared to non-drinkers. So non-drinkers had a greater risk of mortality when compared to the lightest drinking group, although not when compared to the severe drinking group. The alcohol consumption and the risk of coronary artery disease in post-menopausal women with diabetes. This is a Women's Health Initiative observational study. Compared to non-drinkers, the multivariable hours across categories of frequency of alcohol consumption where confidence into here in this way, both frequency and quantity of alcohol intake were inversely associated with the risk of developing coronary heart disease. Alcohol consumption and risk of microvascular complications in type 1 diabetic patients. Alcohol consumption was associated with risk of proliferative retinopathy, neuropathy, and macroalbuminuria in U-shaped fashion. Moderate consumers with alcohol is 30 to 70 grams of alcohol per week had a lower risk of microvascular complications with odds ratio of 0.60, or proliferative retinopathy odds ratio of 0.61, neuropathy it was 0.36, or macroalbuminuria in multivariate adjusted levels. Alcohol consumption was not associated with occurrence of ketoacidosis or hypoglycemic attack. Synergism of alcohol, diabetes, and viral hepatitis on the risk of hepatocellular carcinoma in blacks and whites in the US. So the population-based case control study of hepatocellular carcinoma, 14 hepatocellular carcinoma cases, but no control subjects tested positive for hepatitis B surface antigen. Heavy alcohol consumption and cigarette smoking were found to be independently associated with statistically significant 2 to 3-fold increase in the risk of hepatocellular carcinoma. Subjects with a history of diabetes had an more 2.7 times more risk for hepatocellular carcinoma compared with the non-diabetic subjects. Synergetic interaction on hepatocellular carcinoma risk was observed between heavy alcohol consumption and diabetes. How assessment of intervention at risk of drinking. Treatment providers who deliver brief advice at the time of outpatient appointment are effective in reducing hazardous alcohol use. So the trial for early alcohol treatment is a treat for it. 10 to 15 minutes physician delivered intervention that contain educational elements and advice to reduce drinking have been successful among a group of non-alcohol treatment seeking heavy drinkers. It resulted in a significant reduction in mean number of drinks, frequency of excessive drinking during the previous 7 days, and reduced binge drinking episodes during the previous 30 days. So advice from the doctor also is helping. Findings were consistent with 6 months and 12 months as well as 14 months follow-up. What type of alcohol should people with diabetes choose? Beverages high in sugar such as soft drinks, mixers, sweet liquors, and pre-mixed alcoholic beverages are more likely to increase blood to glucose levels. Preferable to choose low alcohol beers or spirits with diet mixers. Low carbohydrate beers offers no advantage over regular beer. They often have higher alcohol content, can worsen overall diabetes. Managing alcohol-induced hypoglycemia, prevention is the best way of managing alcohol-induced hypoglycemia. Patients with diabetes should be advised to drink alcohol responsibly and moderation. Avoid binge drinking and ingesting carbohydrates while consuming alcohols and before going to bed. People with diabetes should be educated that alcohol can reduce the awareness of hypoglycemia, so they should be informed in advance. Blood glucose levels should be monitored more frequently before bed and morning to identify and reduce the risk of hypoglycemia. People with diabetes should wear some form of diabetes identification so that somebody will take their proper care. Otherwise, other people may mistake symptoms of hypoglycemic episode as alcohol intoxication and fail to help. When consuming alcohol, people with diabetes have someone else who knows that they had a diabetes and understands how to recognize their hypoglycemia. People with diabetes never stop taking insulin to avoid hypoglycemia by drinking. In summary, alcohol influence glucose metabolism in several ways in people with diabetes. Alcohol inhibits with gluconeogenesis and glycogenolysis, which may lead to hypoglycemia. Acute intake without food may provoke hypoglycemia, especially in cases of glycogen stores. Moderate consumption of alcohol is associated with reduced risk of atherosclerotic disorder. Apart from the effects on lipid metabolism, hemostatic balance and blood pressure, alcohol improves insulin sensitivity as well. In case of moderate and sensible use of disturbance in glycemic control, weight and blood pressures are limited. Excessive intake of alcohol may not only cause loss of metabolic control but also accelerate the favorable effects on the TV system. Thank you very much.
Hello. Thanks a lot for excellent talk and the topic which is always in mind of patients, the doctors, because how much we should tell the patient to take and how much we should restrict, all these things are in the mind and the doctor and patient both are confused. You have given the knowledge to the doctors and we will translate these messages to the patients also, but in simple language patient तो ये नहीं समझता है तो वो तो बोलता है कि पाव पीना है अद्दा पीना है तो what you should recommend?
Recommendation to the what type of drink he is taking. Depending on that, he is supposed to take the drink. Suppose he is taking wine, he is allowed to take 150 ml. He is taking a beer, it should be around 300 to 340 ml. The hard drinks, it is around 45 ml. Depending on the content of the ethanol, percentage of ethanol in the alcohol, you have to advise accordingly.
Any question?
And moderate type of drink, it is advisable, but it is not advisable to drink a drink. That is the first thing. They are not recommending anyone to take a drink if he is not taking drink. If somebody is taking a drink and he is diabetic, he should be responsibly take a drink. That's important.
Practically what we have seen, they don't take the night tablets or the OHAs or any insulin which we prescribe if they take the alcohol. So what message we should give them?
Basically, depending on his blood sugar levels, he has to take a call. Because every individual is a different one. Suppose somebody is taking everyday drinks, that much of tablets he is taking, his blood sugar is well controlled. Not supposed to abstain from the medicine. He can take the medicine. He has to follow certain norms. He has to, because so many people take a regular drinks and the medicines as well. So I don't think there is
माइंड में है कि अगर हमने दवाई खा लिया तो हमारी शुगर लो हो जाएगी, इसलिए वो खाते ही नहीं.
You have to make him aware that this can happen if you consume more. He is acquainted with that. I think he can continue.
Any question from the audience?
I have a comment.
Thank you. Thanks a lot, sir.
Thank you very much. Thank you.
Excellent talk. Over to the organizers.
Thank you so much, respected chairperson. I request persons to felicitate Dr. Narayan Devgaonkar, sir.
I request Dr. Prasad Jod, President AMF, to felicitate our chairperson, Dr. Gillurkar sir and Dr. Dengra sir.
Now we move on to the next session. This Sky Walk and Talk. For the first talk, I would like to invite the chairpersons of the session, Dr. D.S. Vasnik sir and Dr. Sheetal Sane ma'am. Dr. D.S. Vasnik sir is a senior physician from Chandrapur. Dr. Sheetal Sane ma'am is a consultant physician who has keen interest in diabetes and health-related education activities. For this session, Dr. C.S. Yagnik sir would join us online through Zoom. Over to the chairpersons.
Okay, do I start?
First of all, myself and my co-chairperson, Dr. Vasnik sir, we thank organizers for giving the opportunity to chair the session. Dr. Yagnik is a big figure in diabetology and everyone knows it. His introduction is written over the slide. And the topic he will be delivering is elephant in the womb related to GDM and big size infant and macrosomia. So I hand over the mic to sir.
Okay, are you able to see my slides? Yes. Thank you. Okay, thank you, Chairperson. Thank you, Sunil, for the invitation. And I have chosen a topic which I have been speaking for last few years because of my worries about what we are doing. And the GDM who benefits is the general sort of subject of the talk. And I chose the title Elephant in the Womb from a book which I read. And I've shown that book on the slide here. It's called The Elephant in the Womb, Declaration of a Sudden Mother. And I think all of us will benefit by reading that book, how the mother and the baby actually look at the pregnancy and how they were helped by their friends. I'll start by saying that gestational diabetes, as we understand, is diabetes diagnosed during gestation. And the two questions I'm going to raise is, do we really know what is diabetes in the pregnancy? And are we sure it's only gestational? And both of these issues, I think, will have substantial implications for our practice if we try to really research on them and find the correct answer. I voiced my concern in an editorial, which was an invited editorial in Diabetes Care about 12 years ago. And I think first concern I raised was, is GDM as a de novo diabetes of pregnancy? Then I said, what's the life course trajectory of a woman who is diagnosed with gestational diabetes? Because periconceptional programming is the major event in pregnancy which determines the future risk for the baby. We have been all very glucocentric. Are there other nutrients like lipids, amino acids, and micronutrients? And Norbert Frankel had told us that lipids and amino acids may be more important. And we in our research had shown that micronutrients are important determinants of fetal health. There is also a mechanism of maternal constraint. And I don't think we are going to discuss that in detail, but maternal insulin resistance in pregnancy is a driver of fetal growth. And the issue is, do malnourished mothers have to be more insulin resistant to produce normal sized babies? And that has obviously implications for the Indian scenario. And finally, have our efforts to treat GDM reduce offspring adiposity either in the short or the long term as it affected diabetes pandemic? And now we add a question, has it done any good to the mother in the long term? So do we really know what diabetes is in pregnancy? And this is the classic APO study, 4 outcomes related to, 3 related to baby and 1 related to mother. Either big baby, neonatal hypoglycemia, C-peptide more than 90th centile, or cesarean section rate. And as you can see, all these outcomes show a continuous association either with the fasting or with the 2-hour glucose during an oral glucose tolerance. There is no threshold, there is no inflection, but still a committee sat and decided to call something diabetes and something normal. That I think has been a problem with this study. Otherwise, beautifully showing that the association between outcomes and maternal glucose is a continuous monotonic one. Is glucose the only nutrient which affects baby's growth? And here I have shown our data in Pune maternal nutrition study that actually it's not only glucose, but cholesterol, triglycerides, HDL, not shown in this slide, are all associated with different measurements in the baby. Either the weight, the length, head circumference, subcutaneous fat, abdominal circumference, omega. And in fact, some of the associations are stronger with cholesterol and triglycerides. This was recognized by Norbert Frenkel, who actually called it a fuel-mediated teratogenesis to include these non-glucose. But in practice, A, we never measure lipids in pregnancy. B, if we measure, we don't know what to do. A lot of research is necessary in this area. Third thing is just the criteria of gestational diabetes, even after so-called standardized IADP criteria, many countries have discarded these. And today, this was a review written by Mukesh Agarwal from Dubai in 2015. In different countries, they use different criteria, either because the main criteria are inconvenient, they would put too much load on the system, or for whatever reason that country doesn't agree. This in itself tells us we really don't know what is diabetes in pregnancy. So is it only gestational? And this is one of the reviews written about predictive and diagnostic biomarkers for gestational diabetes in early pregnancy. So they were trying to find out what abnormalities early in pregnancy predict glucose intolerance in later life. And you will see here a whole lot of very fancy molecules. RBP4, SSBG, FABP4, adiponectin, vispatin, tetuin, various miRNAs, various adipocytokines, whatnot. You will see a notable absence of glucose there because it's the cheapest, and I think that's the most relevant molecule to measure, or HbA1c, which has been shown to predict. But both of these actually tell us that abnormalities in early pregnancy are a marker for abnormalities before pregnancy. And all these molecules which we show here and the clinical history of family history of diabetes, obesity, previous JDM, etc. are all similar markers which are present much before pregnancy. Are there any studies which we can tell us? Given the short duration, I have selected only some slides, but this is a study reported from Kaiser Permanente, published in 2016. They were investigating whether the women diagnosed with gestational diabetes have any metabolic abnormalities in a health visit they had done to the clinic many years before pregnancy. So these are the characteristics of the women many years before pregnancy, when they came for a health checkup, they had a higher family history of diabetes. Their pre-pregnancy BMI was higher. Their actually glucose concentrations were higher, cholesterol was higher, HOMA-IR was higher, insulin concentrations were higher. In other words, all the things which we associate with diabetes were already present many years before pregnancy. And I think the best data now has come from the Pune maternal nutrition study, because in 30 years now, starting with mothers before pregnancy in 1993, we followed them through pregnancy, we have followed their children, and 200 of the 300 plus girls who were born in the study have themselves become mothers and delivered a baby. So we are now able to relative beta cell function in relation to prevalent insulin resistance, what we call disposition index. They had lower disposition index from 6 years of age, again at 12, 18, etc. In other words, their beta cells were not matching the prevalent insulin resistance. Simple story, what we call gestational diabetes in pregnancy, these women have abnormalities of glucose and insulin metabolism right from childhood. And if I were to add mother's glucose in her pregnancy here, that would again show something very similar. So who benefits? Does our treatment affect the pregnancy outcomes? Does it affect the long-term outcomes, either in the mother or the baby? Two major trials, Apnea and the Landon trial in US, showed that preeclampsia was reduced in mothers who were in the intensive treatment group. Cesarean delivery, a bit doubtful, but in Landon, yes. Induction of labor was higher in Apnea. So there is a downside to being diagnosed as gestational diabetes. You end up with inductions because the thresholds are reduced. Doctors are very keen on doing something. And for the child, the main outcomes which were reduced were reduction in the size of the baby. So either LGA or macrosomia, and in Apnea trial, any serious perinatal complication. So predominantly the benefit for the child is that we are helping it to thrive. And that has been a consistent achievement in all intensive treatment programs in GP. Now what about long-term effects for the mother? This is a paper you should all read from Nikhil Tandon and his group in All India Institute. It's a multinational study. And what he did was, he followed up women who were diagnosed with gestational diabetes within 3 months of delivery, did their glucose tolerance test, and those who were normal of pre-diabetic were entered in a randomized controlled trial to help them reduce the risk in future. In very simple terms, the intervention did not prevent subsequent glycemic deterioration. And the meaning given in JAMA is that this study found that a lifestyle intervention was not effective in reducing glycemic deterioration, which occurred in a substantial proportion of women with recent GDM within 2 years of childbirth. Now, of course, COVID had interfered with this intervention. Whether that reduced the size of the effect, we don't know. So more research will be necessary. But on face of it, whatever we did not prevent deterioration of glucose intolerance in the mother. What about children? In a Apnea trial, follow-up in South Australia Center, no change in BMI Z-score, height or weight Z-score at school entry, and no reduction in the obesity, that is BMI more than 85th percentile. In simple words, intensive intervention in the mother during gestational diabetes, no reduction in obesity adiposity in the early childhood. In London trial, very similar things. Whole lot of things measured in the baby, No benefit on blood pressure, cholesterol, triglycerides, fasting glucose impaired, waist circumference, BMI more than 85th percentile or 95th percentile. In other words, intensive treatment of GDM as it is done in current practice, that is diagnosing GDM between 24 and 28 weeks and treating it, hasn't given any benefit either to the mother or to the baby. Indian scenario. Majority of pregnancies are unplanned. There is no preconceptional glucose measurement. But like in our study, we have shown that glucoses are elevated from before. GDM is commonly diagnosed using local criteria which have no outcome association ever studied, and this places a big burden on the health system. Majority of diagnosed GDM women receive intensive treatment, and cost of GDM pregnancy is many times higher than a normal pregnancy. National average birth weight in India is 2.8 kg. And in the NFHS score, the low birth weight rate was 15 to 25% across different states. In NFHS 5, it reduced a little bit. In general, the ODMs, that's offspring of diabetic mothers, in all our studies have approximately 100 grams overweight compared to the normal babies. So instead of 2.8, they go to 2.9 or up to 3 kg. LGA is less than 10%. I am using international criteria. And SGA is still not uncommon. Medical thresholds are reduced, therefore investigations, inductions, cesarean sections, and ICU admissions happen in a lot of pregnancies. And treatment of GDM has not really reduced the long-term risk for mother or baby, as I will show you in our follow-up studies. There are a few long-term follow-up studies, and there are no RCTs of GDM in India. This is our follow-up, which is now being published. On average, like say, we studied about 200 children born in diabetic pregnancies at an average of 10 years after delivery. In those who were on average 15 years, there was a considerably higher prevalence of pre-diabetes compared to those born in non-diabetic pregnancies. So 37% as opposed to 20%, and 5% were already diabetic at this mean age. And those who were younger than 10 years, we did only a random capillary test. That was also higher. In other words, intensive treatment of GDM, which is done in my unit because of the current standards of practice, actually has probably not done much, though this is not a randomized data. Given the clinical practice, we are unlikely to do a randomized control trial unless it is given in a picture. So what I think is the problem? I think our problem is the current practice misses the periconceptional period very badly. By definition, our gestational diabetes is diagnosed in later pregnancy. And during periconceptional period, a whole lot of metabolic and cellular mechanisms are operating about gametogenesis, fertilization, implantation, embryogenesis, and placentation. Perhaps the most important is the epigenetic reprogramming of the embryo, which happens within 48 to 72 hours of conception. Woman doesn't even know that she is pregnant at that time. And as Wolpert said, it's not birth, marriage, or death, but gastrulation, which is truly the most important time in your life. And you will remember from your embryology days, gastrulation, the cell layers are let down and their fate is decided. Again, fetal insulin hypothesis given by my friend Andrew Hattersley. He came from the low birth weight side on a genetic side. But we have in India something like maternal nutrition driving it. And therefore, the lower birth weight, either because of genetics or because of poor maternal nutrition actually has higher risk of adult onset type 2 diabetes. And I dare say that in type 2 diabetes treatment, we are trying to reduce the birth weight of the baby by intensive control of maternal diet and glucose. I am very worried about this, and I would go out in proper research. So what are my random thoughts? The pregnancy glycemia and other nutrients are a mechanism to promote fetal growth. In populations which have been multi-generationally undernourished like Indians, is higher glycemia in nature's way to improve fetal growth in undernourished populations. When and how it may go wrong in convert into diabetes, that's what we need to learn. The elephant in the room may be insulin resistance, and I have a very big presentation now on more than 13,000 pregnancies across the world where we have found very interesting things. How Indian mothers are not increasing their insulin resistance in the pregnancy like the Western women. So we need to really think about it. And that's my suggestion. This is a takeaway message for him, that the elephant in the room, I think, actually is suffering from various things like denial, ignorance, and so many things. The baby in the elephant sort of uterus is asking for mother's help, and mother is saying that my fault was to believe everyone. So I think really we need to take a serious action, research on deciding what glucose levels are harmful in pregnancy. Secondly, when to diagnose this. Really, we should be doing it from before pregnancy. And what should be the strategy for treatment. So I think there is a lot to learn. The outcome should be relevant and sensitive to the local situations. There's always a tale of two worlds, the affluent world and the developing world. We need a national database or a registry. Interventions need to be ethically driven with a primum non nocere sort of phenomenon. There's do no harm. Personalized guidelines may be important. Diagnosing GDM in pregnancy appears to be too late. I have no doubt about this. Preconceptional detection and correction is what should be our approach. And this means that we want to eliminate diabetologists from this and go to public health. From the clinic, we want to go to community, and Indian government is doing a whole lot of programs which will ultimately help us in this, but the policymakers really don't know the connection between their efforts and the risk of gestational diabetes. Thank you very much.
Hello.
Hello,
Can you hear me?
Yeah, I can hear you.
Okay, so delightful presentation.
Thank you, buddy.
But the point is, always to challenge the current dictum is a very important issue. And in the Indian setting, you've been able to show that the current thinking is not working. And what I wanted to say was, what is your view then? Once we get gestational diabetes, what should we be doing with the woman?
Right. I mean, my first objection is about the word gestational. And I'm saying the gestational diabetes has its roots in a pre-gestational period, and therefore we should really get rid of this gestational idea. That means we have to improve the health of the young girls for their nutrition and metabolism from much before they become pregnant or even before they marry. And that's what we actually propose from the DOHAD world, the developmental origins of health and disease, take that to within pregnancy. So my basic like say heme, is that we need to start before pregnancy as early as possible. It should be a community-based approach. And as you know, Jeffrey Rose wrote about community-based approach versus the sick individual approach. And what we are just now doing is a sick individual approach in pregnancy that itself is wrong. And therefore, we really need to shift to the left. Would you agree with that, Tibini?
I think that's a great idea, but you see, you have the entire population of Indian population has intrinsic insulin resistance.
That also I am now seriously doubting the way it has been put. I have been one of the guilty persons to have propagated it. But now that I have actually started looking at disposition index, I think we completely missed the boat in all our old studies by concentrating only on measurement of HOMA S and not looking at beta, not looking at HOMA beta in relation to HOMA S. So we are now rewriting all our chapters. If you see our paper in Diabetes Care December issue, it's high prevalence of pre-diabetes in Pune maternal nutrition study at 18 years. And there we again stress that pre-diabetes at 18 years is predicted by low disposition index right from 6 years of age. So I think there is a basic thinking which needs to change. It's not very easy, but trying to diagnose gestational diabetes, even in early pregnancy, I think is a non-starter. It's trying to close the doors after the horse has bolted.
Okay.
Paresh, do you remember John Jarrett?
John
Jarrett?
Yes.
Keen and Jarrett, the pair?
Yeah.
So John Jarrett wrote in 1997 that gestational diabetes is a case of a glucose intolerant woman who also happens to be pregnant. And I think I now firmly believe.
Okay. So basically, you're saying that the whole thing predates pregnancy anyway, and pregnancy is superimposed on the condition.
Yeah, and if we are looking at next generation, the periconceptional programming, substantial part of it is over within 48 to 72 hours of conception. Therefore, the only way you can influence it is by starting much earlier. And now the research which I saw when I visited Jocelyn a couple of years ago, Elizabeth Patty, she is showing that if you treat male diabetic patients before they conceive their wives, good glucose control is changing the epigenetic signatures in the sperms. I mean, that's a brilliant study. So it's not only mother, but it's also young boys whom we need to concentrate. That's what the DOHAD field is just now trying to propose. I invite you to DOHAD meeting in Vancouver, 27 to 31st August.
Okay, thank you.
That was wonderful input, sir. And I feel the take-home message is that now
So I had made a slide actually that dropped it. I think yesterday I saw Dr. Seshia show a slide from Norbert Frenkel that best time to influence the outcome for the next generation is pregnancy. So it may be true for many things, but certainly I think the diabetes programming in pregnancy happens much before we understand that woman is pregnant. So it has to be pre-gestational. I have contributed to reviews in Lancet. There were 3 papers, Special Commission on Preconceptional in 2018.
Thank you, sir. So we need to focus on our adolescent group. That means adolescent girls and boys as well. Reduce to bring in awareness for the health. So, for the want of time, we have been asked to close the session. Thank you, sir.
Thank you very much.
Over to
Thanks for your
organizers.
patience. Really nice meeting.
Thank you very much, Dr. Yaznik, sir. And as usual, it was one of the wonderful deliberation today. And now we go ahead with the next session, which is going to be by Dr. V. Mohan. So V. Mohan, sir, has joined. We have a record. We'll start. We invite the chairperson, Dr. Puranik and Dr. Vivek Bhalerao. Puranik is a very senior physician from Yavatmal, and Dr. Vivek Bhalerao is a senior physician from Nagpur and past president of Diabetic Association
Sunil
of India.
Gupta, Kavita Gupta and their team put up a fantastic conference, and I'm privileged I would like to express my heartfelt.
Before we start, we will felicitate our earlier chairperson, Dr. D.S. Vasnik sir and Sheetal Sani.
We can start with.
Good evening, ladies and gentlemen. First of all, many thanks to Dr. Gupta for giving us the chance to chair this session, that too under Dr. Mohan. The topic is precision medicine in diabetic care. As all of we know, the 4 pillars of control of diabetes is diet, exercise, drugs, and monitoring of the blood sugar. We had the prescription for exercise. We give prescription for diet, and it's our duty to prescribe drugs along with lifestyle modification. So we have many drugs to prescribe. Initially, we have secretagogues, insulin sensitizer, and now many more drugs they are available. Up to the oral insulin, we have heard 2-3 hours before. Now, choosing a proper drug for a patient, very important. So, what I gathered from the title of this lecture, Precision Medicine in Diabetic Care, what I gathered is a appropriate drug for a appropriate patient in a appropriate doses, considering age, comorbidities, social and financial status of a patient, which has to be considered. And to address this issue, we have none other than Captain of Captains, Dr. V. Mohan. Dr. V. Mohan needs no introduction. So I straightway request Dr. V. Mohan sir to start his deliberation.
I would like to express my heartfelt thanks to Dr. Sunil Gupta, Kavita Gupta, and the organizing committee of Hello Diabetes and Academia 2022. Every year, Sunil Gupta, Kavita Gupta, and their team put up a fantastic conference, and I'm privileged to attend every year. I've seen this year's program also, and it's absolutely fantastic. Thank you again, Sunil and Kavita and team, for inviting me to give this talk. Today I'm going to talk about reversal of diabetes, hype or reality. This is a topic which is gaining a lot of importance, and it's very essential that as diabetologists, we not only know about this, but also give the right messages to people, because non-doctors, software engineers, and everyone else is getting into this field and almost making us feel as if we are the only people not doing this reversal and everyone else is doing the reversal. So that is why I thought I will talk about this particular topic here today. When we look at the natural history of type 2 diabetes, we know that there is a stage of normal glucose tolerance, then there is a stage of pre-diabetes, finally we go to stage of clinical diabetes. We don't control it properly there, you can end in the complications of diabetes. It's important to know that once you reach the stage of complications, there is no reversal. In fact, the disease has a tendency to pull us from one stage to another, to another, to another. And that's how these yellow arrows you can see on this red line, how it is the disease is progressing from one side from one stage to the other. And this is what is called as left to right, or the progression of the disease. But what if we go from right to left? That is called reversal of diabetes. But note that this blue arrow only starts with the stage of clinical diabetes. At the stage of complications, once your eye, kidney, heart, nerves, and other organs are affected, you can't talk about reversing the disease at that particular time. But if it's early in the stage of type 2 diabetes, yes, you can reverse it to pre-diabetes, and maybe from pre-diabetes to normal as well. And that is what reversal is all about, and I'll explain further as we go along. Traditionally, we have always talked about diabetes, type 2 diabetes being a progressive condition. After 10 years, people 50% need insulin. This is all true, because if you don't look after yourself, if you just take medicines and you don't look after your lifestyle, if you don't attempt reversal, then you are only treating the disease, not curing it or reversing it. In October 2021, the American Diabetic Association brought out this consensus report where they defined what is remission. So the ADA defines remission and says that that is the most appropriate term. Reversal implies that there is a total cure of the disease, which is not true. The ADA says cancer goes into remission. Just like that, diabetes can also go into remission for some time. And in anybody who has had diabetes and they have been on treatment and on oral drugs or on insulin, if the A1C is above 6.5 in them, now a stage comes when, after treating, usually after weight loss, the A1C becomes normal, less than 6.5%, for at least 3 months without any medicine. All medicines are stopped, and yet it is below 6.5%, or the fasting is below 126. ADA says that that is remission. To me, I think a little stricter criteria should be used when you call it as remission. I'll tell you why. Suppose somebody had 6.6 HbA1c and was given metformin. After about 3 months, metformin is stopped, and now the A1C is 6.4, 0.2% reduction. We'll say they are in remission of diabetes, isn't it? Only 0.2% has reduced in the A1C. So I think these criteria are a bit liberal. I would say for a real remission, A1C should be below 5.6, and only then you can call it as remission. Remember also that in type 1 diabetes, fibrocalcific pancreatic diabetes, post-pancreatic surgery, when you get diabetes, post-pancreatectomy, for example, remission is not possible at all. Even in type 1 diabetes, only a honeymoon phase or a temporary remission is possible. In type 2 diabetes, it's possible, but only in a targeted population, not in everyone. And I'll tell you about that as we go along. Now, these are some examples of diabetes remission. There could be others. I've just put down 6 conditions. After severe weight loss, you can get remission. After gestational diabetes, once the gestational diabetes settles down after the delivery, the lady's sugars come down to normal. That is a stage of remission. Of course, the diabetes may always come back. Type 2 diabetes can come back. After bariatric surgery, now we have shown that only after until around 8.5 years after the diagnosis, bariatric surgery is possible in our series of the cases that we did. After that, we have 14, 15, 20 years duration. Very difficult to get remission of diabetes even after bariatric surgery. Stress-induced diabetes, severe stress, the stress goes away, you can go in remission. Drug-induced diabetes, we all know this, steroid-induced diabetes. During COVID, very recently, a lot of people have been put on steroids and they developed diabetes. The steroids were stopped, many of them went back into remission. Now, I have shown and others have shown that just after the diagnosis of type 2 diabetes, if you treat them aggressively and you give them a short course of insulin, their sugars can go down and it can become completely normal. And they can even stop even tablets and they can go in the stage of remission. I'm not going to talk in this lecture about 2, 3, 4, 5, and 6. I'm just going to talk about the severe weight loss part of it. Now, how to achieve remission? Diet obviously plays very important role. People think just by doing some walking or jogging, you can get remission. Without diet control, there is no remission. You have to be on a very strict diet, either a very low calorie diet or a very low carbohydrate diet. Both seem to work very well. Of course, intensive physical activity always helps, and that's also needed. Stress reduction I already talked about. And then I also talked about this early and aggressive treatment of type 2 diabetes. Now, there is a debate whether the low calorie diet is more important or the low carbohydrate diet is more important. According to me, I've looked at the evidence. Both are equally effective. In India, we take 60, 70% carbohydrate, and we call it very high carbohydrate diet. If you're able to reduce the carbohydrate and bring it drastically down, in fact, very low carbohydrate diet is less than 10% carbohydrate or less than 20 to 50 grams of carbohydrate in the whole day. If you cut your carbohydrate that much, you can go into remission. And then with very low calorie diet, less than 800 calories for the whole day. Breakfast, lunch, dinner, all put together, less than 800 calories. In that case, you can get into remission of diabetes. How does this remission occur? What are the two defects in type 2 diabetes? First is insulin resistance. Second is insulin secretory defect. Now, when you have a positive calorie balance, what happens is that this calories get converted into fat, triglyceride, and gets deposited in the liver. In the portal vein, you go into the liver, and the liver gets deposited there. Now, this liver, which is supposed to be very sensitive to the action of insulin, we have a lot of fat there. And later on, even fibrosis and all that occurs, you develop severe insulin resistance. So that means the insulin is not working. So the first defect you have now. Later on, this fat spills into the pancreas, and the pancreas starts getting filled with fat. When that happens, the insulin secretion also goes down. So now you've got both the defects now. Insulin secretory defect, insulin resistance. Now what happens if you have negative calorie balance? This fat will start breaking down first, the liver fat. And later on, within 1 week it will happen. And after 8 weeks, the pancreatic fat will also melt. And then the insulin secretion will improve, and then insulin sensitivity also improves. So this is what I said, within 7 days, hepatic fat goes away and insulin sensitivity improves, and after 8 weeks, pancreatic fat also goes away. Here is the evidence from Roy Taylor, who showed that this is in weeks, 0 week, 2 weeks, 4 weeks. You can see by the first week itself, the hepatic fat beginning to fall, and with that the plasma glucose is falling, become normal, and the hepatic glucose production is also falling considerably. Here you can see liver fat measured by various radiological imaging before and after bariatric surgery. Type 2 diabetic patients and in those without diabetes, you can see the red, the before surgery becoming green with a substantial reduction in the liver fat. The 10% liver fat has now become 4% or so. You can see the considerable drop there. This is the pancreas. What happens after 8 weeks? The pancreatic fat comes down, and with that, the insulin secretion begins to go up. Did you know that type 2 diabetes is caused by less than 1 gram of fat in the pancreas? But to get rid of that 1 gram of fat, you have to lose 15 kilos in weight. If you lose 15 kilos, that 1 gram of fat will go and the insulin secretion will improve. Now, the best example, there are very many small studies done on 8 people, 10 people to show remission. But the best remission trial comes from the DIRECT trial. DIRECT stands for Diabetes Remission Clinical Trial, or the DIRECT trial. This DIRECT trial, they had large number of people, about 300 individuals, with very short duration of diabetes. Note that they took people with less than 6 years duration. They also had severe obesity. So they had a lot of weight to lose. And these are people who lose weight. And none of them were on insulin. So that means early stages, beta cell function is good. They are on tablets, short duration, highly motivated people. What they did was 150 of them went to intervention arm, body weight loss. Despite being on this diet, some people did not lose weight. And if you lost less than 5 kg in weight, there was no remission. 5 to 10 kg, little bit more. 10 to 15 kg, it went up more. If you lost more than 15 kg in weight, as I already told you, 86% achieved remission, which is very good. But note that 14% did not achieve remission. That means out of 36 cases, 31 achieved. 5 people even then did not achieve remission of diabetes. Then what happened was, when they followed up these people at the end of 1 year, 20 people were followed up, 6 more converted to diabetes from this group. That means the percentage of remission came down from 86% to 70%. So already 30% have lost their remission. And this is the best follow-up that we have up to now. Beyond 2 years, we don't have any evidence. So the conclusion of direct trial was, you take the best motivated patient, short duration, less than 6 years, and very much overweight people. And if they lose more than 10 to 15 kgs in weight, about half of them you can get remission. The other half are not able to get remission. I have coined what is called as the ABCD mantra. So this mantra summarizes the people who will respond or likely to respond to the reversal techniques or the remission techniques that we talked about. A stands for A1C. A1C should not be very high. In the direct trial, it was 8.4%. So those who had 8 or below, percent or below, are the mild one. They are likely to reverse. If you have HbA1c of 10, 12, 14, 16, you cannot expect reversal in that group. Body weight is high. As I told you, BMI went to 47. And they are the ones who are likely to achieve remission. C-peptide should be good. That means insulin secretion will be very good. Your beta cells are all gone. How can you achieve remission? Short duration, I already told you, duration diabetes should be short and highly enthusiastic and motivated person, that is E. If you remember this A, B, C, D, E, you will be able to remember who are the ones in whom remission can work. However, remember that beyond 2 years, we don't have evidence at present. Also, we don't know in Indians how it will happen, because we have already shown through our prevention trial that where 58% of people could achieve prevention of diabetes in US and Finland and other studies. In India, all the studies which have been done, including ours, only 28-30% could achieve prevention of diabetes. So reversal of diabetes, whether we'll get the same results as we got in the white Caucasian, is something we'll have to see. And the last point I want to tell you about is that re-reversal of diabetes or relapse of diabetes occurs in a large percentage of people. What is this re-reversal or relapse of diabetes? I'll show you a case study which will illustrate. This is a 35-year-old male person, 6 years duration. He is treated with tablets and insulin. He is very keen to achieve remission. He also wanted to lose weight because he is about 123 kilos in weight. His one aim in life was, I'll bring it below 100. Highly motivated. So he lost a lot of weight and is very happy, achieved remission. He finally stopped all his tablets and insulin, still maintained remission. This is how his weight went. From 123 to 118, 116, 102, and then 99. You can see that he has worked very hard for about 2.5 years and achieved, without bariatric surgery, by diet and exercise, he lost 24 kilos and he achieved remission of diabetes. Now, this is how his HbA1c came down from 8.4% to 7, 5.6, 5.4. This 5.4 is without any medicine. He stopped all medicine and he achieved remission. Look at his fasting blood sugar, 132 became 89, postprandial 293 became 110. So this 89 fasting and 110 postprandial is after he has stopped all medicine for a few months. So it is true remission, no doubt about it. Okay? The liver function showed improvement. I told you the liver fat comes down. The SGOT came down from 61 to 16. SGPT came down from 94 to 20. So now he's got normal liver function as well. Ultrasound liver also showed that the fat had disappeared. Now what happened? He stopped all his medicines. He forgot about his diabetes and he told everyone that he was cured. Okay? We tried calling him back and said, sir, why don't you come and check up? He said, why are you calling me? I'm cured. You go and find diabetic patients. I'm not a diabetic patient. I'm totally cured. So we told him, sir, there is no such thing called cure. You are in a remission. So it can come back anytime. He refused to believe. He said, no, no, no. You guys are all commercial. You are just calling me back to make money. So I am cured. Don't go after people like me. They are all cured now, completely cured. I'm going to enjoy my life from now on. So we stopped calling him after some. After 9 months, he came back. He said, I'm not feeling well. Please examine me. So when we checked him up, we found that his weight had increased from 99 to 112. Now remember, he had lost 24 kilos in weight. Now he has gained only 13. Okay, which means he's still 11 kilos down compared to where he was. He's still 11 kilos down. So we would have thought that maybe his HbA1c has gone, remember, to 5.4. Okay, it would have gone to 6 or 6.5 maybe. But actually when we tested, his HbA1c went to 9.6. He had neglected so much, thinking he's cured, he's cured, he's cured. He went on psyching himself saying, I'm cured, I'm cured, I'm cured. Okay, you should remember that there's no such thing called cure in diabetes or in cancer for that matter. It can always come back. We all know about metastasis coming back in cancer. Like that, diabetes, when it comes back like this, it can come back with a bang. And I'm sure all of you have seen it. After listening to my talk now, many diabetologists have sent me and said, you also got this case. Look at how it happened. Re-reversal, re-reversal. They've all started. Look at his blood sugar. 89 fasting became 247. It's almost like his PP sugar. And then his PP went from 110 to 321. He never got such bad sugars in his life. Look at the liver function. 16 SGOT became 66. SGPT from 20 became 152. His liver is now full of fat again. Positive calorie balance, I showed you that. The twin cycle. So like that, exactly, all the liver fat has come back. Pancreatic fat has come back. And he has developed diabetes again. All that happened was he lost weight, got rid of the fat. Fat has come back. Diabetes has come back. So this is an example of re-reversal of what I call as a relapse of diabetes. And I've seen several such cases, re-reversal. I'm sure all of you would have seen it. So these are my concluding statements. First of all, I think now that remission has been shown to occur, I think we should also talk to our patients and start encouraging the targeted population, the ABCD I told you. Those people, we should tell them, look, it's possible for you to achieve remission. Do you want to work on this? It's very hard, but we will help you to achieve it. Then you choose the dietary approach of your choice. Either a very low calorie diet can be used or a low carbohydrate diet can be used. My only point is, don't try something which is unsustainable. Because after 2 months again, they're going to stop everything and then come back. Why go through this yo-yo effect? It's probably bad for your health to keep doing that. If they do something, let them do it on a long-term basis. And they need a lot of support because people, to achieve this remission, a lot of motivation and a lot of encouragement is needed, which dietitians and educators should continuously give them. And finally, we must remember that if they relax and they leave off everything, re-reversal of diabetes or relapse of diabetes, as I have shown you, can occur. But this is hardly emphasized. Only recently, I have started talking about this the last few months, but I have not seen this earlier in any conference, anybody talking about this. And I think it's important for us to share this with our colleagues and also with our patients. That's the reason why I chose this particular topic. I would like to once again thank Dr. Sunil Gupta, Kavita Gupta, and the organizing committee of Hello Diabetes Academia 2022 for inviting me to give this talk and for arranging this fantastic conference. My heartiest congratulations to all of you.
Thank you, sir, for elaborating us on a very novel concept of remission of diabetes with the help of diet and exercise. And it is always duty of a physician or treating doctor to imbibe on the patient's mind that diabetes is not cured, but it may go into remission for some time. So thank you, sir. And there are any questions?
can we give dapagliflozin to maintain that phase of remission as we give aspirin in the ischemic heart disease?
Sir, the session was recorded. Actually, sir is not keeping well, so he could not join live.
Okay, thank you, and I also thank the organizers for giving us this opportunity to chair this session. Thank you, thank you.
Thank you so much, sir. I would like to invite Dr. Vijay Neglur, sir, to kindly felicitate the chairpersons for this session, Dr. N.K. Puranik, sir, and Dr. Vivek Bhalerao, sir. Thank you so much, sir. With this, now we move on to the next session. For this session, I would like to invite the chairpersons, Dr. Anita Basavraj, ma'am, and Dr. Bala Subramaniam, sir. Dr. Anita Basavraj, ma'am, is an associate professor in the Department of Medicine and unit in charge at BJ Medical College and Sassoon General Hospital, Pune. Dr. Bala Subramaniam, sir, is a senior consultant physician from Nagpur. We welcome you, sir and ma'am. For this talk, Dr. Anup Misra, sir, Padma Shri, is going to join us over Zoom.
Good evening to everyone present in this hall. A little correction in my introduction. I am professor and head of the Department of Medicine at Government Medical College at Miraj and PVPGH Sangli. I thank Dr. Sunil and his team for inviting me as chairperson. It is a wonderful conference. And the talk today evening is by Dr. Anup Misra. He's a Padma Shri. He's an executive chairman, Fortis CDoc Hospital for Diabetes and Allied Sciences. He's the director, National Diabetes, Obesity and Cholesterol Foundation. He's a former professor and head of the Department of Medicine at All India Institute of Medical Sciences, New Delhi. He has more than 300 published research papers. He was awarded in 2007 Padma Shri by President of India and in 2006 Dr. B.C. Roy Award. He is the author of book Diabetes with Delight. He is also editor-in-chief and associate editor of many of the journals. His topic is very interesting. Pre-diabetes, phenotypes, telomere length, and vitamin D. A lot of new things to understand from his talk. Over to you, sir.
Good afternoon. First of all, let me thank Dr. Sunil Gupta and his team for giving me this opportunity. Sorry, I can't be with you because of certain pressing engagement, but I hope you get the message from my recording. I'll be talking about pre-diabetes, phenotypes and implications for metformin and vitamin D. And I'll keep you abreast of some of the recent data pertaining to Indian population and important points which pertain to possible changes in the management. So what is pre-diabetes? We all know about it, but just to recap, broadly classified by blood sugar values as well as A1C values. And it has two components, impaired fasting glucose and impaired glucose tolerance between 100 and 125 fasting and between 140 to 199 post glucose values are considered to be having, these people are considered to be having impaired fasting glucose and impaired glucose tolerance, both components of pre-diabetes. And at the same time, a secondary issue is consideration of hemoglobin A1C, but I would like you all to consider only blood glucose, and that too after 75 grams. Now, pre-diabetes is prevalent in Indian population, and though considered to be trivial by many people, this is taken from an article from my colleague, Dr. Ranil Javardhane from Sri Lanka, compiled data from 1.7 million adults, including number of Indian studies, and shown that increasing prevalence of diabetes and pre-diabetes in Indian population from 1972, and data are up to 2019. So it is well known that diabetes is increasing in India, but what is not known or not projected is that pre-diabetes is increasing in both urban and rural population. Now, if you see here, very interestingly, this particular part, if you can see, the rural population is actually outpacing urban population as far as pre-diabetes is concerned. This is particularly dangerous because some of these people do not have adequate knowledge regarding diet, exercise, and do not have adequate medical assistance to tackle pre-diabetes and its conversion to diabetes. And we have some idea that a risk of cardiovascular disease is elevated in impaired glucose tolerance, and this is an old study, 2002 study, which shows that risk of cardiovascular disease is twice in patients with impaired glucose tolerance. And recently, there has been another study which shows clearly that myocardial infarction is highly prevalent in impaired glucose tolerance versus those people with normal glucose tolerance. Having said that, let's go to the Indian population. What is the pace of pre-diabetes and its conversion to diabetes in Indian population versus the Western population? And this following slide will give you a good idea how fast it progresses. Now, on the left side is the graph. This particular graph is for Indian population, and this particular graph is for Western population. This has been compiled by Dr. Naveed Sattar and written in Lancet. What is important to note is that progression to diabetes is 12 to 18% in Indian population and fairly early too. So look at this graph from normal glycemia to impaired glucose tolerance to diabetes versus Western population where progression to diabetes is 5 to 11%, virtually half of that of Indian population. So it progresses faster in Indian population and earlier. But what is more interesting is that if we suppose apply the same diet and lifestyle practices in both populations, Indian population as well as Western population, we'll find less results in Indian population. So its reduction to normal glucose tolerance is 30% with lifestyle intervention versus almost more than 50% in the Western population. So it's a more resistant to lifestyle intervention. So this will give you a good idea how where we stand as far as pre-diabetes is concerned and how fast it progresses, and it has a lot of difficulty in regression. Now here I will show you some new data and data from our group. So again, I'll again reiterate that many people think, including doctors, that pre-diabetes is a trivial entity, and they sometimes give no advice to the patient and trivialize it and say that you are not diabetic. In this particular study, we looked at leukocyte telomere length. Now, leukocyte telomere length is telomere at the end of the chromosome. And this is very important because its length actually denotes longevity, how much you will live. The shorter the length, the shorter is the life. So, if there is a favorable telomere length, there is a healthy phenotype and healthier aging, and unfavorable telomere length, there is accelerated. According to our previous data belief, we think that Indian population has accelerated aging. That is shown by the previous slide where we were shown that pre-diabetes occurs a decade earlier in Indian population and progresses faster. So that's an aging phenomenon. But let's look at further our data. In 797 pre-diabetic women, obese and non-obese, and leukocyte telomere length was quantified by quantitative polymerase chain reaction, and subjects were separated into quartiles of LTL. Now, the dark bars are actually have the shortest leukocyte telomere length. So this first quartile, then there is a longer LTL, and then longer and longer. So 4 quartiles here. And these quartiles are for each skin fold thickness, which denotes the subcutaneous adipose tissue. Biceps, triceps, subscapular, suprailiac, central, peripheral, and total skin fold. So you can see that black bar, actually the quartile 1, which is shortest telomere length, is present in those with thickest adipose tissue, thickest skin fold. And this is more apparent in the central and total. If we sum it up, all these skin fold, then this is total, and central is summing up of subscapular and suprailiac. The thickest central adipose tissue is present in shortest quartile of telomere, which means that the subcutaneous tissue, if it accumulates centrally in the truncal area, in the chest and over the abdomen, is bad as far as LTL is concerned. And peripheral, though it is still showing trend, but it's not so bad. And once we looked at the partial correlation, the side central skin folds, the total skin folds, body mass index, and body fat have important correlation with LTL. And multivariate linear regression analysis identified central skin fold, total skin fold, body mass index, and body fat as independent predictors of leukocyte telomere length. So summary of the study, which has been published just now today, is that Indian women with pre-diabetes, obesity, and truncal obesity have shortened LTL, leukocyte telomere length, indicating accelerated aging. So right at this point, it is important to decrease fat in the body, decrease weight, and that will lead to increase in the subcutaneous adipose tissue, which will halt this accelerated aging. This is the meaning of this particular study. We are working more on this. Now, prevention of pre-diabetes to diabetes, the issue has been addressed long back, and this is the first study, Diabetes Prevention Program. This paper was published in 2002. It had 3 arms: lifestyle, metformin, and placebo. Over a period of 4 years, in those patients with pre-diabetes, the lifestyle fared the best. It decreased conversion from pre-diabetes to diabetes to 58% of the individual versus metformin 31%. So it was a clear winner over metformin. Now let's go further and see that these people were out of the trial after 4 years, and they were followed up to 15 years. And this was the trial which is called as DPP-OS trial, 15 years after initiation of DPP study, published in Lancet in 2015. And you can see the difference between the lifestyle and metformin as far as prevention from pre-diabetes to diabetes is still maintained, although it is narrowing down. Look at this, narrowing down. And this is my editorial in the Lancet, Prevention of Diabetes, more answers, more questions. So this study answered something, but we have more questions, and the questions are how best to prevent diabetes from occurring from a position of pre-diabetes. As far as Indian studies are concerned, this is the seminal paper by Ramachandran in 2006. same three arms of the study: lifestyle, metformin, and lifestyle with metformin. Interestingly, in this particular study, lifestyle with metformin fared as well as metformin. But there was no difference between the two, although the dose of metformin used in this particular study was lower than that used in DPP. But nonetheless, we know that lifestyle is working in Indian population, and perhaps because of fast conversion of pre-diabetes to diabetes and more malignant nature of pre-diabetes, metformin is needed earlier in this. What about the prevention of coronary artery disease or decrease in the coronary artery disease in those people who are on these three arms? This was assessed in 2029 participants from original DPP-4 study. Coronary artery calcium was measured. And interestingly, it was seen that coronary artery calcium severity and presence was significantly lower among men with metformin versus placebo. But no metformin effect was seen in women. So metformin is doing something more, especially as far as coronary artery disease is concerned, and particularly. Now, non-obese individuals are likely to be low insulin secretors, and they may progress faster to pre-diabetes and diabetes. If you can see here, the BMI categories are given down. This is men and women and different ethnicities. The development of diabetes is considered and plotted against the BMI. You see, even at a low BMI, Indians develop that. This particular, both in men and women versus Japanese, Maltese, European, and Chinese. So our population develops diabetes at a lower BMI, and we also know that those people who are lean, the lean people here, their beta cells are lesser, even in those who have no diabetes versus obese people where beta cells are more. So beta cell numbers may be less in these people who are non-obese, and they may have low insulin secretor effect, and hence the side insulin resistance, insulin secretion becomes an important point in the development of pre-diabetes and then subsequent conversion. I come to liver. Now, liver has been talked about a lot during these days, and what I want to emphasize is that not only the increase in the liver fat predicts diabetes, but once it develops, non-alcoholic fatty liver disease develops, progresses, impedes the regression of those individuals who are pre-diabetes. And as you can see here, this is our study. These two photographs show the normal liver with the liver span of 11 centimeters and grade 3 fatty liver, non-alcoholic fatty liver with the liver span of 6.8 centimeters. And we published that anybody who has a liver span more than 15.6 is much more likely to develop that. So that's as far as prediction of diabetes is concerned from liver span. But what I want to show you is this particular study, which was done by Stefan and published in 2015. They took two groups of patients: high-risk phenotype, who had insulin resistance and non-alcoholic fatty liver disease, and low-risk phenotype, that's all the other. After 9 months of the lifestyle intervention, the one which had the high-risk phenotype lost fat lesser amount than the low-risk phenotype, and also the reduction in postprandial glucose was much less, and reversion to normal glucose regulation was half that of a low-risk phenotype. So there is resistance to going back to normal glucose regulation from the pre-diabetes and insulin resistance whenever insulin resistance is present and whenever non-alcoholic fatty. So that impedes conversion to. There are a number of other phenotypes. Pathophysiology-based subphenotyping in individuals at elevated risk for type 2 diabetes, and some have low risk, some have high risk, and these three particularly needs to be considered. Here, there is a beta cell failure. This phenotype, high risk, insulin resistant, fatty liver, we have just talked about. And there is another high risk phenotype where intra-abdominal fat is more, and there is a renal sinus fat is also present. They have lower insulin sensitivity and also low insulin secretion. Their conversion to pre-diabetes and then diabetes is very high. So this conversion is very high, and also there is a relationship to mortality in this. One more point needs to be considered as far as Indian population is concerned, and that is gestational diabetes. And I'm going to show you this particular slide. Incidence of diabetes after gestational diabetes. And there, many people actually go down to pre-diabetes and then develop diabetes, and this is most often occurring in the first 5 years, after which it becomes less. So, the cumulative incidence of type 2 diabetes after gestational diabetes is highest in first 5 years. But it is very high as far as Indian population is concerned, as shown by this particular study, where 267 women were taken at median of 20 months after delivery. Dysglycemia was found in 7.7%, diabetes in 10%, and 47.2%. So just presence of gestational diabetes itself means one has to be very careful. These people will develop diabetes soon, or they will have the pre-diabetes and then conversion. Now, the last point, and again I will show you some of the data generated by our group, low vitamin D. Now, we had shown earlier, several years back, that vitamin D insufficiency is associated with abdominal obesity. And in this particular study, we showed that total abdominal fat, subcutaneous fat, and intra-abdominal fat all were associated, but it is the subcutaneous fat. Again, I want to recall my slide where truncal obesity was associated with the low leukocyte telomere residence. Similarly here, vitamin D deficiency is associated with subcutaneous. Also, non-alcoholic fatty liver disease was associated with low vitamin D level in another study. So there was enough, by the time there were enough studies, it showed that low vitamin D is doing something to glucose regulation. And I would like you to just concentrate on this particular study. It's a busy slide, but I'll make it simple for you. These are quantiles of vitamin D. This is the lowest vitamin. And here are data on metabolic syndrome, abdominal obesity, and anemia. And if you see, highest metabolic syndrome, abdominal obesity, and hyperglycemia is present with in those people who have the lowest quantile of vitamin. So this is some of the earlier studies. And then subsequently, there were a number of studies in different scenarios in patients with pre-diabetes, in patients who have normal, so-called healthy people, and patients who have metabolic syndrome. So these are some of the studies which are represented in this particular slide and showed that blood glucose or insulin resistance or metabolic syndrome had association with low vitamin. So these were association studies. These were not intervention studies. These were not randomized controlled trials. And we also showed in 2018 in women that the higher is the fasting blood glucose in patients with pre-diabetes, impaired fasting glucose, the lower is the vitamin. So there is some association between low 25 hydroxy vitamin D with high fasting blood glucose. This is published in BMJ. Then came the randomized controlled trials, and this slide summarizes the randomized controlled trials in countries other than India. Unfortunately, the same thing that we were seeing in association studies no longer seen. And very few trials actually showed that if we give vitamin D, then it benefits. And the largest trial is this one, where 28,000 units of vitamin D per week was given for 30 weeks, and there was no. And there are some studies with association, most of them. The RCT meta-analysis was done in 2017 and concluded that there was a modest reduction in hemoglobin A1C as compared to placebo, but no effect on fasting. Because very interestingly, in these studies, achieving the repletion of vitamin D deficiency. So once deficiency was taken in those people, the vitamin D supplementation was doing something. There was a greater mean reduction of hemoglobin A1C and fasting blood glucose. Versus if we take all studies together where deficiency is there in some people and no deficiency there. And similar, this is the meta-analysis. And similar results were found in another meta-analysis where though there was less hemoglobin A1C in those who received vitamin D, there was no effect on fasting blood glucose. Further decrease in hemoglobin A1C and fasting blood glucose was seen in patients with vitamin D deficiency and BMI less than 30. So we can categorize patients or people into two, those with vitamin D deficiency and those without vitamin D deficiency. Possibly supplementation of vitamin D will do something good in those people who have vitamin D deficiency. These are randomized controlled trials in India, and surprisingly, RCTs in India showed positive association. Most of the studies, and this is our study, and which I'm going to describe. This is the largest randomized controlled trial in South Asia of 60,000 units of vitamin D per week for 8 weeks, and then maintenance and duration of 18 months. And this was published in Scientific Report. So 121 women with random allocation
This
to
session
vitamin
is
D
very
placebo
interesting,
for
but
58
it is
weeks.
9 minutes
And you can
overtime.
see
9 minutes overtime, and it is a recorded session. I think we stop here. They are wonderful take-home messages. I should thank Dr. Sunil Gupta once again and his academic team for all the lovely sessions which were organized throughout the day. And in this session particularly, we all should agree that from a diabetic clinic, we have to go in the society and in the community, which we have been learning since morning. Because as we just heard, that the pre-diabetic incidence is very much increasing in rural population. And they will not come to the clinic until we intervene. And we learned something wonderful like telomere length. We also learned about the skin fold thickness, all reversal things. And it was a wonderful session. Thank you once again.
Thank you so much, sir and ma'am. Thank you so much, Anup Misra, sir. I invite Dr. Sunil Gupta, sir, and Dr. Vijay Neglu, sir, to kindly felicitate the chairpersons, Dr. Anita Basavaraj, ma'am, and Dr. Bala Subramaniam, sir. With this, now we move on to the next session, which is from the USA Space Station International Symposia. For this session, I would like to invite the chairpersons, Dr. Vijay Neglu, sir, from Mumbai, and Dr. Amit Saraf, sir, from Thane. For this session, we have Dr. Paresh Dandona, sir, from the USA, joining us over Zoom.
Welcome to this session on hypogonadism by Dr. Paresh Dandona. He is a distinguished professor of medicine, schools of biomedicine, science at the University of Buffalo, the founder of Diabetes Center, Western New York, and Paresh Dandona is recognized as one of the world's leading experts in treatment of endocrine disorder And without wasting much time, I hand over the mic to Dr. Paresh Nandona to give his talk on hypogonadism.
Hello. Can you start projecting my slides, please? Okay. So what I'm going to be talking about today is a new syndrome that we described way back in 2004. And it's not frequent in the life of a clinical investigator to discover a new syndrome, but here it is. And from that syndrome and the various findings we've had over the years, we've been able to show that actually testosterone is not only a sex hormone, it's actually a very important metabolic hormone. So I shall present you the data in relation to that. So next slide. So these are the data that we published in 2004 in Journal of Clinical Endocrinology and Metabolism, showing that in type 2 diabetics, and there was a lower level of total and free testosterone. And the frequency of low testosterone and low free testosterone was of the order of about 33%, so 1 in 3. So 34 out of our 120 patients that we presented in that study had low testosterone. At that time, of course, this was heresy because nobody really recognized that diabetes could be a cause of low testosterone. You also see that in this study, there was an inverse relationship between BMI and body weight and free testosterone. There was no relationship with HbA1c. There was no relationship with duration of diabetes, but there was a relationship with BMI. So this led us to hypothesize that even obesity may be a cause of hypogonadism. Next slide. And before we go there, need to show you some other data in relation to type 1 and type 2 diabetes. And you can see that in type 1 diabetes, the levels of free testosterone are normal on the left in yellow, and in type 2 diabetes, they're significantly lower, even in younger populations. And then, of course, we did this large study in diabetic and non-diabetic obese men, and clearly you can see that there is a lower level in the obese, whether they're diabetic or non-diabetic. But if they are diabetic, the frequency of low testosterone is slightly higher. Now, this led us to hypothesize that even in children, because after all, my patients are largely middle-aged patients, coming to the obesity and the diabetes clinics, we hypothesized that even in the younger population of diabetics, there could be a difference. So what we looked at was testosterone concentrations in lean and obese young people between the ages of 14 and 20. And you can see that the distinct lowering of testosterone concentrations, and this population also had a prevalence of around 30% in terms of hypogonadism, as reflected in the low testosterone concentration. Next slide. And then an amusing slide here showing you the famous statue of David, Michelangelo's David, standing in Uffizi Gallery in Florence. And any of you been to Florence, I'm sure you visit the Uffizi Gallery because it's one of the greatest art galleries in the world. And you can see this perfect form, male form of David on the left. And then David made a mistake of coming to the United States for a few years, and see what happened to him. He developed abdominal obesity, and it's not just abdominal obesity. You can see, go back to the previous slide, please. Go back to the previous slide. You can see not only the abdominal obesity, you can see the loss of musculature. You can see the deltoids are gone, the pectorals are gone, and then you can also see shrunken genitalia. Now, this cartoon appeared on the internet a year before we published our data. So clearly, the cartoonist or the artist was very observant and actually seen that with obesity, there's a shrinkage of genitalia, consistent with what I've shown you earlier. Next slide. And here is the issue of estradiol concentrations. Because when we observed that during a meeting in the Middle East, I was in Kuwait presenting these data, and after my talk, somebody stood up and said, hey, that could well be due to increased estradiol concentrations, because with increased adiposity, the adipose tissue could be converting more testosterone into estradiol, which would then shut off the axis. Well, when we did the data, as you can see, go back to the last slide, don't jump till I tell you to move. So you can see that the free estradiol concentration in the hypogonadal population was significantly lower. Next slide. Now, what could be the cause then? It was not as increased estradiol, and this came out from a very nice experimental paper from Ron Kahn's lab in Joslin Clinic in 2001. And in that paper, what they had shown was that in mice that were that had their neuronal insulin receptor knocked out through the genetic mechanisms, the outcome was hypogonadotropic hypogonadism. So this till now remains the major cause that we believe leads to hypogonadotropic hypogonadism, insulin resistance in the brain. And keep that in mind. Now, talking of insulin resistance, the next issue then was, since insulin resistance is something that we had shown previously to be related to inflammation, please go back. Don't rush. Please go back to the last slide. Yeah. Until I ask you, don't change, please. So, what we demonstrated here was that in these patients with the obesity and the hypogonadism, CRP levels were high, and along with it, TNF alpha and interleukin beta were also higher. And these two cytokines have been shown to suppress hypothalamic GnRH and therefore LH secretion. And this could be the link between obesity and the hypogonadal state. Next slide. And then comes the actual study on the adipose tissue itself. So we got hold of a whole lot of hypogonadal obese patients, and we did their fat biopsy. And what we demonstrated there was that there was a diminished expression of insulin receptor substrate 1, AKT2, and GLUT4. 4 sites which are responsible for glucose uptake by a particular cell. So there was a 4-pronged attack on insulin sensitivity, or insulin action and insulin sensitivity, therefore, in these obese patients. So keep this in mind, key. Next, we also looked at another mechanism. Go back, please, and don't change unless I ask you to. I'm sorry to shout. So here you have AMP kinase, which is another mechanism through which glucose is taken up by any cell. And here you can see that the AMP kinase expression in both the adipose tissue and in the skeletal muscle is lower. And there's also a lowering of the phosphorylated form of AMP kinase, which is the active form. Next slide. Next slide. Now, having shown you those data, the next step was to treat these patients with testosterone to see what kind of changes we would see in the adipose tissue and in the muscle. So let's go ahead, and here you can see the curves in the placebo arm, where the testosterone remains low and does not change, and then in the testosterone arm, where it increases significantly and stays high through the study that lasts 6 months, 24 weeks to be precise. And during this time, interestingly, there was a weight loss in the treated group by 3.5 kilos. A1C came down very slightly, but not significantly. And there was an increase in lean body mass by 3.4 kilos, and total fat mass went down by over 3 kilos. Visceral fat went down, and hepatic fat went down. Next slide. And with it, when we did the clamp studies to look at the insulin sensitivity, clearly you can see that the glucose infusion rate was significantly diminished in the hypogonadal population. So next slide. And then, as we gave the testosterone for 24 weeks and did the clamp study again, you can see the testosterone group had an increase in insulin sensitivity. So this was the first clamp study in this group to show that testosterone increases insulin sensitivity. And I've already shown you the mechanisms that go wrong, and I'll show you some more data on that aspect. Now, as testosterone was given over this period of time, please go back. Please go back. What's the hurry? I've told you don't change till I ask you to change. So plasma free fatty acid concentrations go down. Plasma leptin concentrations go down because the adiposity has gone down. Next slide. And here you can see all those 4 elements that I showed you earlier, which were related to insulin resistance, were reversed. So insulin receptor expression increased, IRS increased, AKT2 increased, and GLUT4 increased. So clearly, testosterone has very profound metabolic effects, starting with insulin sensitivity. Next slide. Yeah. And here you can see, and go back, please. Go back. And you can see an increase in AMP kinase expression and AMP kinase phosphorylation following testosterone. So clearly, a profound diffuse effect that would have an action on glucose uptake and insulin sensitivity. Next slide. And here you have now actual data on change in inflammation. So you've got IKK beta, which is a pro-inflammatory protein, P10, a pro-inflammatory protein mediator, and SOX3 not only is pro-inflammatory, it interferes with insulin action. That has been shown, and clearly suppression with testosterone. CRP falls on the right, TNF-alpha falls, the profound anti-inflammatory effect of testosterone. Next slide. Next slide. And here you can see another very interesting aspect. So, in the hypogonadal state, in the adipose tissue, there's a significant diminution of androgen receptor, estrogen receptor, and also of the enzyme aromatase, which converts testosterone into estradiol. So you can see why estradiol concentrations followed the testosterone concentrations in terms of being low in the hypogonadal state. And here you can see the change in all of those three with testosterone administration over a period of 24 weeks, androgen receptor increases, estrogen receptor increases, aromatase increases. And then you can see the diminished androgen receptor reversal, as I mentioned, and in terms of protein expression. Next slide. Next slide. And here, let's look at the muscle. And androgen receptors in the muscle also diminished in terms of mRNA expression, in terms of protein expression in the panel on the left, and then with testosterone administration, the reversal. And then mediators of muscle growth. The fibroblast growth factor 2, which mediates in the muscle growth, increases with testosterone. IGF-1 increases with testosterone. Next slide. Then FGF2 expression again increases with testosterone. It was diminished to begin with. And myostatin, which is an inhibitor of muscle growth, is suppressed by testosterone. You can see that. So clearly, a comprehensive effect on muscle growth as well, beyond just the sexual function. Next slide. And then another aspect. We know that testosterone is given to chronic renal failure patients with anemia, and testosterone makes the anemia reverse and hemoglobin concentrations increase. So we looked into that mechanism, and you can see there's an increase in erythropoietin, there's a decrease in plasma hepcidin, which inhibits the action of testosterone at the cellular level to increase the bioavailability of iron. Next slide. So I'm showing you a whole series of metabolic actions now. Now let's look into a very interesting study we published 2 years ago now, which was the longest study carried out with testosterone administration over a period of 11 years in hypogonadal diabetic patients. And you can see here the control arm where there was no increase in testosterone, and the treatment arm where there was an increase in testosterone concentrations. Next slide. And you can see with it body weight change over that period of time. Remarkable reduction in adiposity and with overall body weight over this period of time. Then you have OMA-IR, the index of insulin resistance, steadily increasing in the arm that was not treated and steadily decreasing in the arm that was treated, consistent with the data that I showed you with our previous study. Next slide. And then here you have normal. What is very interesting, and this is striking, and I want you to concentrate on this one. So in 91% of those patients treated over this long period of time, A1C came to be less than 7%, 83% had A1C less than 6.5%. And then let's look at the bar on the left, where the A1C was less than 6.5% without any anti-diabetic treatment. So clearly, not only was there a reversal of insulin resistance, improvement in diabetic control, but in 1/3 of the population, diabetes remitted in this group over a period of 11 years. Next slide. And then with it, there was survival curve, and mortality remained high in the hypogonadal group, whereas mortality diminished significantly in the testosterone-treated group. And this table shows you the various causes also. Myocardial infarction came down, strokes came down, myocardial infarction and stroke combination came down, retinopathy was less, nephropathy was less, polyneuropathy was less. And fractures were also less because we know that testosterone supports the bone. Next slide. Now, a study published last year shows the correlation tightly with body weight. So this was from the Teen Lab study, with the only adolescent obese population studied in the United States where they had bariatric surgery. And the age range again was 14 to 20. And you can see the weight fell steadily, and the weight loss was steady after 2 years. Testosterone concentrations increased. Go back. Please go back. You can see that the testosterone concentrations from being subnormal went bang into the middle of the normal range and stayed high. But further analysis is also interesting. Next slide. And sex hormone binding globulin, which tends to be low in insulin resistant states, also increased. Next slide. And here, free testosterone also increased. Next slide. And there was a correlation between weight loss and increase in testosterone. Next slide. Now, this is very interesting. So just pay a little attention to this. So what you have is, in blue, those who increase their testosterone following weight loss, and the weight loss is shown in the yellow and orange, and you can see that. But you can also see that in a subpopulation, weight increased again after bariatric surgery, and this is a known phenomenon. And you can see in that group, there was a sharp fall in testosterone after month 36 because of the weight gain. So this is the best evidence that you have that if weight is high, testosterone is low. You lose weight, testosterone increases. If you regain weight, testosterone decreases again. So there's a very tight relationship with body weight. Next slide. And this is the last study I'm going to be talking about. And this is a study from Dr. Wittert in Adelaide in Australia. They did a multi-center study to look into testosterone therapy and lifestyle into reversal of diabetes and pre-diabetes. Very nicely planned study. But what they did in this study was to start treating patients with testosterone around the concentration of 14 nanomoles per liter, which actually is technically within the normal range. But they had large database where they found there tended to be a relationship of increase in blood glucose with testosterone concentrations less than 14. So they did this prospective trial. Next slide. And you can see the over a period of 2 years in the testosterone plus lifestyle program, there was only a prevalence of 12.4% of diabetes, whereas in the placebo arm it was 21%. So very significant difference. Next slide. And fasting blood glucose fall in the testosterone group also significantly greater. Next slide. You can see here pre-diabetes difference also between testosterone arm and the placebo arm. Next slide. And here you can see pre-diabetes again being affected much more in the testosterone arm than in the placebo arm. So this brings me to the end of my slide. And I want to conclude, as I started with, that testosterone is not only a sex hormone, it is much more than that. It is a very fundamental metabolic hormone affecting insulin action and insulin resistance, therefore carbohydrate metabolism. I also showed you data on what it does in muscle, also showed you the mechanisms involved in hematocrit increase, also showed you data as to how it modulates androgen receptors, estrogen receptors, and aromatase. So clearly, testosterone has far greater effects which affect the lives of males. And of course, now I measure testosterone in every new type 2 diabetic that comes to me and every new obese patient that comes to me. And if they need testosterone, they get treated with it and they benefit from it. So with that, I will close my talk and you're free to ask me any questions. Thank you very much.
Thank you, sir. Thank you for a wonderful presentation on hypogonadism. Can I ask a question to you? You said that in patients who are obese.
Can you speak a little more loudly? Your sound is not coming through.
Okay. Can you hear now? Yeah. You said about the patients who are obese had high amount of aromatase in the fat and therefore the levels of testosterone are low. You also showed a data of thin people, thin diabetics who also had low levels of testosterone. Can you explain what is the possible mechanism?
Even in thin type 2 diabetics, you'll have a low possibility of
what's the possible
1 in 3 having low testosterone.
Yeah, what could be the possible mechanism in these patients who are not obese but have low levels of testosterone?
But you see, with type 2 diabetes, insulin resistance is almost intrinsic. And therefore, insulin resistance then expands into the brain as well. And then, therefore, it affects the brain mechanisms. And I showed you that GnRH secretion is affected, and the effect of GnRH on LHRH, on LH and FSH are also affected. And there is another new protein now called kisspeptin, which is hypothalamic protein, which is also involved in this process, but I just didn't want to make it too complicated for you guys. But basically, just think that insulin resistance leads to less GnRH and less effect of GnRH on LH and FSH.
You showed about the prevention of diabetes because of using testosterone. Did you see any cardiovascular complications by using testosterone in these patients?
Good question. Very good question. So let me answer you, because this was an issue that was raised earlier on when we published our work and when we published our reversal of diabetes in, with the long-term treatment. There is a paper from Kansas City. It is actually a set of Indians working at the VA, Veteran Administration Hospital there, who did the national database on Veterans Administration Hospital and looked at patients who were hypogonadal versus those who were hypogonadal and were treated, and versus those who were hypogonadal were inadequately treated. And guess what happened? As far as cardiovascular complications are concerned, and this was published in the European Heart Journal about 5 years ago, showing that administration of testosterone reduced the chances of a myocardial infarction. So that's the largest study that's been done till now. And there's been a recent study again, a smaller study, confirming that point. So there is no issue of increasing cardiovascular complications with testosterone administration.
Thank you very much, Dr. Paresh Dandona. And as always, it was one of the very elaborative description of the topic. And people here in this meeting were eagerly waiting to have this deliberation. I'm extremely sorry for some of the communication between the changing of slides when you ordered for it. and there's some communication gap, possibly the time lag or something with few seconds. We apologize for this disturbances which has happened. But Hello Diabetes Academia team of organizing committee, which includes Dr. Vijay Neglur as well as Dr. Amit Saraf, who are chairing the session. We are really thankful to you for joining with us on this particular evening. And yeah, you have a question here? Yeah, please go.
The free testosterone which was measured, sir, in patients of diabetics. So
You have to be a little louder.
Yeah. Free testosterone which was measured, in India we don't have equilibrium dialysis method. We are just relying on the immunoassay based method. The patients who are having testo on lower side of normal, so how much we rely with these reports of immunoassay to put them on testosterone? Because majority of the labs in India are measuring with this immuno-based method.
Okay, so let me sort of mention something that is hard and something that is softer in terms of evidence. So, as far as low normal concentrations are concerned, I showed you the study from Witter et al., the very important first of its kind, where patients with low normal testosterone were treated. They were not clearly, I mean, by standard definition, they were not clearly hypogonadal. And you could see that there was a tremendous effect on carbohydrate metabolism and the reversal of diabetes and prediabetes. So that's hard evidence. But let me tell you a softer story now. That since these patients have low normal concentrations of testosterone, not clearly hypogonadal, and of course in the United States, insurance companies will not cover trial of treatment with testosterone in these patients. What I have been doing is to give them clomiphene. Clomiphene, as you know, is the standard drug to induce ovulation in women. But the way it induces ovulation in women is by stimulating the hypothalamo-hypophyseal axis. Again, GnRH is stimulation, LH and FSH gets secreted, LH and FSH then go down and cause ovulation in women. And in men, I found now that they stimulate the Leydig cells to produce LH, and there is evidence that they also increase spermatogenesis. So younger patients with obesity and hypogonadism, now I'm starting to treat routinely with clomiphene because this preserves their spermatogenesis, doesn't close the axis, while at the same time increasing their testosterone concentration.
Thank you, sir.
Thank you very much, Dr. Paresh Dandona. Thank you very much for being with us with Hello Diabetes Academia team. And we'll again come back to you. Maybe in next year, we will have a personal meeting, physical meeting, and we'd love to welcome you to India once again next year. Thank you very much.
Thank
sir.
you. Thank you very much.
Over to Master of Ceremony.
Thank you so much, respected Paresh Dandona, sir. Thank you so much, chairpersons. Now for the next session, we have Dr. Sundar Murlia, sir, from the USA. For this session, I would like to invite the chairpersons of the evening, Dr. Rajesh Rajput, sir, from Rohtak, Dr. Manoj Chawla, sir, from Mumbai, and Dr. Nirmal Jaiswal, sir, from Nagpur.
Good evening, everyone. Great pleasure to welcome Dr. Sundar Mudaliar. Dr. Mudaliar joined us here.
Yeah.
Okay. So great. So we will have Dr. Sundar Mudaliar. Good evening. Good morning. Dr. Mudaliar, hi, Manoj here.
Hi, Manoj. How are you?
Good, sir. So Dr. Mudaliar is going to be speaking to us about
ketones from fuel source to signaling molecules to therapeutic agents. And we have Mudaliar's CV up there. Of course, Dr. Mudaliar has great amount of work in the ketone fuel hypothesis and he's a clinical professor of medicine at University of California at San Diego. He's been the site principal investigator in the NIH GREAT study and the NIH also DCCT and the EDIC studies. He's currently a clinical professor at medicine of University of California, investigator, as I said, in multiple important studies that we refer to, and he's published more than 200 original articles in peer-reviewed journals. We welcome you, Dr. Mudaliar, and request you to start your conversation with us.
Namaste to everybody, and I know we are running late, so I will try and wrap up my presentation in time. So first of all, my conflict of interest disclosure, which doesn't affect my presentation, and these are my objectives. I will discuss the evolving role of ketone bodies. Historically, actually, in the 1800s, late 1800s, they were thought to be a byproduct of incomplete fat oxidation. Then the classical view came around that no, it's actually an alternative fuel substrate to glucose and fat when we fast. But in the last few decades, there's an emerging concept that ketones are not merely a fuel substrate. They actually signal through receptors, and they've got multiple effects on tissue inflammation, oxidative stress, mitochondrial function, and a whole host of functions. And very recently, there has been great interest in using ketones as a potential therapeutic target. As you know, if you do a low-carb diet, you fast, intermittent fasting, anything, you get endogenous ketosis. We know that. But you can also give ketones orally or intravenously, and you can get exogenous ketones. So let me start with this quote, which has been attributed to Socrates, and he said, "Bad men live that they may eat and drink, whereas good men eat and drink that they may live." So if we look at an average person, 70-kilogram person, 1,800 calories, about 50% comes from carbs over there. Give or take, I know in India, the carbohydrate content is much higher. Approximately 30% comes from fat. Those are the calories, because each gram of fat is 9 kilocalories. And of course, the rest is protein. There's some variation of this, but bottom line is our body needs glucose, especially the brain and certain tissues like the red cells, the white cells. So we need at least glucose and fat and protein, of course, to build muscles and hormones. What happens when we don't eat? Where are the calories going to come from? Because the brain needs glucose, we need to keep our body temperature. So this is from a very nice article published more than 50 years ago by George Cain, who really did all the pioneering work. Where is the fuel stored in the human body? Well, let's look at it. If you look at it, the majority of our fuel in a 70 kg man who has about 15 kilos of adipose tissue, as Dr. Dondona talked about, we have about 150,000 calories sitting there. What about protein in the muscle? Well, it's about 6 kilograms and around 24,000 calories. Way down. What about the glucose? Well, we don't have much glucose. In the muscle, it's about 100, 200 grams. In the liver, maybe 100, 200. You don't get much calories from it. About 1,000. That will be gone in less than a day. What about the blood glucose and what's circulating? That's a tissue store. Well, look at the glucose. You have only 20 milligrams. And it's only 80 calories. This is if your blood glucose is 100 milligrams per deciliter. If you do the math, 5.5 liters of fluid over there. Free fatty acids, even less, 0.0003 of a kilo. You don't have calories. All the calories are sitting in the fat and maybe muscle over there. So let's look at what happens when we fast for about 24 hours. Well, the fuel is coming from muscle. Muscle is breaking down. This is happening whether you like it or not over there. So about 75 grams, and the amino acid, as we know, goes towards gluconeogenesis, and along with the glycogenolysis from the liver, we get about 180 grams, and that's what is needed by nervous tissues, about 120, 140 grams, and red cell, white cell. Remember, the red cell cannot do anything except glucose. It cannot do fat because there's no nucleus of mitochondria. About 40 grams over there. Adipose tissue is breaking down about 160 grams, and that, of course, goes towards free fatty acids, which powers all the heart, the lung, the muscle. And about 40 grams will make ketone 60 grams, and that also goes over there. What happens if a person fasts for 4 to 6 hours? And these studies were done by George Cahill in the 70s over there. And what he says is, after 5 to 6 weeks, you are burning about 20 grams of fat. That's down from 75, because if you burn your fat, you're gone in about 2 weeks. You don't have any energy left, any muscle stores left. That, of course, goes for gluconeogenesis. But look what happens. Now, that is only giving you 80 grams. That's down from 180. And of that, the rest is made up by ketone. So going, the 180 nervous tissue now has reduced from 144 to 44. This cannot change because these guys need all the glucose they need. So that is going on over there. For adipose tissue, the same amount is breaking down, about 150 grams. Of course, it goes to the muscle. And of course, the rest is ketone bodies, which is, as I showed, is going mainly to the nervous system initially. Some of it is excreted in the urine. So the bottom line is, during prolonged fasting, in order to spare muscle being broken up to make glucose, ketones step up to the plate. As we know, there are 3 ketone bodies. The main ketone body is acetoacetate. It can be converted, interchanged to beta-hydroxybutyrate outside the liver. They're made in the liver, but they're used outside because the liver cannot use them. And of course, it can be decarboxylated to acetone, which is usually expired out in the air. After an overnight fast, circulating ketone levels are about 0.1 to 0.5. And acetoacetic acid and beta-hydroxybutyrate, it's about 70% of BHOB and 30% there. They go to all the tissue. So let's look at the key role of fat and liver in ketone physiology. So during prolonged fasting, what happens? Fat tissue. Now you're going 5 weeks, 6 weeks. There's more lipolysis taking place over there. And where do those free fatty acids go? Well, they go to the liver and they get inside the mitochondria. They undergo beta oxidation over there, and then they get converted to beta hydroxybutyrate. And the key enzyme there is HMG-CoA synthase intermitochondrial. Let me remind you, this HMG-CoA synthase is sitting in the cytoplasm, and that's the one we block for with our statins to reduce cholesterol. It goes into the blood, beta-hydroxybutyrate, goes to the brain, the heart, the kidneys, the muscle, and when it goes in there, it's interconnected, changeable to acetoacetate, and the key enzyme is SCOT, and of course it converts it to acetyl-CoA, and we get ATP. ATP is the currency of the body, no matter whether you get it from carbohydrate, protein, fat, or you get it from ketone, whether you want to grow your hair, you want to grow your nails, you want to walk, talk, your heart to beat, we need ATP. That's a universal currency in the body. And interestingly, our human species could not have evolved without ketone. And guess what? We come into this world in a ketotic state. Let me show you that. This is again from George Cahill in the early 2000s. He wrote it. On this axis is time. On this axis is beta-hydroxybutyrate. Remember, acetoacetate is also there. So let's look at the newborn infant. Infant comes in with ketone levels of about 0.5 millimolar at time 0. And if the infant fasts for about 2 hours, it goes to 2 millimolar. Why? Because when the fetus is sitting in the mother's womb, it's fully dependent on glucose. It's not breathing anything, or very little oxygen in the system. It is just burning the mother's glucose. Once it comes out, it has to fend for itself. That's why infants in the first week lose weight, because they're burning all that fat to make ketones. And that's why they need to feed every 2 hours. They don't have glucose. Their brains are dependent on this. The mother's milk needs to give them that glucose over there. Infants take about 4 hours to get to that level. And human adults, to get to 2 millimolar, we need to fast for 24 hours. But nature sends us into this world for a reason. And Cahill had wrote this in another very nice article which he said that, the principal ketone body, enables us to survive 2 to 3 months, because if we were dependent on protein, fat, other things, and glucose coming there, we would be gone in a few months. And that's why we evolved with such a big brain, which needs glucose. And he showed that beta-hydroxybutyrate, the ketone, is not a fuel, but it's a super fuel. So let me remind you, the brain can use free fatty acids. And why should it make ketones to use? Because ketones is a far better fuel, and it does not cause oxidative stress in the brain. Based on this, after the EMPEREX study, we wrote this article from our group, and we said, maybe all these cardiorenal outcomes, which are kind of like unbelievable, are due to a shift in fuel energetics. Don't ask me how I thought about it. I just had an idea one day, and I read the literature for about 3 months. And of course, we postulated that the cardiorenal benefits are because of the shift in the heart and the kidney away from fat and glucose towards ketones, which are more energy efficient in the setting of diabetes. And the fuel is ketones. It's about 30% more efficient than glucose and far more efficient than fat. And that improves the efficiency of the heart and the kidney. And I have to point out, we were the first to say myocardial and renal. This was in 2016, before all these studies came out. At that time, somebody asked me, do you think it'll work in the kidney failure? I said, yes. I said, do you think it'll work in non-diabetes? I said, yes, I think so, based on my hypothesis. And they said, well, time has shown. HFpEF, they said, do you think HFpEF? I said, yes. And now, of course, the studies are. Within 1 week, this is Cell Metabolism, which is probably the best journal you can get a paper into. These two people from Canada, they're good friends of mine, Gary Lopez-Chuk and Subodh Verma, said, not so soon. Within 1 week in 2016. And they said, it has been suggested that this increase in beta-hydroxybutyrate offers significant cardioprotection. And he cited Ferranini, because Ferranini said the heart, and he also cited our paper, Medallia, and there. But over the years, there is growing evidence that beta-hydroxybutyrate is actually a signaling molecule. And based on this, just end of last year, we updated the hypothesis, and now we said a novel hypothesis linking low-grade ketonemia to cardiorenal benefits with the SGLT2 inhibitors. So we went beyond the fuel energetic. And this was the figure which we gave. SGLT2 inhibitors, as we know, blocks the transporters. Glucose is going out. Glucose is an essential nutrient. The body cannot afford to lose glucose, especially in the fasting state. It depends on the glucose to feed the brain. What's the brain going to do? What's the body going to do? It switches into this mode of accelerated starvation. And what happens is there's more lipolysis, there is more ketogenesis, and it is mild. I'm not talking about DKA with your beta-hydroxybutyrate and ketones 3 to 4 millimolar. I'm talking about double baseline levels. I told you it goes from 0.1 to 0.2 or 0.3, both in people with and without diabetes. That, of course, is a better fuel, improves work efficiency of the heart and the kidney. And then there are all these effects, anti-inflammatory effects, antioxidant stress, histone de-escalation. This causes epigenetic changes over there. Hypoxia, with erythropoietin, mitochondrial effects to mTOR, improve antifibrotic effect, improve mitochondrial function to PGC1 alpha, anti-sympathetic effect, a whole bunch of effects, which of course helps with less myocardial brain damage, less heart failure and kidney failure. Of course, I'm not saying there aren't. There are ketone independent. You have all the blood pressure, hemodynamic, vascular, NHE3, all of those effects with the SGLT2 inhibitors. And just in 2020, Gary Lopez-Chuk and Subodh Verma, they published on the pleiotropic effects of SGLT2 inhibitors and how it helps the heart, the kidney, the vasculature. Guess what? 6 years later, they said, first, improved energy metabolism. And of course, I've met Gary Lopez-Chuk and he's told me, Sundar, I think I'm a convert to your hypothesis. Of course, for the kidney, they put it way down, but they agreed that, hey, there is the improved metabolism, which decreases heart failure and kidney failure. How can we take advantage, if ketones are really good, can be given. And I'm talking about therapeutic ketosis, ketone levels of 0.5 to 0.2 millimolar. And this is a great figure which we had. We can give a ketogenic diet. I'll go into details. We can get MCT oil, medium chain triglyceride oil, and I'll go into some details on that. Beta hydroxybutyrate, we can give it as a salt, either orally or IV. Great effects. We can give it as an ester to drink. Well, what happens? If you do a ketogenic diet, the advantage is, body weight goes down. You get some maybe glycemic benefits, very difficult to follow. You may deplete your body glycogen. If you eat too much of bacon, eggs, and protein, there's dyslipidemia. Cost is low. And of course, you get ketones the whole day. But you have to go to at least less than 50 grams of carbs. You have to eat a high-fat, high-protein diet. Let me remind you, it has been used since the 1920s to treat pediatric epilepsy. What about MCT oil, medium chain triglyceride oil? Now, people in India, as you know, they take ketone, coconut oil is there. In the US, you get bullet coffee, bullet tea. They put a blob of coconut oil in it. But coconut oil has got many. So 0 to 6 are called medium, short chain, 6 to 12 is medium chain, 14 and above is long chain. But coconut oil has got all this. This caprylic acid is the main source of this benefits of it. Most of the coconut oil is C12, which is lauric acid. But there's benefits for weight loss, diabetes, epilepsy, Alzheimer's as well. Studies are going on. Beta hydroxybutyrate, as I said, many studies have shown it's good, but advantages, you can give it orally, but disadvantage is a lot of sodium low, its cost is low, and the duration is short. But there's one study which showed if you give IV beta hydroxybutyrate, one infusion, it improves cardiac output by 20%. Ketone esters can be given, it's a drink. Disadvantage, slight risk of acidosis, a little bitter, but I have had a drink of it, really not so much. It's quite high. The cost is high because the patent is held by the University of Oxford and it's expensive. It gives you ketones for about 3 hours a day, multiple benefits. All the athletes use it. It's used in Tour de France cyclists because the World Doping Agency doesn't allow you. In the 2016 Olympics, suddenly the British swimming team was doing so well. They won 6 medals. And after that, they disclosed because the University of Oxford gave them that drink to drink. You cannot take erythropoietin, you cannot take testosterone, but you can take ketone drink. And of course, there's beneficial effects in heart health. But all this is exogenous ketosis. But how do we get endogenous ketosis? With the diet, and of course, we can give SGLT2 inhibitors. And with SGLT2 inhibitors, whether you have diabetes or not, your ketones are doubled. And I'm saying that that gives you benefits. There are many human studies. I don't have time to go into it. But we know from all the large DAPA heart failure, all these studies, that there are significant benefits. And of course, there's only drug class approved to reduce CV death, heart failure hospitalization, and renal transplant. Does oral ketone administration have any benefits? What data do we have? Well, this was a study done, published in February last year. They gave myocardial oral ketones and they looked at metabolism in the heart. Bottom line, it works. It improves myocardial function and in patients with HFrEF. What about healthy people? So these athletes are taking it. What is it doing to their heart? And this was a great study which was published end of last year actually. They gave them ketone drink and then what did they do? They did echoes on them. What did they find? Yes, there are multiple benefit effects on myocardial function and other hemodynamic parameters in healthy adults, similar to that seen in heart failure patients. Ketones also work in other chronic diseases. As I told you, it's been used to treat pediatric epilepsy for more than 100 years. This is an article from JAMA from May 1927, 96 years ago. And they said, it has been used since 1921. And they noted then, and they said, one of the peculiarities they found, this is in 1921, they said, acetoacetic acid and beta-hydroxybutyrate is accumulating. Maybe it may be due to that. And they also said similar ketosis occurs when oxidation of sugar can't be there and is provoked in non-diabetic subjects by when you restrict carbohydrate and protein. So they noted that over there. And I won't go into the details, but there's nice reviews. Ketogenic diets work in epilepsy, metabolic disorders, cancer, neuronal loss, muscle, nerve degeneration. And the holy grail, of course, is can we use it to slow down aging? And what does the data show? Well, we have all these age-related diseases, cancer, brain disorders, cardiovascular disease. But if you can get beta-hydroxybutyrate, remember, we come into this world ketotic. Can we improve all of it? Metabolic homeostasis. Well, we have to do the studies, and guess who's doing the study? So this study, looking at ketone ester effects on markers of brain metabolism, cognitive function in cognitively intact adults more than 55, randomized double. Guess who's doing it? The National Institute of Aging, the National Institute of Health. So this is very interesting. We are getting multiple studies and other things as well. Let me just finish with what about ketones and diabetes? I'm not talking about DKA there. I don't have time to go into the physiology of that. What was the original treatment for diabetes before we got insulin and agents? This is Elliot Johns Jocelyn, August 1916, before insulin. What did he say? When I'm asked to see a new case of diabetes, I tell the physician, don't change the diet or just omit all the fat until he sees it. Then he says, I omit all the fat in the diet. After 2 days, the protein is gone. Then the carbohydrate is reduced and the patient is on 10 grams of carbs. That is a keto diet. Of course, 6 years later, we got insulin. That's one of the original vials of insulin from 1923. And then 90 years later, we got SGLT2 inhibitors. We literally turned symptoms into therapy. And of course, Subodh Verma, again over there, he said the pump, the pipe, the filter, do SGLT2 inhibitors cover it all? He called our heart a pump. I think the kidney is also a pump. Of course, the pipe is the atherosclerotic disease. The kidney is a pump and a filter. And of course, we have seen all the effects on heart failure, kidney failure, patients with and without their diabetes. I think these cardiorenal benefits, at least partly, are due to changes in fuel energetics through ketones. And we're doing the studies to see if ketones alone, without the SGLT2 inhibitors, can do it. And there's very provocative data. And I submit that ketones also have pleiotropic benefits in other kidney chronic diseases. Will exogenous ketosis have similar benefits? Well, time will tell. So I think I've shown you, I hope, ketones are not just a fuel source. They are signaling molecules. There are several ways to achieve therapeutic ketosis, endogenous and exogenous. And studies are going on which will really clarify the potential benefits of ketones in healthy people and those with heart failure and other chronic ailments. Let me finish with Sir C.V. Raman. As you know, he was the first non-white to get the Nobel Prize in Science in 1933. And before him, 1913, Rabindranath Tagore was the first non-white to get a Nobel Prize in Literature. He said, ask the right questions and nature will open the door to her secret. We have to learn from nature. So with that, I thank you all so much for your kind attention. Dhanyavad.
Thank you, Dr. Mudaliar. I think that was a wonderful summary and the journey for the ketone fuel hypothesis, be it exogenous or endogenous. Thank you so much for that. Let me pass it on to the co-chairs for any questions. Do we have Dr. Mudaliar here?
I do. I'm here.
Right. Okay. So let me, if there are any questions from the audience, please come ahead. In the meanwhile, let me start by asking the ketone fuel hypothesis with the SGLT2 inhibitors, Dr. Mudaliar, the change of fuel hypothesis to ketones. Are there any studies which show that the fuel change to ketone usage persists after a period of time. So we know there is evidence that there is a change in fuel hypothesis, but do we have data that this is what is happening after months of usage as well?
That's a very good question. The data we have so far, let me divide it into two parts. Serum ketone levels are elevated twice normal for up to 1 year. That study has been done, fasting ketones in people on SGLT2 inhibitors. Number two, the studies, nobody measures ketones in a methodical basis, but when you give ketones per se and you get it into the physiologic range which the SGLT2 inhibitors cause, 0.4, 0.5, the studies have been done short term and up to 3 months. Because it's very difficult to do the fuel thing, because you have to do isotopes, you have to look at the isotopes, you have to look at myocardial metabolism, kidney metabolism. But the studies are going on. They're difficult to do.
There is another important issue from your lecture. See, ketones, as we have learned through our medical science, medical schools, is a survival fuel. When somebody is fasting, when food is not available, body has to survive. And then ketones comes into the picture for survival. Even when we come to the earth from the womb, because immediately glucose is not available, that's how ketones comes into picture. Now we
if you could speak a little loudly, please.
Yeah.
Your voice is
So
low.
ketone is basically a survival fuel.
Yes,
It is not
absolutely.
a primary fuel for the body. Even when we come to the word from the womb, since immediately glucose is not available, ketones comes into picture. This knowledge is given to all of us from medical schools. Now we are living in an environment of obesogenic environment where we have plenty of food to eat. And now we are talking of to give exogenous ketones in an environment where already other fuels are available. So there inside the body, there is going to be a competition. Which fuel is to be chosen? The body is primed to choose glucose as a fuel if two things are available. So it looks interesting, but I do not know how it is going to be practically possible in the real world. Number two, it is physiological ketone production, and the gray line from physiological we become pathological ketonemia, which is dangerous to the body. We do not still have those clearly defined norms. Once we start using exogenous ketones, how to measure that we are not producing pathological ketonemia? So the hypothesis definitely looks interesting, which you have generated during SGLT2 inhibitor, but then it's controlled ketonemia inside our body. The exogenous ketone which we are giving are not controlled administration. So it looks interesting, but I have my own questions and confusions.
Very legitimate questions, and I had the same doubts which you had. So let me take your first question. Is there competition for fuel? Those studies have been done, and Gary Lopeshik did the study. When ketones are available, at least for the heart, it suppresses fat and glucose oxidation. There is data for that, even mostly in animal studies. So we know that's a very good question that you asked, because as we know, there's lots of
voice is lost.
The mitochondria. Sorry,
your voice has lost in between.
The mitochondria, all it wants is acetyl-CoA. It doesn't care where it comes from. Does it come from glucose? Does it come from fat? Does it come from protein? Does it come from this? That's the first thing. But if there is, I wish I could show you more of the physiology slide which is there. I have it. I know we are running very late on time. The problem is what you're talking about, pathological ketoacidosis. Now let's be very, there is the ketone body and there is the keto acid. The liver, the hepatocyte makes the protonated form. It makes beta-hydroxybutyric acid, acetoacetic acid. As soon as it leaves the cell, it dissociates into acetoacetate and H-ion, beta-hydroxybutyrate H-ion. That H-ion has to be buffered. If the production is very slow, like you're starving over days and months, the production of that H, it's buffered by bicarbonate, and you regenerate your bicarbonate in the kidney. So you will go initially 24 hours Overnight fasting, you reach 0.4, 0.5. I've done the studies on myself. 24 hours, you'll come to 2 millimolar. And if you do for 5 to 6 weeks, you go to 5 to 6 millimolar. These people do not become acidotic because the production is equal. The salt is there, but the acid is being cleared. In patients with DKA, there is a flood of glucose which cannot be used. There is a flood of free fatty acids because insulin doesn't suppress lipolysis. Now, all the free fatty acids are sitting over there. They have nowhere to go. They go into ketone body. Why? Because in the Krebs cycle, you need oxaloacetate to mingle with acetyl-CoA and form citrate. Now, if glucose is not there, if there is, as in DKA or anything you're starving, oxaloacetate goes out and becomes phosphoenol pyruvate and goes into the gluconeogenic pathway. The Krebs cycle cannot continue. That is why the mitochondria is seeing so much of acetyl-CoA coming in, acetyl-CoA, aceto-acetyl-CoA, and pumps it out as this thing over there. But you ask very, very, very good questions regarding when we give the ketone ester, the salt, there is not much acid, and we raise it. People have raised it up to 3 millimolar, and it is cleared. Of course, there's some proportion which is cleared by the kidney, but I am proposing around 0.5 to 1. You make very good questions. Endogenous ketosis, acid is not the problem unless you go into very severe starvation ketosis.
No, I agree with you that we have a buffer system, and that buffer system actually protects against acidosis. But as patient develop ketoacidosis, as patient develops CKD, the renal mass goes down, the buffering capacity goes down, and the person become more prone to go into these processes. In fact, as EGFR comes down to less than 30 ml, there is already buffering capacity which has reached to the maximum. Patient is already having acidosis. So in these scenarios, giving an exogenous ketones is not going to be buffered. Body does not have a capacity. Does not have a capacity. So probably in those scenarios, whether giving exogenous ketones is really going to be beneficial. So I do not think we have any data for such things.
You ask a very good question. I am not at all proposing that you give it to CKD patients. I'm saying healthy people before they get the kidney disease and all that. The other point is SGLT2 inhibitors work in CKD with EGFRs up to 20-25. As you rightly pointed out, as your EGFR goes down, the glucose excretion is not there. You're not getting 100 grams of glucose in the urine. You're not getting 0.4, 0.5 of the thing. Your glucose, even if your EGFR is 30 and your blood sugar is around 100, you are spilling about 10 to 20 grams. So you're not getting. What I am proposing is there is a doubling of your baseline. So in a patient with CKD, it may go from 0.1 to 0.15 or 0.2. And at that level, acidosis is not really an issue. Of course, we monitor these patients. But I'd love to have a conversation with you offline.
So when you come next time to India, when we will invite you, we will have in person.
I'm ready to come. I'm vaccinated. I had 2 boosters.
But definitely, this is an evolving and a wonderful, interesting concept where we can use change in energetics for beneficial use of the body. And if I can have few comments from please, sir.
Can you hear me, sir?
I'm not hearing you.
I'm Vijay speaking. Can you hear me?
Yes, I know you.
Yeah, thank you very much.
I have full respect, very high regard for you and your
thank you.
academic.
Thank you very much. I'm talking about these esters. These esters contain salt obtained from alcohol. 1,3-butanediol is a substance which is included when you make the ester. And we all know that when you give alcohol to anybody, the NADPH from the liver is used up. Do you think these are the safe molecules to be given to the patient to treat as the exogenous ketones?
Okay, you asked a very good question, and you're the only one I think who knows that 1,3-butanediol, which is cleaved in the gut to beta-hydroxybutyrate. Thank you for the question. I'm not saying give it to alcoholics and things like that. So these are all things over there. But I have shifted my focus. The ester is very expensive. It costs $30 a day. I paid money and I did the study on myself. Yes, it takes my ketones, overnight fasting, ketones to about 2 millimolar. But I can't afford it. Nobody can afford it. So I'm pursuing another track. And that track is caprylic acid, which is C8. And that is far cheaper than that. And let me remind, this I did not know till I read it. Medium chain triglycerides, they get a free pass to the liver. They don't go through the thoracic duct, but they also have multiple other properties. So once they go to the liver, in the cytoplasm, they can easily be converted to triglycerides. No, fatty acyl-CoA synthase, which is sitting there, cannot, if the chain length is less than 10, it can't attach to it. It doesn't. It's only little. It goes for the C16, C18 over there. So if it can't get metabolized in the cytoplasm, it goes straight to the mitochondria, gets beta oxidized, and insulin cannot suppress this process. Insulin suppresses all other ketogenesis, but this process, NCT, studies have been done. There are studies from the 1970s, because insulin acts through substrate, and doesn't matter, you've already given the substrate. Number two, insulin can promote lipogenesis. Doesn't matter, that enzyme doesn't have any much affinity for MCT, C8. So I'm going that route. That is what I'm trying to get money. Maybe you guys can do it in India. I'd love to cooperate with you. Coconut, people take coconut oil. It's not so easy. You have to get the C8 caprylic acid out. I have looked into coconut. I can give you the full biochemistry of coconut oil.
So thank you, Dr. Mudliar. At the fag end of the day, when good number of us are actually having hypoglycemia, ketogenesis already has started. So we have a wonderful discussion, inciting discussion. Hope to see you in future in India. Thank you very much. Over to you, Sunil.
Certainly next year, you will have to be here with the team of Fellow Diabetes Academia. Yeah, that's okay, but he has to be here in Nagpur because he has a very good, strong connect with Nagpur, and he had been in 2018 with us here. So sir, next time we will certainly have this meeting. But wonderful interacting with you. We are all really happy and enriched with the knowledge with what you give and deliver, and wonderful discussion. Thank you very much, Chairperson. A special thanks to Dr. Rajesh Rajput and of course Manoj and Dr. Sundar Mudliar, and thank you, Nirmal, for being with us. Sir will be again getting connected. Sir is also the international advisor for Hello Diabetes Academia. Sir, we had your 2 minutes video morning. We displayed it for during the inauguration period, and everyone really appreciated your efforts to support Hello Diabetes Academia since so many years. Thank you very much once again. We will be again remaining in touch with you. We just now will have Sholay of Hello Diabetes Academia, which has been just depicting all the molecules, glucose lowering therapy in the characters of Sholay, starting Gabbar as diabetes and other things, all other drugs. So thank you very much once again for joining me.
As Gabbar Singh would have said, "Ab tera kya hoga Kalia."
Yeah. Yeah. Thank you, sir. Thank you.
I request SDA, the organizing chairperson, to felicitate our chairperson, Nirmal Jaiswal sir. Thank you, Nirmal Jaiswal sir, Rajesh Purohit sir, and Manoj Chawla sir for chairing this session. So we end with this session here, and please join that Hippocrates terminal for the Sholay debate.